have your WhatsApp number.
I
Can you just send?
I have just shared the message with you, sir.
All right. Okay.
रवि, डॉक्टर वैद सर का मेरे पास है जो मैंने अभी ट्रायल किया था ना उसका.
हाँ, अगर
In
कोई
case
issue
he's
होता है तो
unable
we
to do
can
it.
start from there, sir. No issue.
तो आगे सर मैंने आपका ट्रायल कर लिया है.
ठीक है.
तो in case you are unable to.
All right.
Sir.
Dr. Monu Singh, good evening.
Raju sir.
Yes.
Actually your आपका जो Zoom window है वो open नहीं है.
हाँ.
हाँ ये.
Dr. Monu Singh, good evening.
Sir, on the lower panel Chrome कहाँ जहाँ icon है उसके बराबर में Zoom का icon है.
Dr. Arya, good evening.
हाँ, Zoom है.
Good evening, sir. Dr. Arya, good evening,
On
sir.
the lower panel.
Good evening, sir. Good evening, all.
There is a Zoom icon.
Good evening, sir.
Good evening, sir. Manish sir, we are live now.
Okay, please, everyone, we are live. Okay.
Please be mute.
Okay.
Ravi, please start recording.
Yeah, okay.
Good evening from Arthro TV. Today we have Delhi Orthopedic Association's Arthroscopy Course. Now I request Manish sir to start the program. Manish sir, please.
Okay. Good evening, everyone. And I welcome you all for this webinar. Ravi, can you see?
Yeah, it's coming, sir. Go ahead.
So this is a very special webinar. It's a Delhi Orthopedic Association webinar for arthroscopy course. So it has two parts. One is the shoulder and another one is the knee. So this is our shoulder session, and I will just take you across the main people in DOA, and then our conveners will introduce you to the faculty. I'll also introduce the panelists. So I am Dr. Manish Dhawan. I am webinar moderator, and I am treasurer of Indian Orthopedic Association from 2014 to 2020 August. I am also president of Asami India, and I work in Gangaram Hospital. And my special interests are complex trauma, limb lengthening, and deformity correction. Now, Dr. Sharad Agarwal, good evening, Dr. Sharad, and he is the president of Delhi Orthopedic Association. He is senior consultant orthopedics at Max Super Speciality Hospital, and his main focus is joint replacement and trauma. He is past president of East Delhi Orthopedic Association. He has presented numerous academic papers at various national and international conferences and delivered guest lectures at various national and international conferences. I welcome you, sir. Dr. Hitesh Lar is the webinar convener, and he is expert panelist for today's shoulder session along with Dr. Arya. He is secretary of Delhi Orthopedic Association. He is webinar convener, and he is professor at Sports Injury Center, Safdarjung Hospital. Previously, he was also professor at RML Hospital and Central Institute of Orthopedics, Safdarjung Hospital. He has more than 100 national and international publications to his credit and delivered guest lectures at various national and international platforms. I welcome Dr. Hitesh. Professor Lalit Mani is president-elect of Delhi Orthopedic Association. He is editor of Indian Journal of Orthopedics, and he is director professor at Maulana Azad Medical College, New Delhi. And he is the editor of Journal of Clinical Orthopedics and Trauma, in addition to IJO. He has authored several book chapters, has numerous international and national publications, and chaired many sessions at various state and national conferences. And I welcome you, sir. Dr. Deepak Joshi is moderator for shoulder session, and he is professor of orthopedics and sports medicine at Sports Injury Center, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. I welcome you, Dr. Deepak. Dr. Sameer Mehta is moderator for knee session. He is senior orthopedic surgeon specializing in arthroscopy of knee and shoulder and joint reconstruction. He got basic training in orthopedics in Delhi, and he did advanced training in UK. And he is working as a head of department at Deep Chand Bandhu Hospital, Government of Delhi, and he is also executive member of DOA. I welcome you, Dr. Sameer. So we have two parts, two convener. So now let me move forward. Dr. Ravi Chauhan is our webinar co-coordinator, and the concept and designing of this webinar along with technical assistance is done by him. He works as a trauma and pediatric orthopedic surgeon at Sir Gangaram Hospital, New Delhi, and he's also EC member of Asami India. So he is the backbone of this webinar. I welcome you, Dr. Ravi. Dr. Ashok Sham is editor of Ortho TV. He is assistant professor at Sancheti Institute of Orthopedics and Rehabilitation, Pune. He is chief researcher and head of IORG and editor of Journal of Clinical Research. and Basic Research Committee member. He is the Basic Research Committee of Indian Orthopedic Association and EC member of Maharashtra Orthopedic Association, IOA, etc. Dr. Neeraj Bijlani is co-coordinator of Ortho TV. He is consultant orthopedic surgeon and tech enthusiast at Ortho Tech Clinic, Mumbai. Dr. Shamsul Huda, I welcome you. He is the coordinator of Ortho TV, consultant orthopedic surgeon at Rajeshwar Hospital, Patna. He is joint secretary of Bihar Orthopedic Association, Assami, and editor of Ortho Worlds. Now, the expert panel today we have Dr. R.K. Arya. He is Director Sports Injury Center at Vardhman Mahavir Medical College and Safdarjung Hospital, New Delhi. Welcome, Dr. Arya. Dr. Hitesh Lal is another panelist in addition, and Dr. Monu Singh is Chief of Services of Joint Replacement Arthroscopy and Sports Medicine at Narayana Hospital, Gurgaon, Gurugram, and Dharamshila Narayana Super Speciality Hospital, New Delhi. He is past Vice President of Delhi Orthopedic Association. I welcome you, Dr. Monu Singh. Dr. R.C. Minocha is Senior Orthopedic Surgeon and HOD of Orthopedics at Central Railway Hospital, New Delhi. He specializes in joint replacement, arthroscopy, and complex trauma. I welcome you, Minocha, sir. So thank you. With this note, I request now our President, Dr. Sharad Agarwal, to address the meeting. Dr. Sharad, please.
Thank you, Dr. Manish. Good evening, friends. I welcome you all to the Arthroscopy course of Delhi Orthopedic Association. Again, it is usually a 2 days flagship course of Delhi Orthopedic Association, but however, due to pandemic constraints this year, we had to curtail it to a few hours of webinar. We have an eminent national and international faculty led by Professor R.K. Arya, Director Sports Injury Center and Department of Orthopedics, Safdarjung Hospital, as chairperson of the course to delve on the subject. On behalf of Delhi Orthopedic Association, I welcome Professor Arya and all the speakers and panelists who are sparing their valuable time today for the webinar. The webinar is programmed in 2 sessions. The first shall touch upon the shoulder region and second shall discuss the knee. The program is exhaustive. We shall tackle the salient aspect topics in both the regions. I am sure it shall give an insight of this fascinating field to all our younger colleagues who intend to pursue their career as an arthroscopic surgeon, besides being an update for all of us. My welcome to whole DOA faculty and all delegates who shall be participating in today's webinar. My thanks to Professor Hitesh Lal, Secretary DOA, and Dr. Sameer Mehta, Executive Member of DOA, who painstakingly compiled the program. My thanks to Dr. Manish Dhawan, Treasurer IOA and President ASME India, who is moderating this webinar. Special thanks to Dr. Ravi Chauhan for his untiring efforts in the organization. Thanks to Dr. Shamsul Huda, Dr. Neeraj Bijlani, and Dr. Ashok Sham for all the technical supports. And thanks to the sponsors of this program, Sun Pharma, for their unrestricted education program. Thank you.
Thank you, Dr. Sharad. Now I request Dr. Deepak Joshi, the moderator of shoulder session, to please introduce the faculty. Dr. Deepak, please.
Thank you, Dr. Manish, and I welcome all the delegates. And so the shoulder session, we have 7 lectures. So we have tried to touch the basic as well as the advanced part on the shoulder. So the faculty here to start with, we'll start on the labral repair by Dr. Himanshu Gupta. So Dr. Himanshu Gupta is working as an associate professor at Sports Injury Center, Safdarjung Hospital. He is with us for about 6-7 years now and has been very active in knee and shoulder surgeries, arthroscopic surgeries. Then next, after Himanshu Gupta, we have Dr. Vineet Jain. Vineet is with us for about roughly around almost 9 years, I think 10 years now, after the inception of the Sports Injury Center. He is a professor of orthopedic surgery and sports medicine. So he'll be speaking on the Remplissage technique. After that, we have, after Vineet, we'll have Dr. Skan Sinha. Dr. Skan Sinha has recently joined us and he's with us for about 3 years now at Sports Injury Center. So he'll be speaking on the failures of the Bankart repair. So he's also a professor of orthopedic surgery. And after that, we'll have Dr. Himanshu Kataria. He'll be speaking on double row rotator cuff. He's again he's a unit head with in the Sports Injury Center, and he's working with us for about, I think, 6-7 years now. And he's really, we take guidance from him in performing our arthroscopic procedures here. So after Himanshu Kataria, I think I'll be speaking on Latarjet. I am a professor of orthopedic surgeries, as has been introduced by Dr. Manish. And after that, we have 2 guest faculties, one from Mumbai, Dr. Dinsha Padiwala. We know him very well. He is in Kokila Ben Dhirubhai Ambani Hospital. He is a senior consultant. He is looking after so many star players and very high level athletes. And he needs no introduction. It has been always love to watch him, how he performs his arthroscopic surgeries, and his lectures are always very, very informing. So we have taken him for a very difficult talk on superior capsular reconstruction of the shoulder. And after that, we'll have a guest faculty from South Africa. I am welcoming him, Dr. Sham Osman. He has agreed to take part in our program on a very, very short notice, and he will be talking on the difficult lesions of the long head of the biceps. It has always been a dilemma when we treat the long head of biceps. So Dr. Sham Osman is from South Africa, Durban. He's in practice for about 25 years, and he has a keen interest in shoulder and knee. Besides knee, that he is also working in the field of elbow and the wrist, and he's also currently the president of the ASN Shoulder Institute in South Africa. I welcome all the faculty. I think the time for each faculty is about 12 minutes, and we can have 3 minutes of discussion, and we can give maybe 1 or 2 minutes more for our guest faculties. And I think without wasting time, so we can start with the first lecture on the topic by
Dr. Samir. I will interrupt. Dr. Samir, when we will start knee session, you can introduce faculty that time. Is it okay, Dr. Samir?
Sir. Absolutely.
Okay. Please, Dr. Deepak, please start the proceedings.
Thank you very much, Dr. Manish. I think Himanshu, will start with the talk on labral repair. He can share his screen.
Yes, thank you, Dr. Deepak Joshi. I'll just share my screen. I hope everybody can see the screen.
Yeah, please. Yeah.
Yes, so I'm Dr. Himanshu Gupta. I've already been introduced. I'm Associate Professor in Sports Injury Center. And I'll be presenting on the arthroscopic Bankart repair with all suture anchors. And there'll be a surgical video with a small presentation. It's about 5 minutes presentation and a 6 minute surgical video. So I'll stick to time. So all suture anchors are basically the first generation. All suture anchors are sutures with a slip, and the mechanism is the anchor is deployed inside a pre-riddled hold under tension, and it results in a radial expansion of the suture slip or suture ball, creating an interference fit. So they require small diameter bone. The defect is bone defect compared to solid anchors, so they are bone preserving, and you can put more number of anchors if needed. And it is also advantageous in revision surgery. So because if the previous surgery had been an all suture one, the hole sizes would be small, and even in the current surgery you only need small hole sizes. So it's quite advantageous in that scenario. And another big advantage is since all through the material, the suture material is soft, so you can use curved drill guides for introducing this or these all suture anchors, and that permits easier approach to 6 o'clock positions. Not only is the size small, but the approach to 6 o'clock, the difficult positions is easier because of the availability of curved drill bits. So they have less arthritic potential, smaller in size, minimal disruption of articulating cartilage. They're soft in form. In case of pull out, so there is less damage, and it eliminates the possibility of rigid material loose bodies in the joint. There is no issue of fatigue fracture with them, no eyelet issues like suture wear at eyelet or eyelet breakage, and there are no shadows in post-op MRI like titanium anchors. So these are for the first generation suture anchors, they obtain deployment via a simple insertion device. The anchor is inserted in tunnel, the sutures are pulled back, and it results in bunching of the sheath or formation of a suture ball under the cortex under tension. And examples include the Iconics from Stryker, and there are many such available in the market. The second generation uses insertion devices with deployment mechanisms that do not require manual tensioning. So they reduce the incidence of partial deployments due to under tensioning or accidental anchor pullout due to over tensioning. But otherwise, they are similar to the first generation anchors. And what we have been using are the first generation anchors only. And so our patient, that the video that I've been presenting will be presenting, is Mr. RK, 24-year-old male, not in professional sports. He's just joined some sales job, and he's had recurrent dislocation of the right shoulder. First episode in 2018, total 3 episodes. He has no generalized laxity. Sulcus sign is negative. on 3D CT, the bone loss is 11.6% in the glenoid. So glenoid track width has been calculated to be 17.5 millimeters, and the Hill Sachs interval is 14.2. So it's an on-track lesion, and these are his functional scores. So what we generally follow in our team roughly we follow the guidelines of Ito et al. So if less than 25% bone loss with an on-track lesion, it's an arthroscopic Bankart repair. More than 25% bone loss, whether it's an on-track or an off-track, it gets an Latarjet done. And less than 25% bone loss, off-track lesion, generally it's an arthroscopic Bankart Remplissage, but the word I've used the word generally because we also take into consideration the 4 components of 4 out of 6 components of the instability severity index score. That is age less than 20 years, competitive sports, contact sports, and shoulder hyperlaxity. And based on that, we somehow tailor the surgery for each patient in these groups. So for this particular patient, there is no doubt the patient needs an arthroscopic Bankart repair, and the portals that we use are the routine portals, the posterior, the anterior, and the anterior superior. So this is the video of the Bankart repair. The viewing portal is the posterior portal. And first we will create our the anterocentral portal. That's the torn labrum that you can appreciate over there. And while creating the portal, we have to make sure that the needle, with the needle, we can approach the 5 o'clock, 6 o'clock position. The rod is inserted and the cannula is railroaded over it. And there's plenty of space over here to create another anterosuperior portal. The knife should be parallel to the superior glenohumeral ligament, so you don't cut it. And that's the Hill Sachs defect. So I hope everybody can appreciate. I'm sorry. Yeah, so that's the Hill Sachs defect. All the way till here is, above it is the bare area, and below it is the Hill Sachs defect. You can see the pulsating vessels in the bare area. So the Hill Sachs defect was about 8 millimeters. Total Hill Sachs interval as measured on the CT was 14 millimeters. And you lift the labrum. This is the most important part. You can have some amount of bleeding here. So during these stages, we generally increase the pressure from 35 millimeters to 45 millimeters, sometimes even 50. But otherwise, routinely, we keep it as at 30 or 35. The important point is to note here is that we have to lift the labrum all the way till 5:30 or 6 o'clock, or sometimes even beyond it. And then only you can lift it and shift the capsulolateral structure proximally. So this is the 6 o'clock position. We have lifted the labrum all the way till 6 o'clock and freshen the surface. And I generally make a mark on where I have to put the 3 anchors so that later on there's no confusion. And you don't leave the cartilage looking beautiful. You have to remove its beauty. You have to freshen it at the margins so that you have a healing between the margins of the bone and the labrum that you are going to attach to it. So you're using a curate. I'm using a curate there to freshen it, and you get a bleeding surface over there. So this is the first anchor that I'm going to place, and I hope you can appreciate. Sorry. Yeah, so I hope you can appreciate that it's quite distal. So it's almost like 5:30 o'clock position, and the advantage of these all switcher anchors is because of the small size of the drills and everything, and with the curved drill, you can easily approach the 5 o'clock or 6 o'clock position. So the hole has been drilled, the anchor has been inserted, and then you pull on the anchors. It creates a bunching of the suture material or the slip, and that gives a snug fit there. And then even distal to where I have inserted the anchor, I've started to take the bite. This is the first bite that I have taken. And sometimes I use only simple suture all the way, but sometimes you can use a matter suture. In this particular case, I have used a matter suture in the distal most part. So this is the first bite that I have taken. The advantage of taking matter suture is that even if the first bite is not very good enough, you can make sure that your second bite is better than that. And then I'll use this suture as a pulling suture, and I'll pull the capsulolabial complex proximally so that I can easily take another bite distal to that. And that's the second bite. I'm pulling the nitinol wire and railroading the suture with the nitinol wire. And that's the knot over it. You can use any knot that you prefer. I'm using the Duncan's knot here. Some pass pointing with each throw. That's it. So with the help of the curved drill, you also ensure that there is very less risk of injury to the axillary nerve, because the drill, because of its curvature, goes more superiorly rather than going distally. So that's the second anchor. Again, drilled with a 12-degree drill sleeve. This anchor has been inserted. The sutures are being pulled, so that causes bunching up of the anchor material. The bite has been taken. The nitinol wire has been passed, and the suture is railroaded, shuttled with the help of this. And this is a simple knot in this second anchor. There's a bit of a small cartilage flap over there that I assure you I'll remove in the end. And that's the third anchor. I hope you can appreciate the superior border of the subscapularis, and it's almost at the level of the superior border. And I'm taking the synovium as well as the middle glenohumeral ligament with it, because the labrum is not very good in this region, but that's not a requirement. And while taking the bite as well as while throwing the knots, I'm pulling the labrum proximally so that you have a shift proximally. You don't have a bunching of the labrum between the anchors. So that's the knot. Half knots are thrown with pass pointing. And I'm still holding on the labrum with the suture retriever on the other side. And once the knots have been put, I can release that. So that completes our labral repair. That small cartilaginous strap I've removed is just some cleaning up. And I hope you can appreciate the head is now centered. Earlier it was not centered; it was moving anteriorly. So it's a centered, well-centered head. And now if you try to look at the Hill-Sachs lesion, you're unable to do that because now it's all, the capsular space has now decreased. So biomechanical results of all suture anchors, both first and second generation, have been found to have similar or better strength when compared to solid anchors, whether it's metal, bioabsorbable, biocomposite, or PEEK anchors in various studies. And even in first generation and second generation anchors, no significant difference in load to failure values has been reported. And the most common failure mode for these suture anchors in the biomechanical studies is suture breaking. And these sutures are these are the typical sutures that we use, and we know that they are quite strong. And even in the clinical studies at 2 years follow-up, there's been no reference has been reported in functional scores, redislocation scores, and subjective instability as compared with biodegradable anchors. In fact, even in our experience, our team's experience with all suture anchors has been good. From January 2015 to May 2018, we had 61 Bankart repairs with all suture anchors that had a 2 years follow-up. And of these, 41 were without any additional remplissage or slab. And for these, the ROAS scores pre-op were increased from 40.1 pre-op to 93.3 post-op, and the mean WOSI scores decreased from 943 pre-op to 278 post-op, which is similar to the general reported literature for other types of anchors. And our redislocation rate was also 4.8, which is also similar to the literature. The reported complications include device micromotion and cystic change. There are no anchors that are not without any complications. So every anchor have their own particular types of complications. For example, in the study that they have reported the CT arthrogram at 1 year, and they've measured the tunnel diameter for the all suture anchors as well as for the biodegradable anchors. And they found that for the 1.3 millimeter all suture anchors at 1 year follow-up, the tunnel diameter was 2.5 millimeter average. But this is the diameter in the subcortical region, not the cortex. The all suture anchors get their strength and resistance by the overlying cortex, and as long as the overlying cortex is intact, even if there is some amount of tunnel diameter increase in the tunnel diameter in the subcortical region, that you shouldn't make much of a difference. And proportionately, this increase in tunnel diameter is more than in biodegradable anchors. But this 2.5 millimeter diameter is still less than the original 3 millimeter diameter of an anchor, of a biodegradable anchor. So if a biodegradable anchor 3 millimeter has a further tunnel widening, as compared to that, this 2.5 millimeter is still less. So that's how you have advantages in revision surgeries. So to summarize, labral repair with all suture anchors has an easy approachability to 6 o'clock position. It's a bone preserving thing. You can have likely easy revisions, but a bit of an issue of tunnel widening is still there. Thank you. I hope I finished within time.
Yeah, thank you very much. Yeah, you definitely finished with time, Himanshu. And it was a very nice and informative presentation on the on the all suture anchors. So to set the ball rolling on the questions. So cystic change. So that is what we see when everything is fine, that you have less, these are the very small diameter anchors. But when you see after some time, definitely when you see the x-rays, the cystic changes looks too much after maybe a year or two. Do you think that it is not a problem as vis-a-vis the biocomposite anchors? We think that these are the bone forming anchors, the biocomposite anchors.
So as far as biocomposite anchors are concerned, maybe the amount of cystic change might be more in these. But if you go look at the biodegradable anchors, and even for the biocomposite anchors, there's no anchor that doesn't have tunnel dilatation or cystic changes. In fact, there are certain studies with the bioabsorbable anchors that have reported more than 50% incidence of cystic changes if we see some certain studies. So of course, the studies reporting on cystic changes and tunnel diameter for all suture anchors are limited. But for example, the study that I have just shown, there was tunnel diameter widening, but even after tunnel diameter widening, the subcortical diameter was only 2.8 millimeters and the cortex was intact. So this this widening is still less than the actual original diameter size of the bioabsorbable anchor of 3 millimeters.
Okay.
And
so
as far as functional results are concerned, the results are same at 2 years.
So we can ask this question from our outstation faculty also. What's their take, Dinsha? How are you doing now? All suture, or you are still doing something biocomposite or peak? I think is not. Is Dr. Sham here?
Yeah, hi, I'm here.
Yeah. So how are you doing there? So you are shifted to all suture, or you think the biocomposite or the metal anchors does good?
Well, obviously, our experience has been with bioabsorbable or active anchors. I must say the advantage of using these all suture anchors is because of the small diameter, especially if you have to do circular labral tears or repairs anterior or posterior. And that's when you get a concentration of all these cystic changes within the glenoid itself, and that creates some sort of concern. So I must say I tend to use more of these all suture anchors nowadays. Especially in the lower part of the joint, I'm still trying to use an absorbable anchor with a knotless system and a suture tape. But otherwise, yes, just a drift towards suture anchors.
So that was the next question I wanted to ask Himanshu. I'll ask you. So how you think knotted versus knotless? So what do you think? What do you say that we should do knotted, or we can do knotless sometimes, or maybe we should not do knotless at all?
I think it's a personal preference. Yet studies have shown that knotted anchors, if you use a knotted anchor, that you don't always get the same amount of tension on the anchor, and there's always a bit of creep from the suture time. So knotless anchors have given us a better option of getting much more secure fixation. Although if you use a knotted anchor, I think you get a feel of how to pull the labrum up while you're doing the knots. So that's the only advantage I see.
Yeah. Thank you so much.
And may I add one more thing? I think although we don't have any personal experience, but some of the companies have come up with all suture knotless anchors also. So maybe time will tell.
That is, I think we are evolving. I think so. As the last 10 years, so many anchors have come in the market. Some have really gone down, and always we are having improvements in the all suture system. We may have some. We are getting better and better anchors, and like we are now having the biocomposite anchor. They are doing very well. I think we have any questions from the audience, or
can I have a very basic question? Professor Agarwal. I want to know, like you have made the margin of the glenoid raw and you fix the labrum on that. So we expect that to heal at that joint, at that place. Will that be a concern, the widening of the canal or of the canal or cystic changes? Will they be a concern after 1 year or so, once things have healed?
No, beyond that, I think shouldn't be a problem. It's the problem till the time there is healing. So most of the studies that are reporting on tunnel diameter widening report for 6 months or 1 year point of time. Beyond that,
expect 2-3 months.
Pardon?
Won't you expect the healing to occur in 2-3 months?
Tunnel time widening.
No. He's asking healing process will occur at 3 months. So the Bankart has healed.
Okay.
So now after that, the tunnel has dilated cystic.
So
that glenoid is weak enough so that we have again the detachment of the labrum. That is what, sir?
Yeah.
That's correct.
Yeah. So theoretically, we are hoping that everything heals perfectly well, but we know it's not entirely possible that the whole labrum all through the fixation gets healed. For example, even in other things, we other types of surgeries, we know that okay, there may be some partial healing, there may be some fibrosis, the healing may not be that strong. So it does take time for the healing to be strong enough. So I think till 1 year time, if there is tunnel dilatation, if there is cortical dilatation, it may be of concern.
Okay, thank you.
Thank you, Himanshu. I think if there are no questions, we can move to next talk. Okay, we can have questions later also from Himanshu if we have anything on the labral repair. And
okay, thank you. I'll be muting myself.
I think we'll have the next talk from Vineet. Vineet, you are ready with your presentation?
Yes, sir. Good evening, sir.
Good evening. Yeah, Vineet.
I'll be sharing my screen now.
Speaking on Remplissage. So somebody asked me a question, how is the Remplissage stands today? So I answered them like that. 5 years back, whenever we had a doubt, we never used to do a Remplissage. Now, whenever we have a doubt, we tend to do a Remplissage, and I think Vineet will shed more light on it. Over to you, Vineet.
Thank you, sir. First of all, I would like to thank all the DOA president and the secretary for inviting me here for this talk. And I will be talking about Remplissage, indications and technique. Now, engaging Hill-Sachs, we all know, has been found to be a significant risk factor for failure in arthroscopic surgeries. And of late, this has become a major point of discussion and has now been a part of the management of these instability Bankart repairs. And because of this introduction of Remplissage and our better understanding, especially after the concept of bipolar bone loss, which was given by Itoi, the management of instability, of shoulder instability, has definitely become better. So when we talk about Remplissage, what is important is that we not only depend upon the pre-operative imaging. So we need to prepare ourselves right from the beginning before we go in for surgery. Yes, we are going to do a Remplissage. We'll be talking about just a bit later. And we have to do both pre-operative imaging and dynamic intraoperative assessment. And we use both of them to predict the potential contribution of Hill-Sachs lesion to the shoulder instability. Now, if you see this figure, so this is the post-rectal head defect, which we know is known as the Hill-Sachs lesion. It's basically an impression fracture. And as the shoulder goes into external rotation, the glenoid edge, anterior edge, engages the Hill-Sachs lesion, and this makes the shoulder unstable. So even a small amount of external rotation can go and engage the Hill-Sachs and make the shoulder unstable. Now, different surgical options have been described to address the humeral head defect, and these include Remplissage, humeral osteochondral grafts, osteotomy, arthroplasty, and Latarjet. Now, the most of the traditional techniques before the Remplissage actually came into effect, they focused on open capsular shift and Latarjet, maybe as an open surgery. But in 2007, Wolf et al. Described Remplissage as a technique to address the humeral side bone loss in conjunction with Bankart repair. Now, what is actually Remplissage? Remplissage in French means to fill in. So when we talk about technically what is Remplissage, so it's arthroscopic posterior capsulodiscs and infraspinatus tenodesis. So we are doing both capsulodiscs, which is done more inferiorly, and the infraspinatus tenodesis. Now, this technique is basically done when we find that the Hill-Sachs lesion is very large and it engages the intraglenoid with little overall movement. That is something initially which Bankart described, that you do an intraoperative assessment and you rotate the shoulder intraoperatively and see whether the Hill-Sachs is engaging or not. Now, something which was challenged there on that the fact that the Hill-Sachs lesion has been formed, it's only because that the whole shoulder had dislocated and that part came in contact with the intraglenoid ring later on. Now, in this situation where the Hill-Sachs lesion engages with the little overall movement, a simple Bankart repair alone may be insufficient and we need to address the Hill-Sachs lesion. Now, how do we evaluate the bone loss? Basically, of historical importance are now the X-rays. So normally when you see AP view, you will not see Hill-Sachs lesion. You will not be able to appreciate. So this is a normal AP view of a patient. And when you do an axial view, you can see that the intraglenoid is fine and you can see a small Hill-Sachs lesion. But in the same patient, you do an apical oblique view, you can now see a large Hill-Sachs lesion and you see mild blunting of the anterior glenoid. So how do you do special views is something of importance, but nowadays it's hardly being done now. So what is being done now are the 3D NCCT done of the shoulder joints, which have made our life easier and made the understanding of these lesions easy. Now, what is now done is we just concentrate not only on the humeral head or the Hill-Sachs lesion, we need to assess the glenoid bone loss also. There's a landmark paper which was by Yamamoto and Gardens with Itoi, which gives us this concept of bipolar bone loss, and I believe that the management of instability changed subsequently. So what is done in this is that you assess three things. One is the glenoid bone loss. So that depends upon how much bone loss is there anteriorly. So it is calculated in percentage that of the expected diameter, which we take it from the opposite shoulder or a best fit circle methods. There are a few different methods how do you measure it. You see how much bone loss is there now. So you find this small d, that how much bone loss is there. The next thing you do is you find the glenoid tract. Now there's a formula which the study of EG to establish that the glenoid tract is basically the area which is covered by the humeral head on the glenoid. That is 0.83 or 83% of the expected diameter of, or the normal diameter of a normal glenoid minus the decrease in diameter, that is the small d. So this is the formula which is used. And next, what you calculate is the Hill-Sachs index. Now, Hill-Sachs index is an important thing, we should appreciate it. That Hill-Sachs index is not only the width of the Hill-Sachs. So this is the actual Hill-Sachs. So this is the width of the Hill-Sachs. It's not only the width of the Hill-Sachs. It also includes the bare area which Dr. Himanshu just showed. That is till the point of insertion of the supraspinatus on the greater tuberosity. So based on this, you now decide that what is to be done. So this is the thing. So this is the complete diameter, and you might have an anterior glenoid loss, and the glenoid might be put this here. This is the normal thing. This is how you measure. So this is what Itoi study established, that 83% of the glenoid is tracked within the humeral head. So when the glenoid tract is more than the Hill-Sachs index, this is a non-tract lesion, and you just do a simple Bankart repair. But when the glenoid tract becomes small, especially when you have an interior bone loss in the glenoid, in cases we have multiple dislocation, then the glenoid tract becomes less than the Hill-Sachs index, these are off-tract lesions, and there's something which requires Remplissage. This is the treatment paradigm which was later on described by Giovanni, Itoi, and Bankart. And they said in case of bipolar bone loss, if the glenoid defect size is less than 25%, is an on-track lesion, you need to do just an arthroscopic Bankart repair. If it's an on-track lesion, you need to do arthroscopic Bankart with Remplissage. And if it's more than 25%, the management is basically Latarjet. So technically speaking, what does Remplissage done? So Remplissage makes the heel sac defect extra articular. So once it becomes extra articular, it does not engage. So when it becomes extra articular, it does not engage with the anterior glenoid and does not add to the instability at the shoulder. So it basically decreases the heel sac index and convert an off track to an on track lesion. Now, what is important for everybody to appreciate is that you should be beware of the width of the heel sac and not its depth. So depth can be frightening, but it is not the depth, it's the width which has to be taken into account when you are managing these cases. I will just show a surgical video how we do Remplissage. So this is a case of shoulder instability. You can see the torn Bankart. So we do an intraoperative assessment also. We've done a CT scan below. This is a graduated probe in which we measure the glenoid width. You can see this is how we measure it. And we use the tip of the probe to measure the heel sac index. So here how we measure the heel sac index. So whatever findings are perioperatively, we confirm intraoperatively. So this is the lever which is lying anteriorly. You can see the anterior glenoid bone loss. You can see some cartilage changes also here. So first you place the anchors for Remplissage. This is the posterior portal through which we have come. We have put a cannula in this, and first is we prepare the bed. So the bed preparation is important. You prepare the bed till you have fine bleeding. So this helps in better healing later on. So with the curate and then with the shaver, we prepare the bed. So this is the bed which has now been prepared. And what we use are the metal anchors. Now we prefer this, we find that they have a better hold. What is important to see here is that this anchor this is the inferior-most anchor. We use 2 anchors for Remplissage repairs. This anchor is not to be placed near the insertion of the supraspinatus nor in the end. This has to be, you need to decide intraoperatively to place it. If you place it to inferior, so if you place it to inferior, this you can technically say, yes, you have made the whole heel sac extra articular. But what it does is that it severely restricts your external rotation, which sometimes can be debilitating for the patient. You need to imagine that your basic concept that you're looking at, you need to decrease the heel sac index. So you need not go inferior most, but you need to stay somewhere in between. So this is the first anchor we are placing in. We find that the metal anchors usually have a better hold, and this is what we have been using. Now, once we do this, we withdraw. You see what we have withdrawn is we have withdrawn the our sheath outside, just outside the capsule. It's something which you learn with experience. You do not take it outside. You do not want it beyond the deltoid, but you want it just outside the capsule. So it's gone in, and then we use bird beak to take the bites through the capsule. So this is the inferior bite we've taken through the capsule. We're retrieving the sutures. One limb of the sutures being retrieved here. So it goes in there inferiorly. And then this is the second. So there's sufficient gap between the 2 bites that we have out here. This is the superior limb width has been. So you can again appreciate the gap between the 2 bites here. The superior limb being taken. Now this is what we are making the hole for the you can say infraspinatus stenodesis. This is again, we see this is the superior-most edge. Just come before it. If you go towards the edge superiorly, we're going to restrict the abduction also. So you need to take care, you're not severely restricting the abduction or the external rotation of the patient. So again, from the infraspinatus, this is the inferior bite coming in. And again, as I told you, you need to be very sure that you do not go much beyond the muscle into the deltoid. The other way of doing is you go into the subacromial space, which can be technically demanding, but we find that this is easier. Again, you got a sufficient gap. The next thing is that you go and do your Bankart repair once you have placed your suture anchors. You do not do Remplissage. This is the Bankart repair we've done and completed. Again, we have used all suture anchor in this case. And now we come back in, the head was centralized, and we try tying down our Remplissage sutures. The first what we tie is the inferior most, so that we can have visibility on the superior most. This is the inferior most anchor. This knot is being tied here. So that reduces the capsule. Now this is we are putting in and we're tying the infraspinatus suture. So this is the tenodesis that we're doing. So inferiorly it was the capsulodesis, and now here we are doing the tenodesis. You can again appreciate the superior most part of the defect. So as we tie, we need to push the knot repeatedly so that the muscle seats well on the defect. So this completes our Remplissage. So this is the final picture. This is the anterior repair. You can see the superiormost anchor. You would appreciate that the head is centralized, the Remplissage is complete, and the head is now completely centered on the glenoid. Now, as far as the literature is concerned, various authors have reported that the recurrence rate after Remplissage and concurrent Bankart repair is only from 0 to 8%. Boileau reported his results of arthroscopic Bankart repair combined with Remplissage in 47 patients, and he showed that there was 98% success rate. Zhu et al. And Murrell et al. Both found 100% healing rate for Remplissage when he did a post-operative evaluation with MRI and ultrasonography. Now, there are certain disadvantages also. So just as we talked about, that Remplissage leads to loss of external rotation. Now, there are a few papers who sometimes mention there's no loss of external rotation, but I believe if there is no loss of external rotation, simply means that your Remplissage is not working, because the basic concept of Remplissage is that you decrease the arc of motion. You make it extra articular and decrease the arc of motion. So there's going to be some loss of external rotation, something you need to prognosticate your patient, especially the sports person who are into overhead sports, about this, because it can be of importance to them, but that's how they generate their power. Now, there are a number of clinical studies who have measured range of motion, and they have not demonstrated this to be a significant problem. Now, Boyle et al. Reported about 8% loss of external rotation. However, he concluded that this slight restriction did not significantly affect return to sports. Now, what are the alternative techniques? Biomechanical in vitro Remplissage Latarjet both stabilize against dislocation. So you can use, technically speaking, Latarjet in also these cases. The systemic review longer compared management option of Remplissage, humeral grafts, arthroplasty, and Weber osteotomy. And he found that arthroplasty has the greatest recurrence rate and poorest outcome, while Remplissage demonstrated lowest recurrence rate, lowest complication, and the best outcome scores among all these techniques. So we can effectively say that Remplissage is an effective procedure for dealing with significant hill sac lesion arthroscopically. Thank you.
Thank you very much, Vineet. Do we have any questions from the panelists or any other faculty?
Vineet, can I ask you something?
Sure, sir.
Okay, fantastic demonstration. It was really nice. You know, the filling up. What is your experience? Fine, what literature says. What is your experience? Yours is a very high volume center in terms of post Remplissage stiffness of the shoulder, or maybe in overhead athletes, maybe javelin throwers. You see all kind of players coming to you. So what is your personal experience in this?
In patients, as you said, that the basic guideline for the treatment remains in preoperative measurement of hill sac lesion and the hill sac index and the glenoid tract. So we tell our patients preoperatively what we are planning. So what we have found is that in patients who we do Remplissage, there is definitely loss of external rotation. And as I told in the lecture, it can be sometimes problematic for patients or sports person who depend upon that external rotation to generate power. You very rightly said javelin is one such thing they need to have that external rotation. But you need to have shoulder stability, and only thing we have in such cases, either you go for Remplissage or you can go for Latarjet. So in patients who are in contact sports, we prefer doing Latarjet in these patients, and patients who are not into contact sports, we tell them Remplissage. But if this is a necessary devil, so if the patient gets consent, we do them. But if do not, then we just go for a Bankart repair. But we tell them that, ideally speaking, you need to have a Remplissage. The chances of failure will be higher if you go just for a Bankart repair. But most of the patients, given the right opinion, they agree for it, because I believe Remplissage has given us very good results, given a proper rehab protocol and the right technique. Just I told you, you need not go to the edge of the hill sac lesion, because as you go down, you're going to restrict the external rotation more and more. So you need to draw a line somewhere. Do not get overzealous. Do not try to go above the superiormost margin. If you go to the superiormost margin, it's going to restrict your abduction. So if you do technically right, the patients usually do well.
Dr. Vineet, I have a question.
Sure, sir.
Do you feel that Remplissage in recent times is probably an overdone surgery with no very clear indications, and do you find that literature supports Remplissage over no Remplissage in terms of the recurrence of the dislocation in non-contact sports person?
Sir, to an extent, you may be right. You know, in non-contact sports person, you might get away with that. But I think since the landmark paper by Toei and Yamamoto came out, that has made things far more clear for us shoulder arthroscopic surgeons and has given a technical reason. It was something before, prior to that, Remplissage was something which was done on the whims and fancies of the surgeon. But after that, it has given us a technical reason why we should go for Remplissage. And just as I told you, you know, if you do it the right way, it's a nice thing to do. And if you practice it right, it's not difficult at all and gives good result, you know. By the end of the day, patient demands, patient wants is a stable shoulder. So if you add a Remplissage to it, he doesn't mind it, provided you are able to give him a better stability.
We can ask Dr. Dinshaw about this.
Yeah, we can have a comment from Dr. Dinshaw regarding the Remplissage in contact.
Sir, are you concerned doing a Remplissage in a high-end athlete, like a javelin thrower or whose main profession is basically abduction, external rotation?
So I think basically exactly what Vineet said. I agree with him completely. So in our series, we've seen that you lose 4 degrees. The average is loss of 4 degrees of external rotation at 90 degrees. So if you're at 90 degrees, and that 4 degrees will make a difference to someone like a badminton player, a javelin thrower, a volleyball player. That 4 degrees will make a difference. So you need to have a fine balance. If your technique is correct, you're likely to be around 4 degrees. If your technique is poor, you could be as high as 20 or 30 degrees also. So if you're doing the correct technique, after that you need to assess, is this his dominant arm, non-dominant arm? If it's his non-dominant arm, I think it's worthwhile to do the Remplissage and go more towards stability than with a little bit of loss of range he'll accept. If it's a throwing athlete, anyone who requires that external rotation, I think you'll have to then keep the Remplissage away because they will lose that 4 degrees of external rotation. Does it add to stability? Certainly it does. I think most of the papers show us that it certainly adds to stability. And I think the decision thereafter is the balance between stability and mobility.
Okay, so what do you recommend in such cases in the high contact athletes or the javelin thrower? You think the Latarjet should be done or?
Absolutely. So I think if it's large hill sacks in the dominant hand of a javelin thrower, I'm going to increase his critical arc by doing a Latarjet. So by doing a Latarjet, I'm going to make sure that now his glenoid is wide enough so that that hill sacks, which was initially off track, becomes as good as on track.
Okay.
So whatever experience has been there, and we also give an option of Latarjet. So Latarjet also leads to some loss of external rotation, but definitely what we have seen is less than what we see in Remplissage. So there might be, because you are going to subscap, it's going to have some tenodizing effect there also. But yes, definitely it's less than what we see after Remplissage.
Okay, any more questions? Or we move to next. I will have a quick comment from our chairperson, Dr. Arya sir, on this.
I think I would like to ask Vineet if Latarjet as well as Remplissage has equally good result. Why we not prefer Latarjet over Remplissage in all athletes who require overhead abduction and throwing really?
Sir, one basic thing is that, though the world is moving toward arthroscopic Latarjet, but still Latarjet remains in most of the cases with surgeon and open surgery. While Remplissage makes more sense when given arthroscopic soft tissue repair like a Bankart repair. The second thing is that there is a school of thought which says that you should do Latarjet in all the patients, but what we have seen is a simple application of Wolff's law, the basic principle of orthopedics, that the body tries to, make the bone as good as what it was there anatomically. So if there is no bone loss and you apply a piece of bone entirely there, it's going to get resolved over a period of time. So that remains a basic cause of concern in patients when you do a Latarjet who do not have a significant bone loss. So scientifically speaking, patients who do not have a significant bone loss, if you do a Latarjet, there are chances that there would be a bone resorption over a period of time, and that itself has its own issues and problem. So I think again, I would say again that the concept and the paper, a landmark paper by DOA, has made technically our decisions far more easier than what they used to be before. That there are indications for doing a Latarjet. Yes, for patients in contact sports, you can have a lower threshold for doing a Latarjet. You need not go for 25 degrees. There are papers who say a 15-degree bone loss in a contact sports person or a high demand person is good enough for doing a Latarjet. But doesn't mean that a patient who has just a 5% bone loss, but a Hill-Sachs index, which is more than glenoid trach, you should do Latarjet. You should do a Remplissage. So I think there are indications which helps you now, or paper now, the scientific evidence now, which helps you decide scientifically what to offer to your patient.
Sorry, can I make a comment here, Dr. Joshi?
Yeah, definitely.
Yeah. I think, just to add to that comment between Latarjet and Remplissage, we know that Remplissage has a very low complication rate compared to the Latarjet. And, when you make a decision, you have to consider patient factors as well as bone loss and bipolar defects. I think that helps you decide. We see a lot of contact sportsmen, so we will tend to do more Latarjets. But with the throwing sportsmen, you may want to consider bone blocks to allow them a little more mobility in abduction, external rotation. So yeah, but the take home is that Latarjets do have a lot of complications compared to the Remplissage, which is why people have tended to drift towards doing more Remplissage in these patients with subcritical bone loss.
Okay. Any more comments? That was a very nice tip from Dr. Sham. I think we'll move on to our next talk by Dr. Skand Sinha. So he'll be talking on the problems with the Bankart repair, what to do when we have some problems with the Bankart repair.
Good evening, am I audible?
Yeah, you are audible.
Okay, good evening seniors and friends. Mine is a back to basic talk, how to avoid Bankart repair failure. Is my slide visible?
Yes.
Yes, visible, Dr. Skand, you can start.
Just put it on slide mode and go ahead,
Slide mode. Just put it on the slide mode.
Yeah, it's okay, sir.
So reported failure rates for Bankart repair in the best of hands are 7 to 22%. And we want to know what causes failure. So failure of Bankart is associated with bone loss on the glenoid side more than 20%, or an off-track bipolar loss, generalized laxity of joints, labroligamentous tissue, neurological disorders, especially seizure, if there's a concomitant cuff gear which is missed, generalized internal rotation deficits in contact sports person and young population, and patients who have high number of dislocations at the initial presentation, and finally flaw in the surgery. So basically, we are going to take up all the factors one by one. We'll come to the bone factors. There is about 90% prevalence of glenoid loss in case of recurrent dislocation shoulder, some bit or the other. And Hill-Sachs defect is up to 94% of cases, maybe mild or more. Glenoid is around 24 to 28 millimeters wide, and every 1.5 to 1.7 millimeter bone loss corresponds to 5%. So it's a 20 to 25% bone loss when a patient loses 6 to 8 millimeters of glenoid. All the calculation methods of glenoid bone loss are based on the principle that glenoid is pear-shaped and inferior part of glenoid is circular in shape. So bone loss assessment tools are plain X-rays, which is not accurate, 2D CT, 3D CT, 2D MRI, 3D MRI, and finally arthroscopy. A 3D CT is the most accurate way of calculating bone loss. Calculation methods on CD are based on linear measurement of Bankart length, ratio method, true circle method, superimposed circle method, and Pico method. commonly used methods are true circle method and Pico method. We use true circle method. This is an example. Picture A shows percentage of bone loss on glenoid and face view CT scan. Second picture B shows Hill-Sachs interval calculation on 3D CT. And third picture shows calculation of size of coracoid. So if the Hill-Sachs interval is more than the glenoid tract, it's an off-track lesion. So this calculation is an ideal situation that you have before going in for surgery. But sometimes you get patients who have only CT scan without calculations. In that situation, we can use method suggested by Griffith. They suggested that on end face view of CT scan, if you see the pier shape intact, that means the bone loss is minimal. It's a classic Bankart lesion and bone loss is limited up to 5%. If the anterior margin of pier is flattened and straight, it's bone loss up to 15%. And if the pier is reversed, the bone loss is more than 20%. So this is a simple way of knowing the bone loss on the glenoid side. On the humeral head side, a simple radiograph is good enough. On scapular AP view, we see on external rotation AP, Hill-Sachs lesion. The size of Hill-Sachs is significant because Hill-Sachs is a posterior superior lesion and it's visible on internal rotation AP view of scapula. Finally, arthroscopic measurement is there by viewing from anterosuperior portal as shown by Dr. Bini. But this method doesn't correspond accurately to CT calculation, and more so sometimes bare spot may not be appreciated. Finally, there is dynamic assessment after you do a Bankart repair. So after you completed your Bankart repair and you have a Hill-Sachs lesion, you have completed your Bankart repair and you see whether the head is centered or not. You put the scope in anterosuperior portal and put the shoulder in abduction and external rotation to see whether this Hill-Sachs engages or not. If it engages, then Remplissage can be added. Park et al. They found that selective use of Remplissage by this method is as good as calculating before hand using a CT. That means in off-track lesions also, after doing Remplissage, after doing Bankart repair and doing a dynamic assessment, they found that it was centered in many patients. So result was not inferior if they skipped doing Remplissage. In lab studies, it has been found that the contact pressure at the repair site is 15 to 20% higher if there is only soft tissue labral loss. And this increases up to 4% at the soft tissue bone repair site with 30% glenoid bone loss. Rest other bone losses lie between these 20 to 400%. So any soft tissue repair to bone cannot withstand that amount of pressure at the end range of motion, and the failure is because of bone loss, not faulty technique. The way out, putting a Remplissage for low demand patients and doing a Latarjet for high demand patients. Coming to soft tissues, soft tissue factors are usually underestimated, as we know that increasing number of dislocations, in addition to bone loss, the capsulo-ligamentous sleeve weakens. It is stretched out, and at microscopic level, the microstructure is deranged. So soft tissue assessment can be done clinically on MRI and arthroscopically. On clinical examination, we check for rotator cuff components, assessment of internal rotation deficit. If the Beaton score is more than 6, it's a risk factor. The sulcus sign is present, it's a risk factor. If there's hyperabduction more than 20 degrees of the involved shoulder, that shows the inferior capsule is stretched out. And if there's increased external rotation without decreased internal rotation, that again shows that the anterior capsule is stretched out. And there's a load shift test that can be done in clinic to see for soft tissue insufficiencies. Under anesthesia examination is another important thing. Under anesthesia, we check for anterior and inferior translation of head in position of abduction and external rotation. If it's increased, that shows insufficiency of soft tissue, especially when there is little bone defect. And finally comes arthroscopic evaluation of the ligaments and capsule. We see for tears, and we see for if the capsule is redundant. The way out for soft tissue insufficiency, capsular plication, in addition to Bankart, if the capsule is stretched out. And if the capsule is torn, redundant, we can add a Latarjet and abandon the arthroscopic repair. Fault in the surgical technique, has been discussed by previous two speakers. So I'll emphasize mobilization of labrum is very important, so that chest and north tightening is done properly. Abrasion of glenoid neck adjacent to the articular margin by a manually or by a motorized shaver is important, so that you add healing potential to the soft tissue bone repair side. And if you are using a knotted repair, ensure that knot is not loose, and never repair a flimsy labroligamentous tissue as it is always bound to fail. And do a concomitant rotator cuff repair. Sometimes for beginners, if there is difficulty in reaching down to the anterior inferior corner of shoulder because of tight shoulder or because of head subluxating anteriorly, there is chance of inadvertently placing the anchors superiorly, not inferior enough, and this can lead to failure. So in such situation, assistant can be asked to push the head posterior, internally rotate the shoulder, abduct and distract the shoulder. That will improve the vision. And even after this, if there is difficulty, all suture anchor with curved guide can be used. Finally, well-executed Bankart repair can also fail, like this case. But this case was a wrestler, 22, and his instability severity index was 3. So any case with instability severity index over 3 is bound to fail mostly. But there is a flaw in instability severity score, that it doesn't consider number of dislocations or sleeve dislocators, as both of these conditions are known to cause stretch out of the capsular ligamentous sleeve. To conclude, Bankart repair is successful if causes of failure are ruled out diligently, preoperative level, and during surgery. Thank you.
Thank you, Dr. Skand. That was a very nice talk on why the Bankarts fail and what should we do to prevent it. I think the surgery starts from the positioning of the patient. The surgeon should himself make the proper position with a 30-degree tilt, so that we can have a good view of all the areas and we perform the surgery in a very more technically nice way. So any questions from any of the faculty or panelists on Dr. Skand's presentation?
Deepak, my suggestion that next time when the presentation is made, that the speaker missed his video because the voice was breaking. Only the audio continues, the screen sharing continues, but his own video is stopped. So because the voice was breaking.
Okay. The video was not visible?
The video was visible,
but the voice was cracking.
Voice was breaking because the transfer on
actually there was a lag in the
own video, screen sharing, as well as the sound. That all three were making the things difficult.
There was a lag in the video, sir, that occurs when the size of the file is much more.
Okay.
So I think I have one question from Dr. Vibhu to Dr. Dinsha. He has WhatsApped me. It is Dr. Dinsha here. Then he presented to me a situation in an overhead athlete, a throwing athlete, where they have done a Latarjet, where a hypothetical situation where the Latarjet has been done, but it failed to convert the off-track Hilsach to an on-track. Then what should we do? Should we add Remplissage to it or not, or we do something else? So that's a specific question to Dr. Dinsha from Dr. Vibhu Well from Apollo Hospitals.
Okay, so according to me, I think doing too much surgery in one shoulder is dangerous. Latarjet in any case is non-anatomic procedure, and as Dr. Shyam mentioned, this procedure is prone for complications. So it's not something that's very forgiving. You need to be absolutely sure that your bone is in a perfect position. Your subscap split is also perfectly done. If you're doing a capsular label repair after that, it's not too tight. So all of these things will come in the way of the ultimate range and the function of that Latarjet. Now to add one more non-anatomic procedure to it, which is a remplissage, because ultimately a remplissage also is non-anatomic. You are shifting the infraspinatus and recessing it and shortening its length. So I think that double combination of a Latarjet in the front and a remplissage at the back is highly prone for a loss of range and for complications and for increasing the capsular tightness and for pain. It's a combination that I have never done and which I would not recommend that anyone does, though there have been some papers that have recommended it for basically epileptics. So epileptic patients who've got significant bipolar bone loss, so glenoid bone loss and significant Hill Sachs, they've recommended it, but I would be quite apprehensive of doing both at the same time. I think if you're doing a Latarjet procedure, your Latarjet itself is going to have that triple effect. It's going to add the bone. It's going to make sure that your congruent arc is much larger. It's going to help because it's got the conjoint tendon, which is going to act like a sling. And the triple effect comes in then from the subscap too. So I think that triple effect itself is good enough for stability. And if that's a throwing athlete, then certainly you don't want to do a Latarjet with Remplissage. That will just kill his shoulder.
Thank you, Dr. Dinsha. I think the message has been passed that don't try to do too much on a single shoulder, otherwise you will end up in
absolutely true.
Lots of problems. So I have one more question from Dr. Skand. How you assess whether you want to do a remplissage? You do it pre-op or you do an intra-op assessment, or you do something, a combination of both?
I do a pre-op assessment on 3D CT, which is sent to me by radiologist, calculating all the parameters. If it's an off-track lesion, we plan for remplissage, and arthroscopically we analyze before putting anchors that this is a big defect, Hill Sachs defect, and it is engaging Hill Sachs defect, and we put remplissage anchors first and do the Bankart later. So I don't follow what Park has said, that you do Bankart first and dynamically assess and add remplissage later, but that makes sense also.
Yeah, definitely. That's what most of us do. I have a quick comment from Dr. Kataria that have you passed through a situation where you thought that it's an on-track lesion and it's an on-track lesion, and when you go inside, you have to change your mind and you have to do a remplissage sometimes?
No, more or less, the decision for doing this kind of a surgery is taken pre-operatively only. We've actually
okay. The pre-operative, you have taken a decision, no remplissage. Have you come across the situation that you have gone inside and you have changed?
That has happened many times, and we have added remplissage as an additional procedure. Of course, we do at times discuss that we've really not prognosticated the patient in terms of restricting the ER, but this is a thing which is encountered quite frequently.
Okay. In the first of the lecture, I saw the video that Dr. Himanshu Gupta had shown that the MGHL was taken in the bite. You think that also can restrict the motion sometimes, or you routinely do the MGHL, take the MGHL in the bite your superior?
No, it's a question that if you're looking at, say, a very lax shoulder, probably taking the MGHL through that second bite may be useful. But I think if you're looking at a normal shoulder with not much of a laxity, certainly this can contribute to a restricted external rotation.
Okay, thank you. Any more comment from the faculty? I'll ask the chair, Dr. Arya, to comment on it.
I can make a comment here, Dr. Joshi.
Yeah, you can comment. Definitely.
Yes, I think when we're dealing with instability, your dislocation is anterior and inferior. And therefore, you must not forget the inferior capsular laxity and make sure that you do provide a superior capsular shift to the inferior capsule. And sometimes accessing to inferior capsule is difficult from anterior. In that case, we would create a 7 o'clock or a 5 o'clock portal posteriorly and then get your suture into the inferior capsule And that ensures that you will now draw it up anteriorly. So you put the suture into the inferior capsule and draw it up to your 5 o'clock anchor. And that's how you'll get back some reduction and capsular shift with your Bankart repair.
Yeah, that's a very nice tip. Yeah, you can definitely go from the 7 o'clock and take a bite from that. That's a very nice tip, Dr. Sham. Dr. Arya would like to comment on.
I think I would like to say, let's complete the speakers, and at the end of it, we conclude by discussing all these the pros and cons of every. I think audience will be benefited more, I suppose.
Okay. I think we have the next talk, Dr. Himanshu Kataria. Sir will be talking on the double row rotator cuff repair. You can share your presentation.
Yeah, is that visible?
Yeah, it's visible, and you can start.
Yeah, so I'm here to talk on a real-life surgery, which is on a double row rotator cuff repair. There are some quick facts, just 1 or 2 slides. We are all aware that there are significantly high re-tear rates with the traditional single row repairs, and there are enough series varying from 29% to almost 90%. The second point, which is important, is that the repair tendon needs to sit for a long period of time on the healing so that healing is possible. And tissue compression on the bone invariably enhances healing. As for any repair, whether we are doing a single row or a double row, our goals are: one needs a healed osteotendinous interface, one needs to regain the muscle strength, one needs to achieve flexibility, and one needs to achieve an optimal shoulder function outcome measures. Now, the evolution, we are all aware, it is based on the concept of a footprint reduction, which actually provides for a wide interface between the tendon and the original footprint of the humerus. Now, a quick history of this patient, which is going to be shown. It's a 55-year-old, 5 foot tall female who is a known diabetic with a history of fall 4 years back. She had a painful shoulder since the last 4 months, which actually disturbed her night sleep. We found that she had a clinically restricted shoulder abduction and forward flexion. There was otherwise a positive Job sign, but a negative internal and external rotation lag sign. Her tests for instability were negative, and her MRI showed a full thickness supraspinatus and a partial infraspinatus tear, but a maintained glenohumeral articulation. We'll go ahead with the video now. We go for a quick anatomical, thoughtful placement of these portals, which is very important for optimal visualization and instrumentation. So we have got the standard posterior, the posterolateral, the lateral or the 50-yard, the anterolateral, and sometimes the Navier portal. One then goes in for a standard glenohumeral scopy, where you assess for other pathologies as well as you're looking for the intra-articular extent of the cuff tear. You would then try and address the biceps with either of the means that is available. I think that's a topic in itself. So you could go in for ignoring it. You could go for biceps tenotomy, or you could go for a tenodesis. Once you've completed, we normally do a tenotomy. We presume that biceps is an important source which actually contributes to pain. So we usually try and do a tenotomy. Once our tenotomy is complete and our glenohumeral scopy has been completed, we are now introducing an identifier needle, which is put percutaneously. This is actually useful because it helps when we switch over to the subacromial portal to actually visualize the exact site and the extent of the tear in the presence of a thickened bursal tissue. So once we have this subacromial scope in position, it is this needle which has been put percutaneously, which is very clearly visible now, passing through the tear. And then we subsequently start with our subacromial decompression. We would now create a 50-yard portal because that is what is invariably required to have a good assessment of the tear size as well as the tear configuration. We go ahead with a recession or a resection of the CA ligament and extensive debridement of the subacromial space, removal of the hypertrophied subacromial tissue and the bursal tissue. Of course, removal of the bursal curtain, the bursal leader. And while doing the subacromial decompression, we need to be sure that as far as the lateral extent is concerned, we do not invade into the deltoid. We stay somewhere away from the subdeltoid fascia so that we don't rip the insertion of the deltoid. Needless to say that the decompression definitely provides us with a good working space and gives us a good idea of the tear configuration as well as the size. Like in this particular case, you can see that there is a tear retraction, cuff retraction is there. It is almost just up to the lateral surface of the humeral head. At this stage, we now create another portal, the anterolateral portal. And this is actually done to complete the subacromial decompression, since this is more of a posterior superior tear. So we would need to actually resect out do a decompression from the posterior aspect of the tear also towards the infraspinatus. And one would need actually a very cautious mix of a shaver and a radiofrequency. And of course, the most important thing, a good, well-maintained systolic BP as provided by the anesthetist. The shaver helps us in clearing the chronic bursal tissue, and besides that, it also helps us in abrading the footprint area for a good biological reattachment, just juxta-articular. We have occasionally used the passport cannula, which actually has a distal flange, which helps us sometimes, to keep the subcutaneous fat away from entering. Occasionally, the passport cannula does become a nuisance as it may be too bulky to be available in that tight space. Some more subacromial decompression, again, a good clearing, particularly from the posterior and the medial side of the supracuff bursal tissue, so that the suture passage and retrieval is smooth, and we can easily go up to the musculotendinous junction for taking good suture bites. We will take up again the undersurface of the acromion, the suprabursal tissue, and here you can see a nice tear configuration which is visible. We do create the anterior portal, which is normally being used for suture parking or for suture shuttling. At this stage, we once again prepare the area of reattachment of the cuff. And now we assess for tear mobility through the 50-yard portal. In this case, if you notice, it's not a very mobile tear, and we are very sure that we don't want to put a tear or a double row or single row, whatever, under tension. So it's very important, whatever technique we use, the suture placement and the cuff replacement should not be at any tension. So we've done a further release. Now we are going to go in for placement of our anchor, which is just done lateral to the lateral edge of the acromion. It's a typical dead man's angle at which we insert our corkscrew. In this particular case, since this was a 50-year-old diabetic female with a 4-year-old tendon, so we opted for metallic anchors. We opted for the titanium 5.5 anchors. And we need to ascertain by this needle placement that what is the best position for anchor placement. This anchor, of course, has a suture eyelet which runs through the center of the anchor. This is initially malleted, and then subsequently you can see how easily in such a porotic bone it went in, and then subsequently screwed in. Once it's screwed in, we try and pull the threads to make sure that it's got a good hold of the bone. Now we'll try and retrieve. So you can see it's a double loaded anchor. It's got a tiger and it's got a white. We now put in a suture retriever. What we are using in this case is a bird beak. And we are going to pass this through as much of a normal thick cuff tissue, maybe about 15 or 16 millimeters from the tone ends, just medial to the cuff cable through the musculotendinous junction. And we'll retrieve one of these tiger suture limbs through the posterior portal. While retrieving, if you notice, we are very careful that there is no movement which is taking place at the suture eyelet so that we don't disengage the anchor. I invariably prefer going for mattress sutures. So we will again now be passing the second time the bird beak. And the second fiber wire will be retrieved in a similar fashion through the posterior portal and parked. We have to ensure that we get an adequate and a good thickness, full thickness bite through the cuff tissue. And we try and space each bite roughly about 5 to 7 millimeters away from the previous bite. So this tiger wire is again retrieved now, the second tiger wire through the posterior portal. Now we will take care of the white fiber. This is now going to be passed by using a retrograde suture passage by any device which is actually a suture passer cum retriever. So in this case, you can see here, this is a typical suture passer cum retriever, which has actually got a contained needle for the passage through the cuff. And there are various companies come with various names, First Pass, Cobra, Scorpion, any of them, it's got a fairly large jaw, which ensures that you get actually a thick, full thickness bite through the cuff tissue. This is a retrograde suture passage which is being done. And again, we would be using a mattress configuration. So as to get a maximum coverage on the cuff tissue. This way, all the 4 suture limbs, once they are through the cuff tissue, are parked through in the posterior portal. As you're all aware, the weakest point of any repair in such a situation has always been shown to be the suture tendon interface, with suture pullout being one of the most common causes of a repair failure. So we try and make sure that we have adequate bites through the cuff tissue. We normally tend to use a minimum of 2 anchors in the medial row, but it depends on the tear size. So the number of anchors actually, the decision is based on the size of the tear. This is again parked posteriorly. We're now ready for the passage of the second anchor, and we might have to manipulate the shoulder to a bit of external rotation to get a good view of the abraded surface. And we repeat the same maneuver for passing the second titanium metal anchor. The second bite. And we will quickly fast forward on this component since we are going to be repeating the same maneuver. Once we have all our suture limbs passing through the cuff tissue, the anterior anchor suture limbs are parked through the anterior portal. And subsequently, with whatever knot that we are comfortable with, we'll go with the sliding knots to seat the cuff onto the footprint. Once the cuff is seated on the footprint with the knots in place, now we need to decide what kind of a configuration for the lateral row we take. So in this particular case, we opted for a inverse triangle or a delta configuration for the lateral row. So we will be picking up 2 suture limbs from the anterior anchor and 2 suture limbs from the posterior anchor. That's the last white fiber from the anterior anchor. The knot is tied. Now 2 suture limbs from the anterior and 2 suture limbs from the posterior. We do a trial reduction, picking up these 4 limbs and try and see how well we are able to seat. So you can see we are able to seat the cuff nicely in a mattress fashion. That's an external view also which is available. So now we are ready to pass the lateral row. This is roughly placed at about 7 to 10 millimeters distal lateral to the tuberosity of the footprint insertion. The anchor that we are using here is actually a striker make ankle. It's got a metallic tip and it's got a peak body. So as with most anchors, whenever we will first seat this, we will hammer this and seat this into position. Make sure that it is through the and then 2 working sutures from the anterior and 2 working sutures from the posterior are now loaded through the pull tab, and the anchor is secured by hammering it. Once the anchor is fully seated by malleting it, we make sure that the body is in the bone and all the sutures are under equal tension before we actually start rotating. So this particular device, we are still going for the mallet. This particular device has that peculiarity that it's got a black knob. So when you actually rotate, every 60-degree turn roughly gives you about 1 millimeter to 1.5 millimeter advancement of the So now we are going to rotate and one will see the motion of the suture anchors. And this is actually an incremental tensioning and a seating. So you can see how nicely you have a well-seated cuff with the whole construct, the osteotendinous unit seated firmly into the footprint area. And you have a footprint restoration. You can recheck it by moving it as one unit, and this moves as a one single unit. So this was the pre-operative picture that we had. And this is the post-operative picture with a nicely seated cuff. Thank you.
Thank you, Dr. Kataria, sir. That was a very nice demo video of the double row rotator cuff repair. I think we are short of time. So I'll ask quick comment from Dr. Sham. Always double row. If always double row, you not the medial side like Dr. Kataria has done. You are muted.
Sorry, yes. Yes. I always use a double row fixation. I think it gives us the tension band effect like you would on a patellar tendon. I believe that the superior sutures provide compression to the cuff. So yes, always double row fixation. Medial knot tying, yes, I also do that because I believe if you bring up the arm in abduction, you'll get a windshield wiper effect of the medial row if you don't put it down. So I always repair the medial row, and yes, always double row fixation for me.
Okay. Thank you so much. I think I'll ask Dr. Kataria also that we know that we get so many poor patients with us. So there is always a issue with the number of anchors. So most of the patients are poor. You, Dr. Kataria, know. So how you deal with such situations? Single row?
Possibly, I think if we are looking at, say, a labor class person and a young person with an acute traumatic tear, probably a single row would suffice. Fortunately, the setup where we are working, we have the option of a social welfare officer available to fund these people. But I guess somewhere down the line, you've got to strike a balance between the two.
Okay. A quick comment from Dr. Dinsha too. Single versus double.
I want a low tension repair. At the end of the day, I want a low tension repair. If I can get the low tension repair with a double row, I would prefer that because biomechanically that's stronger. But if my repair is going to be under tension with a double row, I have no problem at all doing a single row, which would be medialized. I certainly don't want to re-tear with a double row. I think that's the bottom line.
So, okay, that's a very nice comment. So we should have a tension-free repair. That is the most important thing, that we should not have a re-tear. I think we are passing through short of time we have. So I think I'll quickly share my presentation and then we can switch on to our guest faculty. So am I visible?
Yes. Yes, you are visible.
Sir, you can go ahead, sir.
Yes.
Thank you. Thank you. So I'll be speaking on Latarjet. Most of things have been discuss the principles. So what is Latarjet? We know it is the process of transferring the coracoid process and the conjoint tendon to the glenoid. So we have a triple effect, we have a sling effect, and we have a bone augmentation. And we repair the capsule in external rotation so that we don't have limitation of external rotation. So as Dr. Dinsha told, that a properly done Latarjet will not have restriction of motion as compared to the Remplissage. So what are the indications? So contact sports throwers, we have already discussed. When we have a poor tissue, multiple dislocation, the labrum is of very poor quality. When the Bankart, a properly done Bankart has failed, when the Hill-Sachs is engaging and it's a very, very large bone defect on the glenoid side, more than 20 to 25%. So that may vary. Some people say that 13% also you should do a Latarjet. So the evolutionary type, Latarjet in 1954 was introduced, and the original Bristow in about 58, almost the same time, where the coracoid is attached to the anterior part of scapular neck through a transversely sectioned subscapularis muscles. Principles: a bone effect, what is lost, we are filling that, the bone loss is filled by a bone. Then the belt or sling effect, very important, like Dr. Manocha was telling in one of the chats that, okay, even if the bone is resolved, the sling is working, the patient is confident, patient is not having apprehension. And the third effect, of course, is we repair the capsule properly in external rotation so that patient has a good amount of proprioception. As with any surgery, the surgery starts at the positioning. The surgeon should himself make the position of the shoulder. That is very, very important. Don't leave it to the residents, or you train them well, but you should always see the position. If the position is right, then you will not struggle during the surgery. So the surgical technique, incision about 3 to 5 centimeter long. The tip I was visiting at some place. I used to make an incision lateral to the coracoid, but now I have started giving the incision just medial to the coracoid, the skin incision. So that makes a life little bit more easy when you are exposing the glenoid. The arm is, we go to the deltopectoral groove. The arm is abducted and external rotation. The CA ligament is identified, transected, and we cut the coracoid distal to the coracoacromioclavicular ligament so that we don't have, coracoaclavicular ligament so that we don't have a problem with the AC joint stability. And we cut from medial to lateral so that we don't injure the plexus. Prepare the coracoid, make 2 equidistant holes, and then the subscap split. Again, it is very important. Put the arm in full ABR, abduction and external rotation. Look at the full view of the subscap. You should be able to see the upper and the medial inferior border properly, so that you make the split. Well-placed split should be done at the junction of upper 2/3 and the inferior 1/3. One should see the plexus of the vessels to assess where exactly you have to make the split, so that you avoid ending up with the complications, and you exactly go end on to the area, the 3 to 6 o'clock area, where you have to put the coracoid. Then the long axis of the coracoid is put superior inferiorly, and we have a short head of biceps, and the coracobrachial attached to the coracoid, so it helps in having a sling effect. The ideal position has to that the coracoid has to be the flush with the glenoid from inferior part, that is 3 o'clock to the 6 o'clock position. So if we make the split proper, I think we exactly end up on the glenoid neck, which is 3 to 6 o'clock position, and we make a parallel hole and do a bicortical screw procedure. So after once we have done, we can do the capsule repair in full ABR position, so external rotation position, so that we don't end up in having a loss of external rotation, and we can also reinforce the capsule with a CA ligaments stump. So it's a small video. You can see that's the incision. Oh, small. I'm sorry. So you can see the incision. That's the coracoid. Patient in breech chair. So that's a clavicle here. The incision is just medial to the coracoid. So that is what we have been giving for last. So then we expose. You can see that's the deltopectoral area. Now that's the coracoid here. This is the coracoid. On medially we have the pectoralis minor muscle. We have a CA ligament on lateral side, and we have a conjoint tendon on the tip of the coracoid. So we expose everything properly. You can see how well is the exposure. So the capillus is retracted laterally here. So we then cut the pectoralis minor from the bone. Very, very careful. We have a plexus just medial. Then we cut the CA ligament, and then we cut the coracoid from the base. Take care that we don't injure the coracoclavicular ligaments. So we remain anterior, and we should take as much as length of the coracoid. We Indians, coracoid is very, very small. So putting 2 screws, sometimes it is very, very difficult. So take the good length of the coracoid. Then you look at the inferior surface, just debride the inferior surface and decorticate it. So it's a little bit of concave surface, so we make it flat. So that's how we just with the saw, that this is how we are making it flat. So that's the inferior surface. We have a conjoint tendon attached to it, so we make it flat, and then we make 2 drill holes equidistant on the coracoid. So now we make the split. So once we make the split, we expose the glenoid. You can see, because of this medial incision, how well the glenoid is exposed. That's the neck of the glenoid. So that's the neck. And we just rasp it, make it raw. That's a bleeding bone. That's entire glenoid. Head is retracted. And we make 2 holes onto the coracoid. So we have jigs and the drill available for making the 2 equidistant hole. Here we are doing it with free hand, and we can use a plate. This is plate we used to do quite often. Now we can use 2 screws also, as we know that we have lots of poor patients with us. So we hold with a device. There are jigs with which you can hold. The most important is, you can see this is the glenoid and that's the coracoid. It is very flush with the glenoid. It is neither too medial nor too lateral. If it is too lateral, it will end up in having an arthritis and a pain on ABR. And if it is too medial, then it will end up in dislocation. So it has to be well fixed, and then we repair the capsule, and that's how the small insert, you can see the capillary is intact, and it's with I think 3 centimeter incision we can do a normal Latarjet. So in a Latarjet procedure, the important is that the correct patient selection, sound surgical technique, and treat everything. Thank you so much. So this was the short presentation. Any question is welcome.
Dr. Deepak, can I ask?
Yeah.
Nice presentation. How do you do and when do you do a capsular lateral repair along with it?
Yeah, if the labrum, most of the times we always try to split. So we split the subscap and we look at the capsule, then we split the capsule. They are separated individually. Okay. Then capsule we always repair. The labrum, if we have a good quality labrum, but that happens very less often, then we should always repair the labrum with the anchors.
Okay, so you repair using the anchors, you repair it and then you fix the bone on the edge of it, correct?
Yeah, you fix the bone, we put the anchors, take the bites through the labrum, and then we put the coracoid, then we finally tighten the. So we first pass the anchors, take the bites through the labrum, then we put the coracoid onto the glenoid, then we stitch the labrum. Okay, that's how we do, but the incidence is very, very less because most of the times when we are doing a coracoid procedure, the Latarjet procedure, the labrum is generally not redundant or the capsule is not that good.
Dr. Deepak, there are questions from the audience. Can I take it now?
Yeah, definitely, sir.
Yeah, there is a question for Dr. Dinshaw. Dr. Dinshaw is there? Dr. Dinshaw, are you there? Yes, he is there. One of the audience want to ask that Dr. Dinshaw, that if Latarjet cannot convert off-track hill sac lesion
I think
to
that
track,
has been covered. Dr. Manish, that has
is
been
covered.
covered.
Okay. And other for Dr. Sikand, that comment of number of anchors, whether single or double loaded.
Dr. Skansina, there is a question for you. Number of anchors and
whether single or double loaded.
Number of anchors, usually we use 3 anchors. The basic thing is the stress should be equally distributed amongst all the anchors and none of the anchors should get overstretched. So 3 anchors are usually used for fixation. And if it's a chronic labral tear with the propensity to roll back, then we use double loaded anchor at 530.
I think this answers to the question. This was asked by one of the audience. Anything else, Dr. Manish?
No, it's okay. You can continue, sir. Continue.
Dr. Deepak Joshi.
Yes, sir.
May I ask? Now, I put that to you on privately on the chat also. So now we have been saying that Latarjet causes bone resorption, so that must be a bad reason. I have many of my cases in this bone resorption happen, but still no recurrence, because I want to emphasize that part with Dr. Dinshaw made, that the Latarjet does 2 more things, that it brings the subscapularis also into a more beneficial position, and it adds a sling from the coracobrachialis and the short head of biceps. So comments of the faculty as to how this residual effect is still useful, and should we give that much of importance to the bone resorption, that being in any case an unanatomical and is expected to get resolved. So my point is that trying to say that the Latarjet may be bad because the bone is resolved, I don't think that is really missing the point of Latarjet.
Yeah, absolutely, Dr. Manoj. The Latarjet is a very good procedure. Even if the bone is resolved, still the patient does very, very well. So I think bone resorption is not that an issue. But I can ask the other faculty. I can ask the Dr. because we have paucity of time, I can ask Dr. Himanshu Kataria, Dr. Shah Osman, and Dr. Dinshaw to comment on it. Bone resorption, still the Latarjet works.
So should I take it first? So in our assessment, we get a CT scan done in many of our patients. At the 1-year mark, at least 30% of patients will have significant bone resorption, though about 50% will retain at least 70% of that bone. Now, clinically, as Dr. Manocha has mentioned, it doesn't seem to make too much of a difference. The stability is there in all of these patients. So the second and the third effect, which is the sling and the subscap effects, certainly are extremely, extremely important. I think patients who have a significant bone loss tend to lose less bone. So less bone resorption takes place in them. Whereas if you've got a patient with, say, 15% bone loss in the glenoid and you put a big bone block there, certainly you'll find that some amount of that bone will be lost because, again, going by form following function, what's not useful to the body is going to osteolize. But even if it does osteolize a little more, clinically, it doesn't seem to make too much of a difference. I've seen at least 2 or 3 patients where the entire bone has got osteolized. Entire means there's no bone left at that 1-year mark. And they're still extremely stable. They don't even have apprehension or a subluxation. So I'm sure that the other 2 effects are just as important. As long as that bone heals and then some fibrosis takes place, I think that sling effect is critical.
Dr. Dinshaw, another panelist, there has been concerns raised recently, especially in one issue of American Journal of Sports Medicine, with the high incidence of secondary osteoarthritis after Latarjet. So what are your comments on it and how can we prevent that?
Okay, so I think that's absolutely critical. I think anyone doing a Latarjet needs to understand that this is a non-anatomic procedure. You know, anything that is anatomic, like a Bankart, you're going to have less chances of OA. Anything that's non-anatomic anywhere in the body is going to have a higher chance of degeneration in the future. I think that we need to recognize. The opponents to that would say that, look, a Latarjet is done in someone who's had multiple dislocations. He's already started getting chondral loss in the glenoid. So it's the chondral loss that has then progressed into OA and not really the Latarjet. That could be an argument. But I think a Latarjet is a very non-forgiving procedure. You saw the way Deepak showed that. In case your bone block is not perfectly in position, if it's not flush, you're going to be in trouble. If it's proud by even a millimeter or 2, you'll get very rapid acceleration of your OA. If you have, after doing a Latarjet, done a capsular labral repair that's too tight and you've restrained your shoulder, increased your glenohumeral pressures, again, that's going to result in OA. So it's not a forgiving procedure. If you're doing a Latarjet, you need to do it absolutely perfectly. Unlike that, a Bankart is an extremely forgiving procedure, very low complication rates, because again, it's an anatomic procedure.
Hi.
Yes, Risha.
Yeah, well, you know, we do a lot of Latarjets, and what you notice is that your superior part of the graft is what gets osteolized. Now, if you look at the glenoid is basically 2 circles, a small circle superiorly and a large circle inferiorly. So whenever you put the bone block, the body wants to reshape the bone that you put in back to its normal circular fashion. So we always see more erosions and osteolysis of the upper part of the graft. And that's one of the things I want to bring out to you, that using a plate system can sometimes become a detriment to you because you leave a lot of metal left behind, and that can then cause damage to the humeral head. So people have now drifted towards maybe using hybrid fixations, using button fixations for this graft. So if you do get osteolysis, you won't have so much of damage from the retained metalware.
Yeah, Dr. Kataria, quick comment so that we can. I
think it's gone.
I think it's not there. So I think we have paucity of time, and we move on to our next talk. So we have Dr. Dinshaw with us on a very, very important and one of the difficult procedures for us, superior capsular reconstruction. It's very, very common in our scenario. People report to us after 6 months, 7 months of a cuff. The cuff is not there. Nothing is there, and we all try to repair it somehow, partially or completely. So we need an answer to this. So how to get over it? So we have none other than Dr. Dinshaw. He has a vast experience in this SCR procedure in the scenario where we don't have an allograft available with us. Dr. Dinshaw.
Thank you. So SCR, what does SCR stand for? So basically SCR is superior capsular reconstruction. Now, we know that when you get a massive rotator cuff tear, if it's repairable, you've got multiple techniques, as has already been shown, to repair it. But if it's irreparable, and this is something that we see very commonly in our country, then you are in a little bit of a fix. Many patients will require non-operative treatment. They're not that symptomatic. They're happy with their shoulders, great. But let's talk about the symptomatic irreparable tears. Now, if they're older, you can offer them a reverse total shoulder arthroplasty. Simple, straightforward option, great. But if they're young, irreparable, and symptomatic, I think that's a real problem in shoulder surgery today. And for these, you've got basically 2 or 3 options, either a partial repair or a superior capsular reconstruction or a tendon transfer. And each of these has its benefits. Now, what really happens in a massive rotator cuff tear that's irreparable? You've got the deltoid causing proximal migration of the humerus, and you've lost your forescupple of the subscap with the infraspinatus. So the humeral head is going to go more and more proximal. It's going to start abutting against the acromion, and this starts off the whole process of a glenohumeral cuff tear arthropathy. If we want to bring this humeral head down, then that's really where we get our forescupples to act again normally. So all of our procedures, like a reverse, are going to get our forescupples back into order. And Mihata described this particular procedure that is called a superior capsular reconstruction in 2013. So what is this? This is basically anatomic reconstruction of the superior capsule of the glenohumeral joint. And biomechanically, what it does is it depresses the shoulder down and restores the normal fulcrum of the shoulder. What are the indications for this procedure? It has to be an irreparable posterior-superior rotator cuff tear in a young patient. So number one, it has to be someone who's symptomatic. If he is managing with just rehab, you don't want to do anything. It would have to be a large or a massive supra with infra tear because it needs to be a posterior-superior tear. There should be no significant cuff tear arthropathy. If the patient has already gone into a CTA, then there's no point in doing this procedure. So up to a Hamada stage 3 CTA is okay. At the end of your procedure, it's absolutely mandatory that you've got balanced transverse plane forescupples. That means your subscap and your infra or your teres minor have to be repairable. So if you have done your SCR for the supra and some amount of the infra, you at least should have been able to repair your subscap. If you've got an irreparable subscap, then this procedure is not going to work. Besides that, of course, a normal deltoid, because the deltoid is going to do the work of the shoulder, no significant bone loss, and no significant joint stiffness. What do? You take a graft, and that graft, I typically like the IT band. So you take a fascia lata graft, or you could take an allograft or a porcine xenograft, and you're placing this graft on the superior aspect here. So you're fixing it to the glenoid after freshening it. You're fixing it to the greater tuberosity like you would do a rotator cuff footprint repair. And then finally, you're taking sutures at posteriorly to the remnant of the infraspinatus. So let's see one case example. This is a 58-year-old female. She's had a symptomatic rotator cuff tear for over 2 years now. And then when she's severely pseudoparalytic, she presents to us. This is her dominant side. This is the right side. And you can see that she's in significant pain and she's got a significantly pseudoparalytic shoulder. When we get the X-ray done, you'll note that there is proximal humeral migration, but there's no cuff tear arthropathy as yet. Maybe a small little osteophyte coming in there, but no real significant cuff tear arthropathy as yet. And when you see the MRI films, you'll note that number one, you've got significant fatty degeneration of the supraspinatus. Number two, there is a subscap tear, the biceps is subluxated out. And the supraspinatus, there's significant tendon atrophy, so your tendon is lost. Now, of course, there's proximal humeral migration, but the cartilage looks okay. Now, in a patient like this, I'm always thinking, can I get away with a partial repair? Can I get away with a medialized single row repair? So I'll prepare them for an SCR, but I'm always going to try and do a partial repair and see what I can achieve. So this patient is starting off, and I'm trying to see how much I can get that rotator cuff into position. That's the biceps that's subluxated out. And we can see that there's a subscapularis tear too. The humeral head, the glenoid, not significantly worn out. So no significant cuff tear arthropathy. So I've done a very, released it from the subacromial space, released the capsule. And with this, I can get some amount of the infraspinatus to come towards the medial aspect of the tuberosity. So I know that I will do an SCR, but I will repair some of that infraspinatus. Now I start preparing the superior part of the glenoid. So my glenoid bed has to be prepared. So the entire superior part of the glenoid, you want at least 2 centimeters of the bone prepared out here. This SCR needs to heal on the glenoid surface. So you prepare this really well, make sure that your biology is good. Once you've done that, you're going to put 2 anchors on the glenoid, on the superior aspect of the glenoid. And these need to be about 1 centimeter from the joint line. These are double loaded anchors, and these are glenoid anchors. So typically I put in a 2.9 osteoraptor. So you can see that's the cartilage. You need to be at least 1 centimeter medial to the cartilage. And these 2 anchors, both anteriorly and posteriorly, go in. If you notice, the first one I took through the remnant cuff, whereas this one I'm retracting the remnant cuff, coming through the Nevacia portal and tapping this anchor in. So these are both double loaded. This is a little bit of a modification from what most other people do. And why is this? Basically, I'm doing this because I want this rotator cuff remnant to get stuck onto my SCR. I think this is really important because this adds to the vascularity. This is a good vascular remnant cuff, and this will heal in the this will aid in the healing process of that SCR on the glenoid. So what are we doing? We are basically taking one limb of this double loaded anchor through the remnant cuff. So anteriorly we took it through and then retrieved these 3. Here I'm putting a bird beak coming in through the Nevacia portal and taking in one limb of the suture. So basically you've got one limb of the suture through the remnant cuff, and you've got the other one free. So this is the glenoid part. We'll now see that we're looking at it now from the lateral side. So that's the glenoid. That's the 2 sutures there. You can see I've taken one limb, one bite through the remnant cuff here and one through the remnant cuff here. I'll then go ahead and finish my subscap repair and my biceps tenodesis. So I've tenodesed the biceps and I've done my subscap repair. And this is really critical. If you can't achieve a subscap repair, don't think of doing an SCR. It's not going to work. If your force couples cannot be restored at the end of the procedure, this SCR is of no use. Once this is done, then I'll put in my medial row rotator cuff anchor. Yeah. So I've got all of this ready. I've done my measurements. I'm now going to put my medial row anchor, and this comes at the junction of the articular cartilage and the greater tuberosity. This anchor typically will have 1 tape and 1 suture. I then go to the region of the fascia lata. So this is the proximal aspect of the hip. You take a lateral incision and you see your fascia lata and you take out a 12 by 4 centimeter strip of this fascia lata. And this will then be folded and tripled. So you want to fold it and triple it so that becomes 4 centimeters by 3 centimeters. And then each of the ends is sutured with a 2-0 undyed vicryl. And I leave a small loop out here so I can hold this loop when I'm introducing it in. Thereafter, outside itself, I'm going to retrieve the sutures, pass them through my graft, and then all I need to do is pull my graft in through the lateral portal. So I'll make my lateral portal about 1 centimeter or 15 millimeters in size, and then introduce my SCR graft inside. Now, when I'm doing that, you'll note that the medial 2 sutures are like a sling. So when you tighten it, that whole part slides into the glenoid. And once I tighten that, all I need to do is take my 2 remaining sutures, which had already passed through the remnant cuff, and tie that down. So now what have I got? I've got the remnant cuff sitting on top of my SCR, which is sitting then on the glenoid. So I think that a lot of the vascularity comes from this, and this gives it its really good healing effect. So take the anterior one, then take the posterior one. Once you've done that, you've completed the entire glenoid aspect. Once the glenoid aspect is completed, all you need to do is, like a footprint repair rotator cuff, these sutures need to then be put into a lateral row. And then finally, you'll take 2 sutures which will go into the remaining infraspinatus with the SCR graft. So you've got 1 suture there, 1 suture here. This is the entire SCR graft that we've got. And you can see the sort of space that we've created there. So that's the subacromial space. This is the footprint repair. We're looking at it from the lateral portal now. So this is the entire SCR graft. That's the medial aspect near the glenoid. This is the remnant cuff that's attached onto it. And laterally, this is the tape going down into the lateral footprint anchor. And you'll notice that this is the patient at about 2.5 months. She's already pain-free at 2.5 months, and she's getting most of her range back. And so this is typically what we see. I think even before the graft heals, it acts as an interposition. And because it acts as an interpositional graft, it pushes the humeral head down, and that really increases the force couples. And number one, it gives her pain relief. So that's why she's smiling out there. But most importantly, it gives her function. And if you were to look at the MRI at 1 year, that is what the SCR looks like. So that's a healed SCR at 1 year. It's healed here on the tuberosity. It's healed here on the glenoid. And this is the remnant cuff that we had sutured onto this. So then this amount of healing also takes place. I think this helps the vascularity. What's really nice is your acromio-humeral distance. So you've recreated this distance. It's acting as a good depressor. It's a trampoline pushing the head down. And that really ensures that your force couple of your subscap here and your infraspinatus here are able to then act and bring this arm elevated. This is also a great procedure, I think, for revision rotator cuff. So in patients who've had a rotator cuff repair, like this 49-year-old male with lower limb poliomyelitis, his arms are extremely important for him. This is how he ambulates. He had done his repair in 2009. He came to me again in 2016, and this time it was an irreparable tear. Again, with subscap gone, his biceps out, and I did an SCR for him. That's the SCR there. So I think it's a great procedure even for failed rotator cuff repairs, provided they don't have cuff tear arthropathy, they're symptomatic and they are young. I think it's a great procedure as a salvage too. Finally, how do they do in the long run? So we've been doing SCR since about 2013, and you can see this is the pre-op image of one such patient. See the X-ray at 2 years. So this is at 2 years. At 2 years, we still have a good amount of acromio-humeral distance, and this is at 5 years. This is her at 5 years, where at 5 years, she has full range of motion. She's got full external and internal rotation. So she's a really happy, pain-free patient even at 5 years. And you can see that, yes, there is some change here. She's got a small osteophyte now coming, which wasn't there in the past. But despite that small osteophyte coming in, the 5-year results we found are relatively good. They do maintain their acromio-humeral distance, which really gives them function. And this is the MRI at 5 years. It doesn't get resorbed. That SCR is still functioning well even at 5 years. So we've analyzed our first 30 cases with a minimum 1 year follow-up. This was done in last year. And we found that this helps not only in getting improved active range, it certainly improves the muscle strength. Radiographically, we've seen that there's an improvement in the acromio-humeral distance from the pre-op of about 3.9 to a post-op of 8.5, and this is at the 1 year mark. We have had 3 patients who have progressed as far as their OA is concerned. Graft tear or inflammation, we've seen in only 1 patient amongst the 30 cases. And this patient was the only patient that really, I think, failed his SCR. This was an allograft and probably an immune rejection, and that graft really completely resorbed over time. And we've had also improvements in the ASES scores from a pre-op 32 to a post-op of almost 91, which is, I think, fantastic for these young patients. So on the whole, SCR is a procedure that's relatively new, but I think it's catching up. And I think that it has a lot of potential, especially for young, irreparable rotator cuff tears where we have no other significantly good option as of now. Thank you.
That was a very, very nice, Dr. Dinsha, very, very nice demonstration of the SCR procedure and the difficult situation we come across so often, what to do in such. So we have a question from Dr. Raju Vash that again, he's very impressed by your talk, and he said that how you recommend, for beginners, can we do it as an open procedure?
To be quite honest, doing this open is a little bit of a challenge. It's difficult to get the glenoid part done open, because when you're doing the open procedure, everything on the humeral side is really very simple. but on the glenoid side is a little difficult. So I would suggest that you start off with a subacromial decompression, and then you put your glenoid anchors arthroscopically, because that is simple. You can put that very simply. Once you've got your glenoid anchor arthroscopically, the rest can very easily be done with a mini open procedure. With a deltoid split, a 5 centimeter deltoid split makes it an extremely simple procedure. So when you first start off, I think that's the way to do it. And surprisingly, you'll find it's not that long a procedure. I think our biggest time goes in the graft harvest and the graft preparation. So if you've got two teams working, one for graft harvest and preparation while you're doing all your preparation, it takes about an hour and 45 minutes, not more than that.
Okay. You any issues with the graft site morbidity or something?
Always very painful. Always very painful for almost about 2 weeks or so. And I think that's because we're doing it open. We've been exploring an endoscopic harvest of the graft, because when we do peritrochanteric scopy, that's the approach that you would use. The problem is that, again, it adds to time. So I think opening it quickly, doing it, getting the graft out, at least that's our standard of care right now. Morbidity-wise, our only issue has been pain. These patients are a little painful for almost 2 to 3 weeks. So that is an issue. In the series, we haven't had hematomas there, because often we put a drain, but reported hematomas and soft tissue infections at that site have been reported in the other series.
And sir, I believe the facial lateral graft would be the easiest and the big and the largest to be taken out than anything else.
See, the graft options today for us are the facial lateral graft, which, because it's autogenous, I think is the best graft. When you fold it 3 times and make it at least 8 millimeters thick, I think that's perfect graft. It will heal, no immune rejections. It's perfect. The only problem is time. So if you see a lot of the series which come in from the US and elsewhere, they use an allograft. And the allograft, it's predictable. It already comes to you. It's sized. You just have to cut it, put it in. It'll save you a lot of time. But at the same time, it's allogenic tissue. It's not autogenous tissue.
Yeah, exactly. I think we will have more questions after the last talk. Harmesh, I think we can have it after.
Okay, fine. Perfect.
So because we are positive time, there will be lots of questions from Dr. Dinsha. So I think we'll go switch to the last talk by Dr. Sham. I welcome him from South Africa. He has come on a very, very short notice, and he will be presenting on a very difficult topic, the biceps lesions. Dr. Sham. Can you share your screen?
Can you see my screen?
No, we are not able to. Just share it.
Hang on a second.
Dr. Harmesh, you can ask your question in the meantime he's sharing.
Okay, Dr. Dinsha, it was excellent preparation. Although I'm a non-arthroscopic surgeon, let me admit that. So it's going to be a very stupid question. Maybe it may sound. What is the pain generation in the first go? Why is the patient painful, and what takes the pain away by this procedure? I would like to know the basics.
Absolutely.
What is the pain generator in this case? Yeah.
So that actually is not a basic or a foolish question. I think that's the most critical question. I think our patients to come to us primarily for pain relief, and then number 2 for function.
Yes.
And where does the pain come from? I think the pain basically comes from the fact that there's proximal humeral migration. You've lost your forescupple, you've lost your supraspinatus, which acts as a humeral head depressor. Now, as soon as you've lost that, the humeral head starts proximally migrating, it starts hitting the acromion, and then that creates the pain, creates the bursitis, creates the inflammation. Now, as soon as we're putting in SCR, why do these patients land up with immediate pain relief even before it's healed? I think it's the interposition graft effect of that SCR. It's keeping the humeral head about 8 to 10 millimeters away from the acromion. I think that's the number 1 cause of pain relief. We've also seen in inflatable balloons, which are similarly used for this. I think that also gives it the same sort of effect. As soon as you bring that humeral head down, your pain has gone. Now, once it's in the fulcrum, because your subscap is repaired and because you've got either teres or infraspinatus that you've repaired, your forescupple is there. So with the humeral head being depressed and your forescapula anterior to posterior working, you've got function then coming in. So I think that's the dual effect of SCR.
So just a small question. Once SCR fails, in case it may fail, obviously any procedure can fail. So what are the options, bailout options? What do you do then? Those patients who fail SCR.
So we've had one patient who's failed in the last 5 years. He opted not to undergo a revision SCR. But in most of the series where they fail, it tends to fail on the glenoid side. On the humeral side, there's a big footprint, so it always heals. On the glenoid side, a lot of the surgeons tend to put only a single anchor in, or sometimes a single row, 2 anchors. I think maybe that's not enough. You need to really prepare the entire footprint on the glenoid, as you saw in that video. Put in double-loaded anchors, do a good fixation there, add the remnant cuff onto the SCR. I think that's the best way to get healing. But if you had to do a revision SCR, those have been also reported. Though I think it's a daunting procedure. And at the end of the day, a patient who fails an SCR, the only option that would be left is if he's retained some amount of range, you can think of a tendon transfer, a lat dorsi tendon transfer.
Do you consider revision sort of reverse also in these cases?
If the patient is older, so if it's a patient over the age of 65 and he comes to me with an irreparable rotator cuff tear which is painful and dysfunctional, my first choice would be a reverse total. I wouldn't even offer him an SCR.
But if SCR has failed, then also revision is one of the options?
It is an option. It is an option. But a lot of these patients are 48, 50, 52. And so the a reverse can be done in anyone at the end of the day. It's going to give them a good procedure, a good result.
So my worry is you have taken away almost 2 centimeters of the superior glenoid cortical bone. So if he needs a reverse shoulder, so does it hamper the reverse fixability?
Not at all. Not at all. So remember that when you're freshening the superior part of the glenoid, you're not truly taking out the cortical bone. You're just roughening it.
Okay.
And all of the base plates for the reverse will always come on the lower part of the glenoid.
Okay.
So you'll find the base plate always is on the lowest part of the glenoid so that you don't land up with scapular notching. So on the superior part, no problem at all.
Okay. Thank you so much. Thank you so much.
Thank you. I think, Ramesh, I think we will go ahead with the next talk. We are overshooting.
Sure.
We have lots of questions for Dinsha coming. I think we can ask later on.
Yeah.
Deepak, can you see my screen?
Yeah, we can see clearly. You can start.
Thank you so much for the Delhi Orthopedic Association for inviting me to give a talk to you guys. I come from Durban, which is on the east coast of South Africa. It was the first port of call all the Indian laborers brought to South Africa 150 years ago. My talk is on the long head of the biceps, and we should understand the anatomy. The tendon is 9 centimeters long. It's the long head of the bicep we're talking about, and it has about a 5 to 6 millimeter in diameter. Now, the important structures is basically the intra-articular anatomy. The biceps arises from the supraglenoid tubercle or the labrum, but as it exits out the joint, this is the main area that we have to worry about. This constitutes the medial pulley and the lateral pulley. And these are made up from the superior glenohumeral ligament, the coracohumeral ligament and subscap on the medial side, and the coracohumeral ligament and supraspinatus on the lateral side. Now, when you look at it, the roof of this pulley system is made up of the coracohumeral ligament, and this is also important in maintaining the stability of the biceps. So this is an important factor to consider, because when you look at the extra-articular anatomy, the biceps lies in the biceps groove, but it creates a 30-degree turn as it enters into the joint to go to the supraglenoid tubercle. And this is the critical area where the injuries to biceps occur. Now, on the biceps groove, you have a transverse humeral ligament. This relatively serves no purpose in stability for the biceps, but it has a rich network of sympathetic nerves as well as branches from the axillary nerve, and therefore is a cause of a pain generator for these patients. Now, clinical presentation of biceps, they usually present with anterior shoulder pain. These are usually aggravated by overhead activities and lifting activities, and some patients complain of a popping or clicking when they're up in the throwing position. This suggests biceps instability. Now, when you look at clinical tests, groove tenderness was the most reliable clinical test in diagnosing biceps pathology, and an ultrasound-guided injection also had high diagnostic capabilities. The clinical test you're well aware of, and O'Brien's test is important to do to exclude a slap lesion. MRI is useful to identify pulley lesions, instability of the biceps, and cuff tears. Unfortunately, it is not very specific for subscapularis tears, and therefore it has a poor correlation in terms of diagnosing intrinsic biceps pulley lesions or subluxations compared to arthroscopy. Now, when you do an arthroscopy, you look at from the posterior portal, and you can pull the biceps almost all the way into the joint. So you can have a good look at the tendon. This will tell you the superior and inferior surface of the biceps. And if you see a fish scale appearance, this is highly suggestive of a biceps tear, which is different from a rotator cuff tear. What disorders do we have for the biceps? These are essentially inflammatory, traumatic, or instability problems. Inflammatory is primary or secondary inflammation, whereas traumatic injuries result in biceps rupture and slap lesions. So primary tenosynovitis is uncommon. It only occurs in about 5% of patients. The synovitis is isolated to the tendon, and you will see what's called a lipstick sign as you pull the biceps into the tendon, into the joint itself. Untreated primary tenosynovitis will lead to tendinosis and subsequent degeneration of the biceps. If you get tendinosis, you may get thickening of the biceps, and this results in an hourglass biceps deformity, so much that the biceps does not enter the biceps groove, and therefore in flexion, the biceps will buckle in the joint because it's not sliding on the humeral anymore. Secondary inflammatory or secondary tenosynovitis is more seen when you have other associated pathology, as in a frozen shoulder seen here. So the inflammation is not isolated to the tendon, but is generalized. These may also be secondary to mechanical problems like pulley lesions and cuff tears, which then leads to tendon fraying and degeneration. So you can see you can either have isolated fraying or significant fraying involving the longitudinal length of the bicep tendon. So trauma can either be acute, and usually this presents with a rupture, but it could be due to repetitive injury. So if you see the picture on the right, the biceps sits at 30 degrees to the mid-axis of rotation of the humerus, and therefore there's a tendency for the biceps to bear down on the lesser tuberosity. And therefore any rotational exercises would bring damage to the biceps and pulley region. So we see this a lot in swimmers and overhead throwers. They may have a spectrum of pathology such as tenosynovitis, and primary tenosynovitis is seen more commonly in this group, and they may have tears, instability, and other associated lesions. Bicep subluxation is when you get damage to the pulley. You see the medial pulley plays an important role, and if you get disruption of the medial pulley, the biceps will now sublux immediately. This is not always visible, but an ultrasound can give you information on this. When you're doing an arthroscopy, forward flex the arm and bring the arm into slight internal rotation. This will allow you to bring your camera into the biceps groove itself. And this is where you'll see hidden lesions. If you have more significant tearing of the pulley as well as the subscap, the biceps will now dislocate into the subscap, creating a tear of the subscap and subluxation of the biceps. If you have a full thickness tear of the subscap, the biceps will now dislocate fully medially, and you see on the picture on the left that the biceps now looks like the MGHL. If you have disruption of the hood of the pulley lesion, and without a subscap tear, the biceps will now sublux anterior to the subscapularis. Lateral pulley lesions are seen when you have an injury to the insertion of the supraspinatus, as seen in this case here. They're usually seen following fractures, anterior dislocations, or supraspinatus tears. If you see a sentinel sign, this is when you get abrasion of the anterior part of the biceps. As seen here, you'll see that only the anterior part of the biceps is affected, and this is a suggestion of a subscapularis tendon tear. We know to diagnose subscap tears by clinical examination. When you're doing arthroscopy, though, you need to pull the humeral head back posteriorly to allow you to see the subscap footprint. Now, what are the indications for surgery for biceps? Of course, if you have failure of conservative management, if you have tendon degeneration, tears, or an hourglass biceps, slap lesions have now treated more commonly with tenodesis than repair, and pulley lesions with instability and subscap tears requires a biceps tenodesis. So you have tenodesis versus tenotomy. These are the two common operations performed for biceps pathology. Multiple meta-analyses have shown that there is no significant difference in functional outcomes whether you use a tenotomy or tenodesis in patients. However, we know that tenotomy is quicker to do, it's cheap, it's simple, and the recovery from this is quick. However, the Popeye deformity is apparent in 60 to 70% of cases, and they have fatigue and cramping on excessive use of the arm. They are minus reduction of strength of supination in the forearm. And therefore, this will not be tolerated in a manual worker or somebody who is very muscular. Tenodesis showed better strength and return to sports, but they are associated with other complications, such as hardware complications in fixation, increased operative time, increased operative skill, and longer return to sports. However, there was no significant functional differences in both these techniques. So tenotomy is quick and cheap to do. You can use a cold knife or a hot knife. Is therefore indicated in the elderly or not very active patients, or in those where the Popeye deformity will not be noticed. Tenodesis, however, will be indicated in the other group of patients, and these can be done either intra-articularly, suprapectoral, or to the adjacent rotator cuff repair, and these are all arthroscopic techniques, or you can do an open subpectoral tenodesis. So intra-articular tenodesis, we would indicate for slap lesions or minimal localized fraying of the tendon, and with this we use a loop and tack technique. So if you follow the screen from the left, you create an initial cinched loop, another limb is taken, and then pass through the tendon, and this will secure fixation to the tendon at that spot. The tendon is then fixed with a knotless repair just distal to the articular margin of the humerus and above the biceps groove. Results from a loop and tack suture technique with non-absorbable or knotless anchor fixation, 91% good, excellent results in this paper with no Popeye deformity. But they did have cramping. And therefore, we would consider a suprapectoral tenodesis in patients who have biceps instability and those who have significant fraying of the tendon. If those who prefer knotless fixation, we would use an inlay technique. This is an interference screw fixation, which shows high pull-out strength and good biomechanical pull-out strength itself. And the fixation is done in the biceps groove. So step one is to apply a suture to the proximal biceps to maintain tension and length. The biceps is then tenotomized. A sizer is then used to measure the diameter of the bicep tendon. We then use a drill. The drill is usually 0.5 to 1 millimeter larger than the diameter that you had measured. A bicep swivel lock here is used to then insert the biceps into the tunnel while holding tension on the proximal suture. Once this is done, an interference screw is inserted, and the interference screw is laid slightly proud to the bone to show cortical fixation, and the excess tendon is then resected. So this is an interference screw fixation. You see a bicep tendon lying in the groove, resection of the transverse humeral ligament to avoid any pain post-op, and a prominent screw, and you can see the secure fixation where the patient can actually be lifted off with the interference screw in place. However, we have seen problems with interference screws. We had fixation failure and avulsion of the biotenodesis screws, and these led to Popeye deformities in up to 30% of the tenodesis group. This was unacceptable. The Popeye may only also occur by the killer turn that we do when we put the interference screw. So most ruptures would occur at the mouth or entrance of the interference screw tunnel. And the failure that is poorly tolerated due to tendon lengthening following this. So what about an onlay technique? We would initially prepare the groove, braid it down, and lightly decorticate this area. We use a double-loaded anchor. This can be any kind of anchor that you want to use. We then pass lasso loops into the tendon, and this is repeated with a second suture. And the lasso loops show significant cinching or catching of the tendon and a quite secure fixation. To increase this fixation, you might add a second anchor above your initial lasso loop techniques and knot tying, and use a cinch loop with a knotless anchor. This can also be done with a new all suture anchors, and in this, because of the small size and diameter, we can actually put two anchors using lasso loop techniques as well. But if you have extensive degeneration or fraying of the tendon in the biceps groove, you will now need to consider a subpec tenodesis. Also, you do a subpec tenodesis for revision cases. So subpec tenodesis, like a Latarjet, is not a simple operation. The location of the subpec anchor, subpec tenodesis, the anchor is inserted at the lower border of pec. Remember, the biceps lies medial to the pec major tendon. And it's important to understand that the brachial plexus and the musculocutaneous nerve is very close to the area that you'll be working on. So we make a incision, initially was described along the axillary line, but if you're doing this for the first time, I would suggest that you go right up to the end of the pec major insertion and make your incision in this region, because that's where the biceps lies. When you're dissecting, make sure that you always stay lateral to the conjoint tendon. This will avoid any injury to the musculocutaneous nerve, and to avoid further injury to the musculocutaneous nerve, use blunt retractors on the medial side and sharper Holman retractors on the lateral side. When you're doing a subpectoral tenodesis, your initial step is to do a biceps tenotomy and deliver the biceps tendon into the wound. A width stitch is then applied to the tendon because the failure is at the tendon suture junction and not with the interference screw fixation. You drill your tunnel at the inferior border of the pec, and this time I would always drill it 1 millimeter bigger than the diameter that's measured. This is because you're dealing with cortical bone, and because of that reason, you'd also need to use a tap before you insert the screw. To achieve a good cosmetic result, the muscle or the muscle tendonous junction must be at the level of the inferior border of the pec. However, this is not easy operation and has associated complications. The biggest complication is a fracture through the drill hole. This is usually from rotational forces on the arm. So to prevent this, ensure that the tunnel is middle of the shaft on the AP diameter of the humerus. Otherwise, you could use an onlay technique like we did in the proximal area and use a unicortical fixation by using something like a pec button. You drill unicortically, insert the button initially, and then the button, sutures on the button are then used to tie down the bicep tendon. And in this case, the tenotomy is done after the tenodesis so that you will maintain accurate anatomical length to this technique. So in conclusion, the groove tenderness is a good diagnostic sign. Careful assessment of the pulley lesions and subscapularis must be done at the time of arthroscopy and at the time of initial investigations. It's been shown that tenotomy and tenodesis have similar outcomes in terms of function for the patient, and the location of the tenodesis, whether it's intra-articular, suprapectoral, or subpectoral, or the fixation methods used, have no difference in outcomes. So this is your choice. Therefore, arthroscopic tenodesis is an attractive surgical option because it's right there where you're working. It's easy to do, and with adequate skills, this is the preferred option. However, subpec tenodesis is done in revision cases, and you should be able to do this to get good results. We mentioned donating to the superior capsule, and now we'd say, don't kill the biceps, because you can use that as a superior capsular reconstruction. So thank you very much, and I hope you're happy with this talk, or you're not. Thank you very much.
That was very, very nice talk, Dr. Sham, and it's a self-explanatory talk. Lots of information on the biceps tenodesis. I think we have overshoot the time a little bit. It always happens. We can have 1 or 2 quick questions, and then we can hand over to chair.
Dr. Deepak, can I ask one, please?
Yeah.
Thank you. My question would be, so what do you, how do you fix, I'm talking of subpectoral fixation in a degenerated tendon, which doesn't come up to either the tubercular groove or intra-articular. So what best can be used for the tenodesis? Because we cannot drill anteroposteriorly because of the radial nerve, which is lying in the posterior radial groove. So what implant or what technique do you use to do tenodesis, to fix it well?
We're talking about subpectoral tenodesis, I assume?
Absolutely,
yes,
absolutely.
So
yes.
yeah, I avoid using an interference screw because you need a larger diameter to put the graft into it. So I would use a peg button. You could even use all suture anchors, which only require less than 2 millimeters drilling into the bone. You place your anchor in first, and then get the tension right on the onto the pec muscle and tendon, and that is your point of fixation. Remember, the fraying would be only in the first 5 to 6 centimeters of the tendon. So when you come into the subpec region, there is no fraying there, and you fixing the muscular tendons junction onto bone. So yes, don't drill through the humerus, just drill unicortically.
Oh yeah.
Yeah. Thank you. I think, Dr. Sham, I'll ask Dr. Arya to make the closing comments on the shoulder session.
Thank you very much, all. I think it's been a nice discussion. Only thing I would have loved to have a little more time for question answer, because I myself am left with a lot of questions. It's all thought-provoking presentation by all. But nonetheless, I think we have still a time for next meeting, a similar meeting where we can sort out two issues. I think we should hand over for the next session on knee. Thank you all.
Thank you, Dr. Arya, for such kind words. Thank you, Dr. Arya. So, and thank you, Dr. Deepak Joshi. I request now Dr. Sameer. Dr. Sameer Mehta.
Yes, sir, I'm there.
Yeah, please introduce the speakers and the panelists, and you can start.
Yeah, thank you very much. Thank you, Deepak. You've been still been very kind.
Yeah.
For winding up almost. Dr. Bhasin, sir, welcome. Nice to see you. So let me introduce my faculty. The first lecture is by Dr. Dinshaw Pardiwala from Mumbai. He's already been introduced. And Dr. Dinshaw, I must tell you that when we were preparing for this program, and Deepak and me never consulted about which faculty to be invited. So you can see how much you are loved here, that both of us invited you separately. So welcome, sir. We know he doesn't need any more introduction. He's the head of Arthroscopy Division, Sports Medicine at Koklaba and Dhirubhai Ambani Hospital in Mumbai. And I've been fortunate to see him work in his OT with his patients at close quarters. So that was a nice experience I always carry with me. So welcome, sir. The second speaker is another a very veteran orthopedic surgeon, well known in India and abroad. He is Dr. Raju Vaish. He's a senior consultant surgeon at Apollo Hospital in Delhi, and he's been editor-in-chief of JCOT and JASSM journals. Under his editorship, we have done record publications this year, and this is another record that he has besides many others. He's a member of publication committee at the CICOT. He's a past president of Indian Cartilage Society. In fact, my introduction to the cartilage and all these teaching happening was through his teachings in various platforms. He has more than 450 publications, which is massive. And he's a BC Roy prestigious awardee. He has featured in Wikipedia, and he has Limca and Asia Book of Records. And for that, you'll have to visit the Google to see what all records he holds. He has operated and done replacements in the oldest patients of around 93 or so aged patients. So welcome, sir. Nice to have you as a faculty, and thanks for taking an invitation from us. The third senior faculty is none other than Dr. V.B. Bhasin from Sir Gangaram Hospital. Again, he doesn't need any introduction. He's been there for too long. He's been there for how many decades, sir? As many decades. And he's been a pioneer in this side of the country, in Delhi. And most of us have learned, and I've been fortunate to enter his OT and see him work. And one thing about Dr. Bhasin is that he's a different way of working. He has he's developed his own techniques, his own way of doing things, which are very different what we are taught or we're told by the various companies all over. So Dr. Bhasin, it's welcome, sir. It's a privilege to have you here. Besides his August faculty, we also have Dr. Dhananjay. Dr. Dhananjay, are you there? Dr. Dhananjay Sabat is a yes, he's there. He's a senior consultant, associate professor in Maulana Azad Medical College. Dhananjay is our literary head, we would say, because he has a lot of many publications. He time and again in WUMEDI and various other fora, he develops, he submits his well-devised new techniques of his own, and which are well accepted and look forward to. So, Dr. Dhananjay, welcome again. Third, another speaker would be myself, and I would not like to introduce myself, and I would talk on meniscus repair. We have August faculty in panelist, which is Dr. Monu Singh, already introduced by Dr. Manish Dhawan. He is a past vice president of DOA. He is a senior consultant at Narayana Super Specialty Hospital, Gurugram, and he's the chief of services of arthroscopy and joint replacement. Dr. Monu Singh, welcome, sir. Dr. Manocha, well, I think now we can say that no seminar or webinar is complete without Dr. Manocha's presence. His questions, his deep insights, and his discussions are really fruitful, and we look forward to it. He's the head of department at Central Railway Hospital at New Delhi, and he specializes in complex trauma, arthroscopy, joint replacement, and all other procedures that you can name off. So welcome everyone, and thank you for taking our invitation. So the first talk would be from Dr. Dinshaw Pardiwala, and he's going to talk on acute knee dislocations, a favorite of anybody, any orthopedic surgeon, not just scopy surgeons. On to you, sir.
Thank you, Samir. Samir, you got my screen there?
Yes, sir, very much.
Perfect. Okay, so I'm going to cover very quickly acute knee dislocations. And as all of us orthopedic surgeons know, traditionally, knee dislocations were classified based on the position. So this is the old Kennedy's system. And in this, we had the anterior dislocations, the posterior dislocations, the true medial and lateral dislocations, and the complex rotatory dislocations. But the problem with this classification system was that a lot of these dislocations actually self-relocate or reduce by the time you come to the surgeon. So it was impossible to say what sort of dislocation it was. But if the patient did come in a dislocated state, then you could predict based on this dislocation that something like an anterior, well, 30% of these will have vascular injuries. Something like a mediolateral usually will be associated with the common peroneal nerve palsy. So you could make other associations based on this traditional classification system. But because of its deficiencies, Schenk then came out with the anatomic classification system. And I think this is really important to understand because most of our communication and discussions today is done with the Schenk. And in this, you've got the KD1 to the KD5. And 1 basically means that 1 ligament is deficient. 2 means 2 ligaments are deficient. So like this patient has had an anterior dislocation with a sleeve avulsion of the collaterals. So when you reduce it, mediolaterally he's stable, and all he's got is a bicruciate deficient knee. So this is really a KD2. A KD3 would mean ACL, PCL with the MCL. KD3 would mean ACL, PCL with the PLC. KD4 would mean all 4 ligaments gone, and KD5 means an intra-articular fracture along with ligaments being torn. So this makes it easier for us to discuss knee dislocations. Now, a lot of people will say, how can you get a knee dislocation and get only 1 ligament torn? Well, these are relatively rare, but these are case reports where you could land up with a subluxation or a dislocation, and ultimately it's only the PCL which is deficient. What's important with these knee dislocations is not just the ligaments. I think it's a really important topic, primarily because of the associated injuries. When you get a knee dislocation, if it's a high velocity knee dislocation, 50% of these patients will have a vascular injury. And if it's a low velocity, you could also land up with a small little intimal injury, something like this, where this is a rugby player who's had an ACL, PCL, MCL. You feel his pulses are okay, but when you do his vascular study, that's what it looks like. So a small little intimal injury to the popliteal artery. So you can get many forms of vascular insults with knee dislocations. Also the soft tissues. So when you get a high velocity knee dislocation, you can get a very severe soft tissue disruption, a sleeve internal degloving. So all of this makes it more challenging. And especially if you've got open knee dislocations where the whole thing is ruptured, these are the ones which really give you a problem from soft tissue envelopes. Another aspect I think that is important is in all of these classifications, we never discuss the patellar tendon or the extensor apparatus. And there are many patients that we see who also have disruption of the patellar tendon. So this is something that you need to look out for with these high velocity knee dislocations. Finally, periarticular fractures, bony avulsions. So you could get a KD3M like this, which is a ligament avulsion, or you could get a big osteochondral fracture, which is a true KD5. So different sorts of methods then have to be applied because now you're dealing with a fracture and a dislocation. And finally, remember that you could get polytrauma also, and polytrauma is probably one of the reasons why some of these knee dislocations are neglected. So like this patient had an anterior dislocation of the hip. This was reduced. He had a knee dislocation, which fortunately self-relocated and was referred to us only about 2 months later with this. So as soon as you see that scar there in the front of the knee, you know that he's had a dashboard injury there. And when you really examine the knee now, you know that yes, he's got a PCL, PLC, and he did have a knee dislocation or a subluxation. So sometimes these are missed injuries just because of other more major trauma in the same limb or in the body. So how should you proceed with a patient who lands up with to you with an acute knee dislocation? So the first thing is when he comes to you, he's going to have a deformed limb like this. You would ideally like to reposition this. Don't do a formal reduction, but at least reposition it so that your neurovascular bundle, if it's being pressed upon, or if your soft tissues are being compromised, at least that becomes a little in position. So quick clinical assessment of the neurovascular status, feel his pulses, quick assessment of the soft tissue cover and the associated injuries, and then try and get in any trauma A&E, you're going to have a C-arm there. Try and get a quick confirmation of the type of dislocation, because sometimes you could get intra-articular fractures or tip condyle fractures, which would look exactly like this. You don't want to try and do a formal reduction maneuver. So once you've done a gentle repositioning, sometimes when you do that gentle repositioning itself, it is going to reduce. Then get him into the OR. And I would prefer, if the patient is starving especially, to do an emergency close reduction under GA, because what this does is it gives me the opportunity to do a good examination under anesthesia. So you examine for all the ligaments, ACL, PCL, PLC, MCL, very quickly once after the reduction, and this gives you a good idea on how you're going to progress. If you've actually managed to get a reduction with your repositioning of the limb, you don't require to do a GA or a EUA. The next step, which is I think critical in all patients who've got multiple ligament knee injuries, even if they've come to you reduced, if you found that he's got a PCL, PLC or an ACL, MCL, do his ankle brachial index, ABI. This is really simple. So what is ABI? Basically, you want to get the systolic blood pressure in the injured lower limb, so that's at the ankle, divided by the systolic blood pressure in the uninjured upper limb, and that's brachial, and this gives you your ankle brachial index. Now in the lower limb, I prefer to do this with a Doppler, but if you don't have a Doppler, just do it with your standard palpation technique, and that would be good enough. If your ABI is less than 0.9, this indicates that he has some vascular injury, and it's worthwhile that you do some vascular study. If his ABI is 1, then you know, or more, you know that then it's very, very unlikely that this patient has a vascular injury. And this is something that you can do sequentially. So you can do this on presentation, you can do this on day 1, you can do this on day 2, whereas you can't do arteriograms on day 1, day 2, day 3. At least this is a simple little test that you can do, which will save you from a major complication in case this patient lands up with a late thrombosis because of an intimal injury. So some surgeons prefer to do a vascular study for all of their patients. And if you have that facility, then great. But if you don't, at least do an ABI. And if the ABI is less than 0.9, you certainly want to do a vascular study, either do a formal arteriogram or a CT angio or an MR angio, or at least an arterial color Doppler, so that you know the vascular status of that limb. That is more important than jumping onto the ligament straight away. And finally, you need an MRI, because an MRI will tell you a lot more about the bones, about the soft tissues, about occult fractures, of course, about the ligaments and the menisci. And then once you've got all of this information regarding the soft tissue cover, about the bones, about the ligaments, about the neurovascular status, I think you're ready to go ahead for your treatment. Now, your treatment, why is knee dislocation so complex? It's complex because there's so many different types of knee dislocations. There's so many different scenarios, and you need to understand this so that you can deal with each of these heterogeneous dislocations a little differently. I'm going to try and make it a little simple for you, but in case you want to go back and read something, this is a very simple chapter that we've written in this book, Complex Knee Ligament Injuries, which discusses each of these different sort of options that you have and the algorithm. So for me, once I've done my evaluation, my patients will fall into either of three groups. There's one that requires emergency treatment. There's the second that requires an acute phase treatment. And there's the third that requires, which come to you chronic. And those are, of course, the chronic phase treatment. So we won't talk of chronic since that's not our topic today. So emergency operative treatment in an acute knee dislocation is only required in 6 different scenarios. And let's see these one by one. So the first is if there's a vascular deficit. So if there's a vascular deficit, something like this is going to require emergency management. Get your vascular surgeon in, and he may opt then to open up and then do either an end-to-end repair or a vascular anastomosis. But you need to restore the vascularity to that limb and save it. At that time, based on what the soft tissue cover is, you could use that opportunity once revascularization has been achieved to at least achieve some capsular repair or MCL or PLC repair. If you're not too happy to do it at that stage, leave it alone. You can always manage it later. The second is open dislocation. So when you've got an open dislocation, of course, you're going to reduce it. But this is a situation where, again, you need to get a good soft tissue cover. Either you do a primary closure with antibiotics after a good debridement and wash. A plastic surgeon needs to do a cover, may require an external fixator. So you need to approach these immediately. If your extensor apparatus is ruptured, like in this patient, then you must go ahead and fix that primarily. And during this procedure, you may actually get a good capsular repair and do whatever extra-articular repair you can do. But of course, no ligament reconstruction of ACL or PCL at this stage. The third is an irreducible knee dislocation. So say you get a posterolateral knee dislocation that's irreducible, and you find that you can't reduce it in. This is usually because of MCL invagination. And this is what your X-ray would look like after the attempted reduction. If you were to do an MRI, you'll note that in that MRI, that MCL has invaginated in the joint. Your MFC, your medial femoral condyle, has buttonhole, and that's why it's irreducible. This again is a relatively urgent situation to an open reduction. And when you do this, as soon as you've taken that medial incision, you'll find the medial femoral condyle just popping out. And that's the MCL inside. You actually make the valgus further, so you accentuate the deformity, pop that whole MCL out, it'll come out like a sleeve, and then you do a primary MCL repair. You could opt to do all the rest of the stuff later, because in an emergency situation, you want to keep it simple and clean. If you have compartment syndrome, then you'll need to do a release. If you've got an extremely unstable knee joint, you may require to put an external fixator to maintain the reduction. It may not be possible in just a splint. And if you've got a knee fracture dislocation, then again, always deal with the fracture primarily. But if you can repair the extra-articular ligaments, the MCL, the PLC at the same stage, I think it's worthwhile, because then once the fracture is united, you can always go down subsequently for your ACL, PCL reconstruction. As far as the acute phase surgery, so it's, say, not an emergency, you immobilize the limb in a slab or a knee brace, give it a few days, and between the 7th to the 10th day is probably the best time to then take care of these patients. Now, you have different options based on your experience, on your infrastructure. You could either opt to do a single stage, everything in one shot. So single stage cruciate reconstruction with collateral repair or an augmented repair. If it's very early, 7th day, 8th day, you want to do this as an open. You could opt to do this staged, where you do just the collateral repair primarily, and then secondarily you do a cruciate reconstruction. And in some patients, you're going to have to delay the whole thing, as I'll show you, and then do everything at a later stage. So let's see the first scenario. So this is a complex rotatory dislocation. This is a KD3M. So ACL, PCL, MCL is gone. This is a young player and he's got an extremely unstable limb. In someone like this, I would prefer to do this all as a one-stage open. So go ahead and do the ACL, PCL reconstruction as an open procedure and do his primary MCL repair. And I think this then gives you a great result, but it has to be a male young patient who's going to do good rehab, because otherwise there's a risk of arthropfibrosis and stiffness developing in these patients. And if you look at this particular patient, we'll see his 20-year follow-up or 18-year follow-up. This is someone I dealt with, I think, in 2001. This is a true lateral dislocation, extremely unstable. He's a kabaddi player. He had all 4 ligaments gone. I had to do it primarily as a single stage open. And this is his 18-year follow-up. This was, I think, about a year back that we saw him. Full range, back to kabaddi, no osteoarthritis, and a very stable knee. Because what you've done is you've taken care of everything in one shot. And therefore, you don't have the risk that because you're rehabbing this knee in the absence of an ACL, PCL, or MCL or PLC that you've repaired, will get stretched out. But this is a daunting procedure which requires good rehab. So if you're in any doubt, if your patient is not going to be with you for your rehab, it's better to stage these patients. In the acute stage, do just the collateral repair. And then in the second stage, you can come down for your cruciate reconstruction. And in the first stage, you can do an open MCL repair, or you can do an open PLC repair, or if there's a peroneal nerve palsy and you're planning to do a neurolysis, you can do a neurolysis with a PLC repair. Or if your patellar tendon is gone and this is all you want to deal with in the first stage, just do a patellar tendon repair. And then in the second stage, once that has healed, then you can come down for your arthroscopic bicruciate reconstruction. But you must remember that in this interim where you're waiting for 2 to 3 months, please brace him, because if you don't brace him and you're rehabbing without the 4-bar cruciate linkage system of the ACL, you could cause an unnecessary stretch on your repaired MCL or PLC. But sometimes this is a better way to do it because this decreases the risk of arthropfibrosis. You're doing it in the acute phase as a repair because that's the best time to achieve a repair, allowing the range to come back in a protected fashion, and then 2 or 3 months down, you go and do your bicruciate reconstruction arthroscopically, which is a relatively safe and simple procedure. So here, that's the ACL. We're looking at it from the posterior portal now, ACL, and that's the PCL there. There will be some scenarios in which you need to do a delayed sort of surgery. So this patient is one of those case examples. So he's a 20-year-old, he's an obese male, he's fallen off his motorcycle, and he's had a knee dislocation with a patellar dislocation. Now, he's not from my city, so he was reduced by a surgeon. He was put into a long leg brace and then sent to me, and he came to me about 10 days later. And when he's come to me 10 days later, he's in a reduced position. He's got laxity of his ACL, his PCL, and his MCL. And what we saw was a significant amount of cast swelling with ecchymosis. His MRI showed that he'd got ACL, PCL, MCL tear, but he'd also got a locked bucket handle tear of the meniscus. So that's his medial meniscus with a locked bucket handle tear. And he's got all this tibial part was all right, popliteal artery all right, but he had a significant acute DVT. Now, in the presence of an acute DVT, I don't want to go ahead and do ligament reconstructive surgery with a tourniquet. So I'm going to do the absolute minimum possible. So without a tourniquet, very quickly, I reduced his medial meniscus and repaired his medial meniscus. So that's it. And then put him into a sling, into a splint, protected him, allowed that medial meniscus to heal. And once his DVT was out of the way, at 3 months, I'll go down now for his actual ligament procedure. And at this stage, I'm going to do everything. I'm going to do all his 3 ligaments as reconstruction. So the first thing, we're looking at the medial meniscus, and that's the healed medial meniscus repair. But as you can see, his medial joint space is opening up tremendously because, of course, we've done nothing for their MCL. And although we put it into a splint, we know that these really shattered ACL, PCL, MCL, the MCL is not going to heal. So once we confirmed that the meniscus was all right, then we went ahead with a single stage arthroscopic ACL, PCL reconstruction. So that's his ACL with an internal splint. That's his PCL. So we finished the ACL, PCL reconstruction arthroscopically. And once we've done that, we've gone ahead with an anatomic MCL and a posterior oblique ligament repair. So in scenarios where you can't tackle this, though the patients come to you acute, you can't tackle it in the acute phase, you would have to go for a delayed sort of reconstruction of all of the ligaments. So in conclusion, I won't go into the details for complications because this itself is a big daunting topic. But if you'd like to read this, we've written this up in detail in the Asian Journal of Arthroscopy just earlier this year in the Jan 2020 issue. The main thing you want to deal with is this, that if you're taking care of an acute knee dislocation, make sure that you've at least reduced it and kept it in a good position. And if you're doing a staged surgery, make sure that in between it doesn't dislocate. You don't land up with scenarios like either this, A or B. If the patient comes to you where he's been reduced and then in the plaster, the reduction is lost, and then you put him, immobilize him in that unreduced scenario, you're going to land up with something like this, which is really a headache. This is a fixed posterior subluxation or a dislocation, which then comes to you 2 or 3 months. And then to try and take care of these in the chronic phase becomes an extremely daunting task. So you can land up with many complications, but if you are a little careful with these acute knee dislocations, you should be able to manage this minefield and get out safely. Thank you.
So thank you very much. In fact, this is a topic where I would say everybody would have many questions, from downright PG who deals with such situations in emergency to the senior consultants who really reconstruct. So sir, I'll start with my question. What would be your graft choices in a case of ACL, PCL, MCL, PLC, and also MPFL reconstruction scenario?
Okay, so I think that's the beauty of doing these in the acute phase. So if this patient comes to you acute, the question is, why do we want to take them up early? If you take them up early, you can achieve a good repair of the MCL and the PLC. So if you achieve a good repair of the MCL and the PLC, your options for graft then are only for the ACL, PCL, and maybe the MPFL. But in case, as you're describing, if someone comes to you late, then what are our graft options? So my graft options are, I use the quadricep tendon as a double bundle for the PCL. I think that's the most important. So a double bundle PCL, quad tendon, that's great. I then will use the ipsilateral semi-T and the gracilis as my next graft option. Semi-T can be used, and the contralateral semi-T and the gracilis. So you've got all of these options. In today's day and age, fortunately, I've got access to allografts. So having access to allografts, anytime I'm in a little bit of trouble, especially if it's a delayed phase, I would use an allograft ligament to try and get these 4 ligaments done. But the typical options, quadriceps tendon, same side hamstrings, semi-T and gracilis, opposite side semi-T and gracilis become good options. A lot of surgeons are today using the peroneus longus autogenous also as a graft. I think if you're really stuck, you may look for that option too.
All right. Thank you. Thank you. Dr. Monu Singh, please.
Just a small question, Dr. Dinshaw. In a single stage repair of 3 or 4 ligaments, 3 or more ligaments in a later stage, do you have a preferred sequence of progression for repair of the ligaments?
Okay, so I think that's a fantastic question. So I think that's a question that I've ruminated on for many years. And I think what is my preference today, I'll tell you. I think this is what I would do. So if it's a 4 ligament reconstruction that you're doing, number 1 has to be the PCL, because your PCL is your central strut of the knee, and this really reduces your knee. So my PCL would be the first particular fixation. I will pass my ACL, and usually I'll use an endo button on the femur. So it's already fixed on the femur, but I won't fix the tibial part till later. Okay, so you got that? So PCL is passed, ACL is passed, PCL is fixed, ACL has the endo button on top. Now, the next fixation has to be the PLC. Why the PLC? Because if you've got a rotatory instability and you haven't taken care of the PLC and you try and tighten the ACL, you'll fix that in a in a mal-reduced rotatory position. So it should always be PCL first, PLC second, ACL third, and then finally the MCL and the PUL. So I think that is the most logical way of doing it.
Fantastic. Thank you. In case nobody's asking me, I have another simple question. Yeah, one more. Could you just give us a little brief about the post-operative protocol and how do you, mobilize these patients?
Okay, so number one thing, I think the first thing you want to make sure is no complications. So the most important thing is limb vascularity and venous return. So post-operatively, first thing, check that your vascularity is still there. The limb is well vascularized. You're not landing up with any swelling. I always prefer thromboprophylaxis in all of these patients. So I think preventive thromboprophylaxis in all of these patients is important because otherwise some of them will land up with DVT. They've had an injury in the calf region and you may, a tourniquet has been used. You may delay the rehab. So all those reasons, I think thromboprophylaxis number one. Keep them protected. They require a splint. And usually I will start their knee range within 3 or 4 days. As soon as they're relatively pain-free, you want to start off their knee range because the next big obstacle is arthrofibrosis. So you want to start off range early, especially the ones where you've done a 4-ligament job, start off the range, on the 3rd day itself. Keep them non-weight bearing for at least 2 to 3 weeks. And if they start weight bearing, they need to be weight bearing in full extension and locked in full extension. So usually I won't let them walk normal gait till about the 4th or the 6th week. You need physiotherapy. Don't leave them alone because otherwise they won't get their range back. Isometrics and co-contractions start off straight away, but don't start off resisted hamstrings for at least 3 months because resisted hamstring strengthening, if they're doing, it'll start pulling your tibia posteriorly and you'll end up with a grade 1 or 2 residual laxity of the PCL. So wait for hamstring strengthening, but quad strengthening and SLR you can start off immediately.
Fantastic. Thank you.
One small question. In rehabilitation, it's the PCL which I think plays a spoil sport because you can't you have to have a passive movements. You cannot do an active and for pretty long. And the PCL rebound brace of a good company is very, very expensive. So what is the trick here? How to go about to do a good physio rehab?
Okay, so very true. So if you get if your patient can afford a 1 lakh dynamic PCL brace, great. I think that solves your problem. I think it's a great device. Very, very few patients are going to afford that brace. At least put in a static PCL brace. So if your static PCL brace is there, and when you're doing a range of motion, that range of motion is being done in prone position, then gravity will be assisting you in preventing a posterior sag. So there are 2 things here. One is the MCL and one is the PCL. The MCL with any hinge knee brace is well protected. The PCL is the one that's the problem. So if you don't have a good, so if you can get a static PCL, use that. If you can't get a static PCL, just use a simple hinge knee brace, but do it in prone position so that gravity is not bringing the tibia posteriorly. Make sure it's done passively and not actively. He shouldn't be using his hamstrings to achieve flexion, but otherwise those hamstrings are going to pull that tibia slowly posteriorly. I think those are the tricks that I would use.
Oh, great. Thank you. Any other question? Maybe in the chat or any other faculty wants to ask a question? So I think
in presence of extensive ecchymosis, you still go in for an acute repair of arthroscopic procedures? Or?
No, absolutely not. So I think the soft tissue cover is critical. If there's any risk of that soft tissue cover getting necrosed, or if you think there's an internal decurving, just put them into either a splint or an external fixator. Make sure that your soft tissue cover is, healing, it's recovering. only then should you attempt any intervention. If you do MCL repair and your skin sloughs off, that's going to be a disaster. So I think that's why knee dislocations are so challenging, because there are many aspects that you need to think of. You need to think of the ligaments, you need to think of the bones, you need to think of the vascularity and the nerve, you have to think of the soft tissue cover also. And according to me, I think the ligaments are the least of the problem. Those can always be dealt with even subsequently. The most important thing would be get a good bony structure. There's a fracture, take care of that and do a good anatomical restoration of that bone with reduction and fixation. Make sure that the soft tissue cover is good, and make sure at the end of the day, his vascularity is okay and he's got his range. As long as this is there, ligament reconstruction subsequently will be able to solve the problem.
Thank you.
Thank you very much. If there'll be more, then we can do it on a WhatsApp, and then there are various means to do it. Let's start rolling. And the next lecture is by Dr. Raju Vaish, and he's going to talk on cartilage, articular cartilage defects. Please, sir.
Good evening, friends. First of all, let me thank Dr. Samir for his generous introduction and for giving me this valuable opportunity to be here in this seminar, which is wonderful. I learned a lot today. And just to take you through some of the current concepts in the management of articular cartilage injuries or defects that we encounter very commonly during arthroscopic procedures. And most of the time, arthroscopic surgeons find these articular cartilage injuries or defects as a surprise, and they are not prepared to deal with it. And most of the time, the MRI report which they have do not mention anything about these articular cartilage defects. And hence, this is a highly underreported entity. And until very recently, these defects were left untreated, or rather there was a willful neglect by arthroscopic surgeons because they did not know how to deal with it, and there were not many options available. Now that we know a lot about articular cartilage effects and injuries and their treatment, we can deal with these defects in much more satisfactory way. So articular cartilage is a very unique structure which is highly specialized, and it's designed biomaterial which is smooth gliding surface for most of the diarthrodial joints. It is further unique that it has no vascularity, no neural supply, no lymphatic matrix, and it is immunologically naive, and hence it is quite a useful thing to do transplant because there is no immunological reaction. There are very few cells present in the articular cartilage, which is about 5%. These chondrocytes are the cells which are viable elements, and mostly they are present in the extracellular matrix and the water, which is the main component of the articular cartilage. Articular cartilage has several important functions like shock absorption. It provides elasticity, avoids friction between the bones, and also protects bones to some extent. The cartilage, unfortunately, has very limited capacity for self-repair, except for superficial cartilage lesions and in children. But most deep lesions and in adults, once the cartilage is damaged, it is not repairable. Gradually, it leads to degeneration of the articular cartilage and premature onset of osteoarthritis. And that is a very big problem, especially in articular cartilage injuries in young and middle-aged patients. The problem is that we found these articular cartilage so commonly during arthroscopic surgery in almost all age groups, especially about 50% of these patients have articular cartilage lesion in less than 50 years of age. The factors which contribute to the development of these articular cartilage could be mechanical or endogenous. Mechanical factors are overuse and trauma, obesity, the joint structure may be defective due to some pathology or malalignment. There may be loss of muscle strength, like in chronic osteomalacia or paralysis. The endogenous lesions could be heritable disorders, developmental disorders, certain diseases of the joint, and nutritional problems like vitamin D deficiency, etc. Cartilage, as I mentioned before, is so far was not very conducive for imaging because on a routine X-ray and MRI, most of the radiologists would not be able to pick up or report these lesions. But still, all patients with suspected cartilage lesions should have AP standing weight bearing view, Rosenberg view, lateral and axial view, and also, if possible, a long leg HKA X-ray weight bearing to check for any malalignment. Now there are MRIs which can tell you in greater detail with 1.5 or 3 Tesla machines about the cartilage pathology. Cartilage mapping can also be done, which gives you not only the anatomical lesions of the cartilage, but also its biochemical properties, biological properties of the cartilage and how diseased it is. Sometimes bone scan may be useful, especially if you are considering to evaluate subchondral bone pathology associated with cartilage lesions. The treatment of any cartilage lesion, the most important thing is to relieve pain of the patient, inflammation, restore function, and his disability. But the most important part is to postpone or alleviate the need of future prosthetic replacement, especially for younger patients. And hence, it is our duty to preserve a natural joint in younger patients with joint preserving surgeries. The cartilage lesions could be treated with medical treatment, surgical treatment, and now with regenerative treatment. And I will dwell on these to some extent. The non-surgical treatment are activity modification, weight loss, knee braces and orthotics. Non-steroidal anti-inflammatory drugs are useful for pain relief initially. Nutraceuticals in early stages are quite useful in patients whom you do not want to operate or don't think it is necessary. And several types of nutraceuticals are now available. Intra-articular injections of hyaluronic acid, PRP, mesenchymal cells are useful as a biologic procedure. In case of severe inflammation associated with cartilage lesion or any inflammatory pathology, one can sometimes use steroid injection after aspirating the knee. The surgical lesion treatment for cartilage restorations are microfracture, mosaicoplasty or ROTS, cartilage transplantation, allograft, and arthroscopic surgery, osteotomy and arthroplasty are the main cornerstone of surgical procedures for any knee surgery, including treatment of cartilage lesions. Surgeons usually underestimate the implication and use of orthosis, but the literature supports in a great deal the role of orthosis in early cartilage lesions because its progression can be retarded by using simple offloader knee brace with or without lateral wedge insole. And it has been also reported very recently in many papers that combined use of lateral wedges and offloader knee brace can restore medial lateral joint loading and can prevent the progression or sometimes healing of the cartilage lesion. So this must be tried if you are trying conservative treatment. So all cartilage lesions do not require surgical treatment, and the treatment should focus on reducing pain, joint mobility, functional improvement, and try to preserve a natural biologic joint. And it can be achieved by pharmacological and non-pharmacological means. But these non-operative treatment are usually useful in early stages of cartilage lesion. However, in advanced cartilage lesion or big cartilage lesion in high active people, surgical treatment is definitely required. There are several surgical treatments that can be done. These are classified into palliative, reparative, and restorative techniques. The palliative treatment, which is most commonly done by most arthroscopic surgeons, are debridement and lavage and radiofrequency ablation of the cartilage lesion. But it has been seen that this is not a very good procedure, especially if you have a moderate or large lesion, and one should avoid that because you may actually precipitate the onset of early osteoarthritis and more pain for these patients. This used to be a very, very common procedure described first by Lanny Johnson when I was a resident in UK, and we used to love to debride these cartilage lesions so hard so that we can see subchondral bone to full extent. So it's not a good procedure now. Reparative treatment basically focus on marrow stimulating techniques. You can achieve it by doing micro drilling, abrasion arthroplasty, or microfracture technique. Microfractures are probably now one of the commonest procedures that are being done if one see articular cartilage lesion during arthroscopic procedure. I will discuss about the pros and cons of microfracture in coming slides. Restorative techniques are autologous chondrocyte implantation or ACI, autogenous osteochondral grafting or OATS, also known as mosaic plasty, and fresh allografts. And these restorative techniques are must for younger patients with large cartilage lesion where your reparative technique and palliative treatment are going to be unsuccessful. The debridement and lavage can be done in low demand patients with smaller lesions, those who present with mechanical symptoms or recurrent effusion, typically like in osteoarthritis in middle-aged patient. The marrow stimulating techniques expose the chondral defect to pluripotential stem cells that stays in subchondral bone, and they form some sort of cartilage, which is actually not a hyaline cartilage, but a fibrocartilage, and can last for 2 to 5 years. But it's not very durable, especially in high active people. So it is indicated for small lesions in low demand patients. The restorative treatment like ACI re-established normal congruity with mechanical stable hyaline or hyaline-like cartilage. These are best reserved for high demand patients with significant symptoms and history of failed prior palliative reparative procedure, but these are complex and quite expensive procedures. As I said, cartilage is an ideal tissue for transplantation because it is immunoprivileged, is avascular, aneural, it is amenable to storage, and it can be fashioned to fit the recipient defect in any shape and size. Mats Brittberg and Lars Peterson from Sweden, Gothenburg, were the first people who described ACI in 1987, and since then, more than 50,000 patients have already been done, but it has gone through evolution, and we will discuss that. Main indication for ACI are large OCDs, osteochondral defects, traumatic cartilage defect, in selected osteoarthritic patient where there is a localized defect in a young patient. So, as I said, ACI has gone through evolution. First generation involved coverage of periosteum and then putting the cells underneath the periosteum. The second stage, second generation involved collagen sheet. Third generation used matrix-based base on which the cell were implanted like Macy. And now we are into the fourth generation where we have gel-based implant like Chondron, which is now also available in India. So ACI is basically a two-stage procedure where you in first stage take the biopsy of the cartilage from the normal cartilage of the patient and then send these cells, the sample for culture, cell culture in a lab. And after 4 to 6 weeks, you transplant these cultured cells into the defect after cleaning it. And these are the steps which you can see. You first take a cylindrical osteochondral unit for culture, and then from the non-weight bearing area, either from the intercondylar notch or from the lateral femoral trochlea or periphery of the lateral femoral trochlea or medial femoral trochlea. Here is one example, a large osteochondral defect on the medial femoral condyle. I must tell you one thing. Whenever you are looking for looking an MRI of a patient with knee injury, always suspect a cartilage injury, especially in chronic patient. You will see a lot of subchondral changes. So if you have any evidence of subchondral sclerosis or marrow changes, you must think that the underlying cartilage may be defective. And this is 2 years post-op after ACI. You see all the subchondral bone has healed very well with the overlying cartilage. This is the same patient before the ACI and 1 year after the ACI. See how beautifully the cartilage has formed with smooth gliding surface, which is stable. So ACI is indicated in high demand patient with large lesions with history of failed palliative and reparative treatment. In US, FDA has not still permitted to use ACI if you do not have a history of a failed prior treatment. But in Europe and in India, one can do it as a primary procedure if the indication is there. ACI has several advantages because you put highly differentiated culture cells into the defect, so that grows the articular cartilage very well. It's now a proven technique with medium to long-term good results are available. The disadvantages of it include it being a two-stage procedure. It is more expensive, time-consuming, and you have to rely on a cell culture lab, and cell culture is quite expensive, and hence, which does not involve any cell culture. It has been seen that cell alone are not sufficient to regrow the cartilage. You must have a matrix to put these cells in. Different biomaterials have been used instead of periosteum. These biomaterials provide scaffold for cell transportation, and these are usually inert and preserve the chondrocytic phenotype of the cells and hence do not destroy or damage these cells. So the commonly used biomaterials that are used for the ACI are collagen sponge, gel, hyaluronan matrix, PGA, and PLA. So, friends, ACI resurfaces focal chondral defects with hyaline-like cartilage, which is biomechanically superior to fibrocartilage that you get with microfracture, etc. As I mentioned before, single-stage techniques like ACIC or BMAC are now being commonly used to overcome the shortcomings of a two-stage procedure of ACI. And Kim and Shetty has described a technique where you do you can do this procedure single stage arthroscopically without opening up the joint under dry arthroscopy using carbon dioxide insufflation, which is available in most hospitals for laparoscopic surgery. And you can see these steps. There is a large chondral defect which was cleaned, that micro drilling was done, and then you put these bone marrow cells, which is concentrated, and put it on the defect. So cultured cells must be used with scaffold, and instead of culture cells, now there is a trend to use mesenchymal cells, which are not so specialized, and only time will tell us whether cultured cells, which are so specific, are these any much better than mesenchymal cells with scaffold. Articular cartilage repair is now becoming very popular all across the world, as we want to preserve the joints of younger people, and hence many techniques are being used. And there are lots of new things coming in for joint preservation, like meniscal cell culture, meniscal PCL scaffold. 3D bioprinting is also very useful and might become very, very popular and promising technique for preserving these joints. So to sum up, the treatment algorithm for cartilage injuries, that if you have a grade 1 lesion, then usually no surgical treatment is required. You can treat it conservatively. In grade 2 lesions, in smaller lesions, you can do abrasion, debridement, or radiofrequency chondroplasty, or sometimes microfractures. But in larger lesions, you require ACI or BMAC or ACIC, or sometimes OATS if these facilities are not available to preserve these joints. So the awareness about cartilage lesion must be there, because a high index of suspicion is required in the early diagnosis, and you must be prepared to deal with it. MRI is the imaging of modality, but the specialist, the radiologist, must be sensitized to pick up these cartilage lesions. Only symptomatic patients with significant cartilage require interventional treatment, and focal defects are the most preferred lesions, not the global cartilage defect that you see like in osteoarthritis that can be treated by various techniques. Scaffold and tissue engineering techniques are being considered promising apart from the cells that are required for regeneration of articular cartilage. And single stage procedures are becoming popular and may give way to ACI in future. But very important point is that if there is any malalignment present with cartilage defect, then malalignment should also be treated either at the same time or prior to cartilage treatment. Otherwise, cartilage regeneration treatment will definitely fail without any doubt. And lastly, most of our patients demand cartilage repair techniques for advanced stage of osteoarthritis, which is not true, and this is not a suitable technique for advanced OA. It cannot be a replacement for total knee arthroplasty. Of course, it is a biological replacement of the knee or joint in younger patients with early damage or localized damage. Thank you very much for your attention.
Samir, can I ask a question?
Yeah, sure.
Yeah, thank you, sir. Thank you very much for the nice presentation. I'm Dr. Vineet Arora. Sir, I would like to say in neck of femur fracture, and whenever it's even it's an old one, we still try to preserve the neck. And similarly, you have just put on a one word, we should try to preserve rather than going for replacement. So where do you find the things are? For aged patient also, we can try this regeneration procedure.
Thank you.
You say you should consider biological age of the joint rather than chronological age of the patient. There are some patients I have seen even in 60 years, 70 years have very good articular cartilage of the joint with focal defect, and you should not hesitate to go for a joint preserving procedure. Whereas you can have some patients early in 35, 40 years of age with diffuse cartilage lesion or degeneration. And in those cases, cartilage regeneration procedure may not be that successful. So biological age is more important than chronological age.
Can I ask a question, Dr. Sameer?
Yes, Sharan.
Sir, excellent insight into this fascinating field, I would say. My question is that very often what we see is patients having mild to moderate osteoarthritis. You will very categorically saying that it's more, beneficial in traumatic lesions or focal cartilage loss. But when we see a patient with mild to moderate, age about 40, 50s, how do we go about it? I mean, you said you have to have a focal lesion. So do you advise MRI, something which cartilage mapping in all those patients to decide, or you go to an arthroscopy and then see what kind of lesion, then decide? How do you, proceed in such cases? Mild to moderate osteoarthritis, 40 to 50 years of age.
Yeah, I think that's the very pertinent question which we all face in day-to-day practice. First of all, osteoarthritis is a global disease of the joint, right? So if you think it's an osteoarthritis, usually it is progressive to other part of the joint, even if it is present initially in medial compartment or patellofemoral joint. In osteoarthritic knee, always I would like to have a long leg X-ray to check the malalignment. Because most of these patients, if they have malalignment, whatever you do is not going to be successful intra-articularly. And in these patients, either you advise them offloader knee brace, shoe insoles, or correct their malalignment with high tibial osteotomy. That is likely to be successful. In fact, there are reports now that to suggest that with high tibial osteotomy, there is regeneration of the cartilage in these patients. So I would consider that. But if patient has any mechanical symptoms, then I would, or if there is a degenerative tear on the MRI which is symptomatic, I would do an arthroscopy. And if I find any localized defect, if it is small, then I would do a microfracture, but not a larger defect. If there is a large defect only in one part, and let's say patient is around 35, 40 years of age, I might consider doing ACI or OATS in this procedure after explaining well to the patient that it may fail after some years because we are doing it for a disease which is a global disease of the joint.
Dr. Monu Singh?
One question that I have of you, Dr. Raju.
Yeah.
What is the efficacy of these cartilage transplant procedures in presence of a kissing lesion? We are usually talking about lesions, cartilage lesions, which are buttressed on the other side by a normal articulating cartilage. But if you have a kissing lesion, how effective is this procedure, sir?
Yeah, kissing lesions are usually seen in patellofemoral joint and sometime in tibiofemoral joint also, but more so in patellofemoral joint. Kissing lesions do not have as good success after cartilage transplant as a non-kissing lesion. Let's say if a non-kissing lesion has a success rate of around 85-90%, the kissing lesion would have a success rate of around 60-65%. So still, if you feel that the patient is young, symptomatic, you have to treat it, these kissing lesions as well.
Dr. Manocha?
Sameer, can I ask one?
एक मिनट Dr. Manocha is asking. Vineet, उसके बाद आप.
Yeah, sure.
Unmute yourself, Dr. Manocha. Unmute yourself.
I have a very simple question. My patients of this microfracture, they are asking for, after the microfracture, for long-term treatment of nutraceuticals like glucosamine and chondroitin, and also sometimes this viscosupplementation. So I do advise that without knowing how I stand scientifically on this. So what is your take on this?
Yeah. After microfracture for a localized small cartilage lesion, it is good to have a follow-up treatment with hyaluronic acid or PRP and sometimes mixed. Several people have claimed good results. Nutraceuticals again give nutritional supplement to the newly generating cartilage, and I always use them. I also prefer to offload the area with the offloader knee brace and lateral wedge insole. That also helps in relieving pain and taking pressure from the microfracture area.
Dr. Vineet? Dr. Vineet?
Sir, Raju sir.
Yes,
hello.
Vineet.
Sir, can you hear me?
I can't see you.
Yeah, sir. As you said, the ACI is equally costly treatment as the replacement. I'm talking about TKR. Then would you still like to advise this ACI to the patient, even they are having the focal defects of a middle-aged person?
Of course.
Because you, as you said, this may fail.
Of course. Sometimes ACI may be now more expensive than joint replacement. But this is a biological replacement for younger patient. If patient is 40, 45, I would not like to, for a focal defect, I would not like to do a replacement and then revision surgery after a few years. Arthroplasty, has its own complication and longevity. Plus, many people are not happy with their knee replacements, especially younger patients. So it is better to preserve their joint if possible. Cost may be a factor that can be discussed, but most patients, actually the biological procedures appeal to the patient much more than the artificial joint procedure, which are good for older patients.
Right, Dr. Harmesh?
Okay, thank you very much,
Yeah,
sir.
Dr. Rajesh, sir, very excellent presentation. I just want to know what is your use of growth factor concentrate. It has recently come up in comparison to PRP. They say it has less tissue reaction, less post of inflammation. Do you use it in your armamentarium, and in which selective patient do you use this? GFC.
There are very few actually reports that are available. There are very few studies. The companies which are promoting these growth factors actually quote conference proceeding where there are 5-10 cases have been presented by a single author, but not large randomized control or multi-center study. So we really do not know about these. Theoretically, they may be appealing, but we really do not. I don't think it's an evidence-based medicine at the moment.
Sir, I think the last question is from me to Dr. Dinshaw and yourself. What do we have for chondromalacia patelae besides microdrilling?
You mean chondromalacia patelae in a young patient, adolescent?
In a young active patient, what do we have besides microdrilling? What do we have for him?
You see, if the if the articular cartilage is big, we have been using carbon patches and carbon rods in these patients with younger patient, adolescent with severe cartilage loss. But most chondromalacia patients that we see in younger adults have little fibrillation and fissuring of the cartilage with or without maltracking. If there is any maltracking, you treat maltracking either with brace or with the surgical procedure. If there is no maltracking, sometimes there may be just lateral tilting of the patella, ELPS, excessive lateral pressure syndrome. In those cases, still lateral release is quite good. But if you have simple fibrillation of the cartilage, usually this settles down with activity modification, knee braces, and I also give them these glucosamine type drugs, supplements to regenerate cartilage, although there is no conclusive proof for that. And many of these patients, I have seen younger patients presenting with knee pain and fibrillation and fissuring have vitamin D deficiency. We did a thesis on that and found almost 90% of the patients who have younger patient less than 40 who have knee pain were associated with vitamin D. So there is some role of vitamin D there as well. Thank you.
Dr. Sameer, you have to unmute yourself.
Dr. Harmesh, I think your question is left, but can we take it later, please? Because Dr. Bhasin is waiting.
Okay. Very small thing I just wanted to ask.
Harmesh, we can talk later.
Any role of high uronic acid? Anything better than placebo?
No, definitely there are scientific studies to confirm it is not a placebo. It does help.
Okay. Then thank you very much, sir, for your wonderful presentation and all the queries answered. Thank you very much. So now I invite Dr. Bhasin. Sir, apologies for making you wait for so long, and I know you have guests at home. So thank you for bearing with us. And sir, please present your presentation. Thank you.
More than myself, my guests who have come are all orthopedic surgeon, Dr. Matthew, Dr. Dull, Sudhir Kumar, and Dr. Dimri from England. They were here to meet me today, and I was supposed to have this presentation at 8. So they said we will come at 8:30, and then we will be there with you. So they have been waiting patiently. I think they deserve to be, thanked more.
Absolutely, sir. Absolutely. To all our seniors who have taught us, Dr. Matthew, Dr. Dull, and all the guests, thank you, sir. Thank you for waiting.
Yeah. They have been patiently
Dr. Sudhir, sir, good evening. And Dr. Dimri, he said, has also come.
Good evening.
Sir, thank you very much. And all of us here in Delhi are really indebted to you for waiting for so long and keeping your close friend away from you for so long. Thank you, sir.
So they have patiently waited, and they say we'll keep quiet when you talk. So I said that will be nice if they can manage to keep quiet in spite of all the lubrication they have had. Anyway, so I will be speaking.
Kind of you. Thank you.
No, thank you so much.
Please.
And it's so nice of you. All of you who are still watching it, Harmesh, Hitesh, Dinshaw, you, so many of you are still.
It's our privilege, sir.
They're all watching. And they have the option of not watching, but they are there to watch. So I'm grateful to even all those the people who are watching. Anyway, thank you for watching it. So I have my technique of ACL, which I call a socially responsible technique of ACL reconstruction. Why it is socially responsible? Because it is a low implant cost, scientifically based technique for ACL reconstruction. It is scientific, bio-friendly technique for ACL reconstruction. It is not bioabsorbable. Biology doesn't get absorbed, but it is a bio-friendly technique, which is what I call this technique. How this technique evolved over a period of time with me in India is what I will share shortly. In 1995, we started using semi-T and gracilis, and subsequently only shifted to only semi-T because that was sufficient. In 1995, that was an era where gold standard was called the bone patellar tendon bone, was in vogue, and it was called the gold standard. There was not much available for fixation of a hamstring graft. Only thing available was an open loop endo button, and you have to calculate, you have to tie knots, and a lot of other things. So we had to devise our own method to fix the graft, and this is what we started doing in 1995. And we still continue to do it because it has stood the test of time in a private institution and it is working. So that is what I'm going to share with you. And this is what I call a made in India ACL reconstruction. It is an Atam Nirbhar type of a thing where we are self-sufficient with all the implants. It uses minimal implant ACL reconstruction. The ACL reconstruction essentially involves an adequate graft material inside a properly placed anatomical tunnel providing proper environment for the graft to heal to the tunnels, and it should be a biologically friendly technique. Basically, this is the basis of all ACL reconstruction. And we call it Atam Nirbhar because this is the only implant which we use. These are not special proprietary implants. These implants have already existed for more than 40 years. They are simple cancellous screw, one simple cancellous lag screw, 2 washers, and number 5 ethibond threads. These are not specialized arthroscopy. In 1995, this is what we started using. We have tried to use other implants which are available commercially in the market, but we have found what we've developed on our own is the most strongest possible fixation, and it is biologically friendly. So this is what we always keep coming back to, and we still keep using this as the method of fixation for our graft. So this is what is the implant, and how we use it is, I'll explain you in reverse. Now this is a post ACL reconstruction X-ray of a patient. You can see there is a tunnel here. This is a tunnel where it has incorporated. There is formation of a tunnel wall here. This tunnel, one is on the tibia, other is on the femur. The femoral tunnel has a small channel at the top. Okay, so we drill a tibial tunnel. The graft goes from tibial tunnel all the way into the femoral tunnel, and the graft is jammed in the femoral tunnel. From the top of the graft and from the top of the femoral tunnel, there are threads which go and tie around this washer. So this is the fixation at the top. At the lower end, from the graft, there are 2 or 3 threads coming, which are tied depending on the position, whether it is the AM bundle or PL bundle, over an ordinary cancellous screw post. So this is in reverse. We will share the technique, what we do as we go forward. So this is the lateral view of the same. And this is the technique which we do. We harvest the semi-T graft only. We take a periosteum extension of the graft. It increases the length, and it is biologically better incorporated in a bony tunnel. The periosteum heals to the bony tunnel. So this is the extra periosteum we get. We run a number 5 running ethibond stitch on one side of the graft and then the other side, and then we harvest the graft. After removing all the muscle, we don't cut and throw away the graft. We fold the thin part to make the rest of the graft thicker. We fold the graft like this, and again at this end, the inside end, we again run a number 5 stitch along one side, bring it down on the other side, and this is how we check that the number 5 thread is holding the graft securely. We double this graft over a number 5 ethibond noose knot. And once this graft is doubled, so we quadrupled this graft by doubling the double graft over an interlocked noose knot. Those knots on the screwdriver are interlocked noose knots. We pass the double graft through it and fold it, so it becomes a quadrupled semi-T graft, which is held on both the sides. So at one side, the top end has got interlocked noose knot. This will go in the femur, the one on the left side of the screen, one on the right side. We tight size this graft. That means we drill a tunnel through which the graft just tightly passes or just doesn't pass. After taking the graft, we don't put it on a tension board. We put it back into the donor site, which is probably the patient's own site, the best biological environment for the graft to remain while we are making the tunnel. Nowadays, one team prepares the graft, the other team is preparing the tunnel. So we really don't need to do it. But in case you need to do it, instead of putting it on a saline outside, we put it in the patient's own body. That is the best environment. So this is how we do tunneling and pass the graft. So this is the tibial side. We don't aggressively debride using a power shaver. We do minimal debridement of the remaining stump. We don't do a notchplasty. We try to reach the femoral site, insertion point of the graft. We clear up that area and we clear the intercondylar notch, the medial wall of the lateral femoral condyle. And now once we have gone all the way behind, we use a curette to cancelize that area. So what you are seeing is the remnant of the ACL, the postfemoral remnant of the ACL. Yeah, that is what it is. Just in front of it is the anatomical site. We cancelize it, remove the cortical bone from it, and cancelize that part where we are going to put the femoral tunnel. So we clear this area. We don't aggressively use shaver, but we do use shaver also to clean up this area. Once we have cancellized it, we mark this area and our tunnel should reach this area. We do a trans-tibial drilling. Our aim is to breach. So this is from the anteromedial portal. The femoral site is inspected and it is marked using a pick. Okay, so now we are drilling a tibial tunnel. It is important to, so this is the downslope of the medial tibial spine. On the inner side of it, in line with the posterior margin of the anterior horn, we make the tibial tunnel. It is important to make the tibial tunnel correctly. So once we have put this, now this is the trick. We raise the end of the jig and we take it medially so that we are able to reach the right point on the femur. In this technique, transtibial technique, it is important to get the tibial tunnel right so that you reach the right point on the femur. So we raise the jig, we put in a guide wire, and we see the guide wire inside. So that is the guide wire coming at the tibial site. We cut around, we make a periosteal elevation around the guide wire. Then we drill around this guide wire a 6 mm reamer. A 6 mm cannulated reamer makes the first initial tibial passage. Now, once we have this 6 mm tibial passage on the tibia, we shift the scope medially, visualize the site at which we have to reach. Now, from this tibial tunnel, we have to reach this femoral site. We take a bead pin. Oh gosh, it has started again. I don't know why it started again. Anyway, this is again the same thing. Somehow it has started again. I think it was missing somewhere and then it started again. I'm sorry for this, but I think we'll have to go through it. So this is the locating the femoral site, preparing the femoral site, cancellizing the femoral site. Aim is through the tibia to reach this site. If you are not able to reach, you may use an accessory anteromedial portal. But what we have found is that our technique of drilling the tibial tunnel in the trick which we just showed you, we'll show it to you again, makes sure that we are able to reach the femoral site through the transtibial site. It is important to make the tibial tunnel in the way we want. We are now doing it so that we are able to reach the intended site. It is important that the graft should be at the right place and of the right quantity. So we have shifted to the medial portal for visualizing. And we put, this is the trick, that we lift the jig higher so that we are more horizontal, and we lift it medially so that we aim at the tibia, at the femoral site which we want to reach. So this is the site, we lift it up and we take it medially, the jig medially, so that we are able to reach the femoral site from the tibia. This is the guide pin on the tibia. And once we have the guide pin, we elevate the periosteum on the tibia, and on this guide pin we put a 6 mm cannulated reamer. Now this is a tibial passage. This is not the size of the graft. This is just a passage, 6 mm. and then we shift to the medial portal again. We have to bring our beath pin at the intended site on the femur. It is important to be able to reach the right point. And once we have reached the right point, through the cancellous bone, we insert just with our hand. As you can see, this is quite posteriorly. One can see the remnant of the ACL stump, and it is quite low. One is quite clear, close to the cartilage. It is on the side wall, not on the roof of the intercondylar notch. You can see the articular cartilage of the thing, tibia. Then we drill it and bring it laterally on the femoral side. At the femoral side, we palpate the wire, make a small incision there. And once we have made an incision there, we reflect the vastus lateralis anteriorly. We expose this beath pin coming from the femur. We reflect the periosteum. We expose it. And as you can see, we are reflecting the periosteum. And now once we have done that, the beath pin comes out and is brought out laterally. Once we have brought it out laterally, we tight size the graft. A reamer corresponding to tight fitting graft is put over this beath pin, and it goes, that is the graft lying inside the patient's body, not on a tensioning board. We will show you what we use as a tensioning board. You will see it in a while. And we retain the position of the tibia well. So visualizing from the medial side, on this beath pin, we put a cannulated reamer corresponding to the size of the graft. So this reamer goes from tibia into the femoral site. So let's say a graft is 9 mm, which is usually the case. So this 9 mm reamer goes and comes out laterally. And once that channel has been made, we put a looped ethibond on the beath pin. This looped ethibond is brought laterally, and on this is loaded the graft, keeping the anteromedial bundle and the two lateral bundle and the posterolateral bundle. We mark them by different knotting technique, which we can show you a little later. So this is the graft going from the tibia. This is the femoral tunnel you are seeing. The graft is pulled and jammed. So this is the posterior wall. Right next to the posterior wall is the remnant of the ACL, and the tunnel is quite posterior and low, as you can see the cartilage of the joint, in tibiofemoral joint. So this is where the tunnel is located, and we pull the graft from the tibia into the femur. It is a very, very tight fitting graft. Believe me, So, and once we have pulled the graft in, the double interlocked noose knot ethibond, there are 4 threads. So we pass the 2 threads inside of the washer and 2 threads are outside. The threads are tied in pairs, and this is how we achieve a cortical fixation on the femur. And this is our tensioning board. We pull the graft about 25 times to pre-tension the graft. After doing that, we put an ordinary cancellous screw on the upper tibia, right distal to the tunnel. And then over this tunnel, over this post, we tie. Now, these are threads which mark the different positions. Now, the PL bundle, the AM bundle, and the intermediate bundle. There are 3 pairs of threads which are coming out of the tibial tunnel. We mark them by different knotting numbers. So we tie the PL bundle first in extension, as you can see now. That has been tied over the tibial screw. Then we flex the knee about 10 to 15 degree and tie the intermediate bundle, which is the PM bundle. And then the AM bundle is tied in about 30 to 40 degree of flexion. We have been doing this even before we became aware that there is a double bundle technique, but this is what we have been doing for many, many years. So now it's in flexion of about 30 to 40 degree. The femur is supported and the tibia is unsupported so that it falls posteriorly. So we tie the knots here and then we tighten the screw. And this is what is the final picture. As you can see, This is the old ACL, then the new ACL going through it. So that is the new ACL graft in place. At this stage, if we find that there is an impingement in extension, then only do we do a minimal debridement. Yeah, okay, just 1 or 2. So this is the new ACL and the old remnant stump of the ACL, which we only remove what is and the debris from the ACL, old ACL. So we only remove whatever is essential and blocking extension. So we check for extension impingement. So we extend the knee, and if there is a tissue which is blocking extension, then we may remove a small part of it, which may remove using a shaver or a punch. And this is how we make sure that this is how we do an anterior drawer, which the patient should move and not the knee. And this is what makes sure that the graft is securely fixed. Okay, so this was essentially the technique, a small presentation on the tight fit. Now we have passed the graft from tibia to the femur. We have not yet fixed the femur, but still we are able to pull the patient without the graft coming out. So this is what the tight fit we ensure in the femur, which is not possible with an endo button because the graft does not slide back. Any orthopedic surgery has two aspects, the technical success and biological success. We all enjoying the technical success, putting screws, drills, and everything. But what the patient has to live with is the biologically incorporated, viable, functioning ACL. That is what we aimed for. So technical success, as you can see that technologically, this is a strong fixation. But what is the biological outcome? We all must have to understand that. This is how we studied the biological outcome, because this was our original technique. First, we needed to prove to ourselves and then to others to continue in doing this technique. So these are post-ACL reconstruction, relook biopsy from ACL, which shows well-vascularized tissue. A post-ACL reconstruction, one can see the reconstructed ACL and MRI. What you are seeing on the right, lower side, is what you can make out that there are two bundles in the even seen in the MRI. So this is the bundle which is the AM bundle, and the PL bundle one can make out even in the post reconstruction ACL reconstruction. Another way to convince that this technique does work is the second look arthroscopy, which we used to do in 1995-96. So this is from 1996, a video which shows a continuity, ACL in continuity, well vascularized and having a good tension. Any ACL which is not taking tension will get absorbed. This is 1 or 2 years after the reconstruction. It is maintaining its integrity, it is maintaining traction, and we are doing an anterior drawer to make sure that it is functioning well. If it was not a functioning ACL, this would have got absorbed. Okay, another interesting thing which we found, that we have all studied Wolff's law, that structure adapts to the function. We have heard it in bones, but believe me, I have seen it occurring even in ACL. So if you put a ACL in a proper tunnel, there is a formation of PL bundle-like structure, which we will show you. So this is again a relook arthroscopy, and you will see that what you are seeing now is the AM bundle here and a PL bundle here. Now the structure of the ACL, once it is vascularized, has got adapted to the function. So there is a PL bundle-like structure formation, even if you have not made double tunnels. What is the advantage? This is biologically, there is only a graft in the graft bed. There is no implant or no bioabsorbable implant in the graft bed. Only the graft bed has got total contact with the graft. There is no intervening implant present. The technique is simple. One needs to measure only the graft diameter and length. There is no calculation for the thread part or how much one has to pull. The cost advantage is tremendous. Implant is a conventional screw and washer. No specialized expensive implant is needed. At this point of time, I have a thought to share, although it's late in the night, but still a thought to share. Do we have to ape what we have been told and sold? We are guided by West, but we have to practice medicine with the resources of the East. We have to look after our people. West is not able to look after with its vast resources, with a limited population, how can we expect to look after our people, which is a large population with limited resources, if we continue to follow the methodology and guidelines which we get from the West? We have a large number of clinical material available. We certainly can develop our techniques and technology and show to the world that this is what is possible at a much more affordable cost. We have to understand, we have to look after our people, or do we have to look after the commercial interest of the companies? Scientific medicine based on correct principle, but techniques which our population can afford is what we should all strive to do. Thank you very much.
Thank you, sir. Thank you very much. I would say this technique, and this technique is definitely biological. It's truly Atmanirbhar, and it's truly and a very cost-effective method to do, and especially Indian patients who are always compromised and monetarily compromised. Thank you very much for sharing your technique. So one question that I'll start with is, when you do a semi-T quadruple graft. So in an average patient, what length do you look forward to? कि इतना graft मेरे पास इतनी length होनी चाहिए to make a good fixation.
Okay. See, the standard recommendation is that you should have minimum 15 mm in each tunnel. I say we should have minimum 20 mm in each tunnel. So if it is 20 mm in femoral tunnel, 20 in tibial tunnel, in between will be at least 20 to 25 millimeter graft. So we must have 6 to 6.5. 6.5 is what I usually say is the least. Least recommended by textbook is 6 centimeter of graft. But we have had a thesis on this. What should be the expected length and what should be the expected diameter? We have had a thesis about 4 years ago, and it is probably accepted for publication also. Now, this is what we found, that it depends on the body mass index of the patient and height, and what is the height of the patient, what is the build of the patient. So most of the time, what we do is we divide the graft. Let us say most of our grafts are minimum 8 mm thick. 90% will be, I would say 80% would be 8 mm, 10% would be 9 mm, 5% will be 10 mm, and 5% will be 7 mm. So this is what is the diameter. It is the diameter which matters. If you have got a longer graft, let us say I've got a graft of 9 centimeter, I just make my femoral tunnel longer so that it goes more into the femoral tunnel and it doesn't stick out of the tibial tunnel. That's all. I don't need to calculate anything. I just make the femoral tunnel longer if I've got a thicker, longer graft. But what I would accept is not less than 6 centimeter of graft length, and most of the grafts are 8 or 9.
So you answered before asking me a question, you answered it. I wanted to know the diameter, and 8 millimeter is a wonderful diameter for us Indians. And you needn't worry about it at all. Harmesh, please go ahead.
Sir, if I ask Dr. Manocha to tell me 5 principles which we should follow, you have broken all the 5 principles of ACL, but beautifully, and hats off to you. It should be called an invention rather, not following anything which is written in the books, not following that transtibial tunnel. Now people don't follow. Then again, all implants you are not using expensive. It's a beautiful explanation and a beautiful thought process. Thank you. Thank you.
Thank you, Harmesh. But when I started doing 95, everybody was doing bone peddler. The fact that people have shifted to hamstring was probably we did think it right at that stage in 95 to start doing bone peddler. And I have thought of going to some of those endo buttons which are tight rope. Believe me, if your graft is very tight the way I do it, it is impossible with that tight rope to put the graft in. The loop breaks if I put it. So the only way that I could do a closed, those tight rope was that I had to make my tunnel loose. Now what am I doing? I'm biologically compromising. I'm having a loose fitting graft.
Incorporation will be difficult. Yeah.
It will be there, but it does work. I'm not saying it doesn't work.
Much longer.
But it is probably biologically. If I put an interference screw between the graft and the tunnel, Does that screw interfere with attachment of the graft, or does it help? That part of the graft which is which has an interference screw between the tunnel and the graft is a screw there. At the best, it may get absorbed, but it is not getting converted into a graft tissue. It is not bioconvertible. In the technique which I use, there is a complete contact. So biologically, I could never convince myself to doing interference screw or the other loops. Yeah.
Dr. Monu, please.
Thank you so much.
Fantastic presentation, sir.
Thank you, sir.
Just a few things which I need a little more clarity about. You like putting in a tight-fitting graft in the femoral tunnel, but along with the graft, you also prefer to leave a synthetic material over there, and still, it is the graft is incorporating pretty well over there.
So the graft, the material is only at the end of the tunnel. It is not the entire graft. Yeah.
It is in the tunnel, but if you tie up your graft and if you have to pull that thick graft inside a tight tunnel, it has to have a good hold, and that would certainly leave a lot of material inside. And
no, sir, no. There are only that loop which is there at the end is in the tunnel. The rest is outside. It is through a channel. That part of the where, you know, at the end of the femur, the graft is totally jammed in. At the top of the graft, only a thread is coming out. The thread is, that's all, which is the material. It's only a loop at the top. That's all.
You do feel that it has the adequate strength to pull it through without cutting it into the graft?
Sir, we showed you, we pulled the patient and the graft did not come out.
I do not doubt that. I do not doubt that. But my concerns, I'm just voicing my concerns here. And of course, I would request you also to share whatever the complication and the rate of complications have been with this technique. Now, the second part of concern is where you are lifting up your jig and we are taking it more medially. So you're placing, with your transtibial technique, you're placing your tibial tunnel more, underneath the weight-bearing area, and you're placing a stress riser right underneath that. You feel, has it ever given you a problem? Or
sir, the weight-bearing area is through the Fukasawa's point, which is 62% from the medial condyle of the tibia. We know it from the principles of high tibial. We have never had a stress fracture, as opposed to stress fractures which used to occur in bone patellar tendon growth. We have never had a stress fracture. It is not that medially. The aim is that through the tibia, you should be able to reach the femoral side. What matters is that the orientation of the graft inside has to be correct. Where the tibial tunnel or femoral tunnel is, just to make sure that the tibial tunnel is such that I am able to reach the femoral side. That's all. If I'm not able to reach it, you can make a medial portal. It is, as I said, it is different from a conventional Western thought process, which we are all colonial still slaves to follow. This is my original technique of doing it. And we are all used to be taught by the West. This is the difference. This is the only difference.
If I can have just a quick, could you summarize what complications you've had? What are the significant complications you faced, if at all, with this technique that you feel that one has to be careful about?
Not as far as the technique is concerned. We have had, usual infections which can occur. Not too many, sir, but we do have. And the only problem which we have seen is infection sometimes. Maybe arthrofibrosis also sometimes. But that is probably comparable to any technique. I see more patients coming to me because of the same techniques done elsewhere than which I have seen my own techniques. So that is not a very huge number, or not a significant to say that this is technique specific. Stiffness can occur, due to arthrofibrosis in other methods also. So I have not seen any complications regarding.
Well, Dr. Bhasin, innovative
fixation, because probably it is the most biologically strong.
Fantastic technique, sir.
Dr. Sameer.
Fantastic technique and great presentation.
Go forward,
I really appreciate that.
Dr. Bhasin, excellent technique. Thank you.
Thank you, sir. Thank you.
Samir, unmute yourself.
Please, let us wind
Samir,
up.
Unmute.
Unmute yourself.
Sorry. Sir, thank you very much for your presentation, for waiting. And it was a fantastic presentation, which I think would be the highlight of today's webinar. Thank you very much, sir.
Thank you. Thank you so much.
We are privileged. Dr. Dhananjay, are you around? Hope you haven't slept off. Dr. Dhananjay Sabat. Dr. Dhananjay, are you around?
Yeah, I'm there.
Okay. So Dhananjay is there. Thanks, Dhananjay. So there is a special technique of by Dr. Dhananjay, and we are waiting for it. Please go ahead with your talk.
Okay, shall I take it now?
Please do it now.
Okay, I will just log in from my computer first.
Please do.
Right. Just a minute. I was waiting for you to complete.
Yeah, don't worry. I thought you should go first.
Okay. I will just take half a minute just to log in.
No issues.
From my computer, and I will start. Right.
In the meantime, can I put a small question to Dr. Bhasin if he is around?
Dr. Bhasin, मुझे लगता है सर चले गए होंगे, उनके दोस्त वेट कर रहे थे सारे.
Okay. The idea is there are only two loops kind of being pulled, and he has fixed it in three different things. Like he says AM, PL, and the intermediate. How does two loops, two kind of
Dr. Harmesh, to be very frank, I'll need to see the video again and study how he's tying his how's making the semi-T, because ultimately we come out with 4 threads, right? So
because
2 for each.
Normally AM and a PL bundle will have 2 tunnels in the femur differently. Now
Absolutely.
we are having the same tunnel, and still we are talking about 3 bundles in a
There
way.
is a different technique of tying, so I think I'll have to revise and go ahead and see how it ties it.
Yeah.
No, what I feel, Dr. Harmesh, that when he's referring to those bundles and he's tying them up, he's doing it in a different position. So when he's doing them in a different position, the limbs which are getting
different parts of flexion,
they are in different states of flexion.
Yeah.
And that is leading to a differential load and a differential, function of those limbs. 4 limbs that he's got.
Sir, that is the principle. But how do we have 3 pairs of sutures? I think that was the question. 3 pairs instead of 2, what we normally have when we fix it.
No, he had 3 because he had quadrupled it. He folded it once, so he had 2, and then he folded it again. So the other side had only 1 because it was already connected. So he has 3 pairs.
That makes a very simple explanation. All right, Dr. Bageja, you had something to ask.
I think he's ready. Dr. Dhananjay is ready.
Well, you can ask the question. Don't worry.
Dr. Monu, now this time the tibial tunnel is separate and femur is separately made, non-anatomical, not a single guide wire. Am I right or wrong? Now protocol is like
we are using guide wires, but our tunnels nowadays they are much flatter. We are not having straight up tunnels that we used to have few years back. It's more anatomical. We are bringing them.
It's not 11 o'clock. It's 9 o'clock. Yeah.
Rather 8:30, Dr. Harmesh.
It's the same, but now we are having much flatter tunnels.
Yeah.
Right? We are not, earlier we used to stand them up, but right now we are trying to go more posteriorly on the femoral side.
Dr. Bageja, to achieve that only, he has put it more higher and more medial.
He lifts the jet up and more medial, so it goes more lower. Right, so this is, I think, his technique.
But there's no fixed idea. If it is not getting, he can always make an anteromedial.
He's modified his technique. He's modified his techniques. So
with the transtibial technique, you are more or less committed to your femoral tunnel because of your tibial tunnel. Yeah. So once your tibial tunnel is made, then you have very little leeway in a transtibial technique.
Yes.
I guess, Dr. Harmesh, it's over years of decades of practice. His devices.
No doubts, Dr. Samir, but it makes sense that if you raise your hand and make it more medial, it will go to 11 to 9.
But then the point is that then you're changing your tibial tunnel also, isn't it?
Yeah, but he says it doesn't matter. Tibial tunnel doesn't matter. Yeah.
No. May I make it a point?
Please.
Sir, we were waiting for you.
वो dinner कर रहे थे.
I have published a paper about this part only. The tibial tunnel, if you want to get it that low on the femur, so what you need to do. Now, if you move it up, you make the tibial tunnel smaller. And if you move it medially, you make the tibial tunnel under the weight-bearing medial condyle and with a very small subchondral area present, further closer to the closer to the interspinal area. What the point Monu was making.
Right.
Now the thing is that with that thing, you can definitely reach posteriorly and down, but your tibial tunnel is so small that if we used to if we tried to use anything which we use as an interference screw or something a fixation which is an interference fed, he would not have an appropriate size screw. What my point? The second thing is that if you move it that far medially, the biggest damage which you cause is to the medial collateral ligament. We stay low down and make the tunnel vertical. The reason is that the lower down towards the shaft, the MCL tapers down to a narrow strip, whereas closer to the joint is much wider, extending from front to back. So if you carry it up and medially, then you are damaging your tunnel. We conducted a thesis for this purpose. If you have to make the femoral tunnel so far down on the femur, you actually are placing the mouth of your tibial tunnel completely on the MCL. That may not be important in isolated ACL injury. That becomes a very important point when there is a associated some medial collateral disruption
Dr.
also.
Manocha, I don't think they are going so medial as to even reach a MCL.
It does.
I really doubt.
It does reach.
It
does reach MCL.
MCL is right there. The anterior edge is almost there.
MCL, it does reach the MCL.
That's right. It's
The
a very
whole of the
broad one.
tunnel
But if it is so broad, then probably 8 millimeter will not
no
really
8 in,
do any
there
harm.
is no space for an 8 millimeter. It definitely reaches there.
Okay, sir, I'll wind this up by saying that the proof of pudding is in eating it. He's been doing it for the last so many decades, and they're doing good.
And he has always been innovating his techniques very beautifully.
Absolutely.
No doubt.
So we move forward from here. And Dr. Dhananjay, we love to see your techniques. Go ahead, please.
Thank you so much. Thank you, Dr. Samir, for the invitation. I'm sharing my screen.
Yeah.
Yeah. I hope I'm visible.
Absolutely, yes.
Okay, thank you. Basically, the arthroscopy in an acute multiligament knee injury is always a challenge, right? Dr. Dinshaw have already told how it poses a challenge, but sometimes we need it. In the acute knee ligament surgery, we sometimes need to do arthroscopy also. And when there is a gross disruption of the capsular ligamentous structures, we are always in a challenge to prevent extravasation, prevent a compartment syndrome or associated complications because of it. So the techniques what usually people do is putting an egress incision so that the fluid can freely flow out and you can continue on your arthroscopy work. But this is only possible when the knee is reduced, so that you can identify the structures nicely and you can proceed with some arthroscopy work. You may need to repair meniscus, root repairs, all this can be done in the same setting also. But it may be difficult when the knee is not reduced or it is an irreducible dislocation type scenario. So in that scenario, we may need something more. So my experience of dry arthroscopy in such few scenario, I will just share a case sign, and the patella is sitting out and the medial femoral condyle making the most of the prominent part of the dislocation, but there was no neurovascular deficit. So we plan for a open reduction definitely, and then I thought if we are reducing it open, since it is irreducible, then why not stabilize it, right? So these are the radiographs of the irreducible posterolateral knee dislocation, and these are the MRI pictures. You can see the whole of the MCL and the medial structures are flipped inside the joint, and through which the medial condyle has buttonholed and leading to irreducibility of the lesion. You can see this continuous structure, medial structures MCL, and further these are the muscles of vastus medialis. All of the MPFL, everything is gone. These are the the other pictures T2. And in axial sections, you can see even the MPFL is incorporated into these ruptured structures. There is a gross disruption on the medial side. That's why it was not reducing. So on table, I started with a diagnostic scopy, and believe me, it was such a difficult to find out the structure. This is somewhat I have entered on the lateral side. I can see the lateral meniscus, but no lateral femoral condyle. This is the lateral femoral condyle is actually anteriorly sitting, and some disruption of the lateral structures. As we negotiated so the lateral condyle to the notch area, we can see the medial side of the structures. So then we removed this fat pad and cleaned the medial side a bit. And I thought if I can resect the tissue which is interposed arthroscopically, then it may reduce open. So I started cleaning a bit, but identifying the tissue was really difficult. And there are a lot of tissue. This is the whole MCL and all this coming. This is the ruptured ACL. And this tissue was such a way interposed that I planned for a open. I converted into open after 5 minutes of scopy. So I did a anteromedial anterior incision on the medial side, and with using that mixtures, took that sling of tissue out from the medial femoral condyle. Then only the knee got reduced, and here is the whole of the MCL which is torn. This is hold with the forceps. So after that, the knee is reduced. Then I started putting my scope, but now I went with a dry scope, and I was able to actually make out the whole of the medial side, the meniscus then, and I used a shaver to resect the ruptured PCL area to clean the posterior side. Intermittently, we can wash the joint to reduce this blurring of the vision on the camera when the blood sticks to it. And intermittently, you can suck the collected blood or fluid using a that metal suction spine people use. That is a very nice device which can be used for sucking out the blood from the deeper tissues. So the posterior capsule is liberated to make space for the PCL tibial tunnel. And this is the PCL jig which can come in. So the whole of the maneuver can be done through the opening on the what we have made on the incision on the anteromedial side. All this cleaning and instrumentation. Next, we put a PCL tibial jig through that incision, and the jig was placed adequately below into the footprint. It was drilled. I have taken a peroneus longus graft for this PCL, and a triple peroneus longus will be used for the graft source. The drill has come in. It was protected with the protective sheath, the PCL protector, and it was over drilled with the required diameter. Then the PCL femoral hammer is used for outside in drilling of the PCL, which was dilated and the tunnel was created. For PCL femoral hammer, we retracted the skin flap of the same incision posteriorly so that we did not make a outside incision. The same flap was retracted posteriorly, and through that the PCL jig was placed and tunnel was made. So once this is done, the suture is passed, a SSR loop is passed through the tibial tunnel, and it was taken through the femoral tunnel. The loop was reversed and the graft was pulled in. and it was fixed on the femur with a screw outside in, and then it was on the tibia with an interference screw. So the MCL was repaired. The deep MCL, sorry, I just forgot to show something here. Yes. Okay. Let's I will go again. Okay. Sorry for the disturbance, just went off on its own. Sorry. So the deep MCL was repaired with a anchor, and the superficial MCL was sutured end to end for completion of the medial side repair. And in the standard way, we have, I usually use a custom-made PVC brace with a drop lock, which is cheap and quite sturdy to protect multi-ligament injuries with collateral injuries for these patients who are poor, and it provides good stability to the collaterals. We can give a mold according to the collaterals we have repaired. Like that, we have a MCL repair, then we can give a bit of Harris mold and use a posterior calf pad for support of my multi-ligament injuries. And I didn't actually did an ACL reconstruction in this case, but yes, we could have easily done that also. Considering his 54 years age and a low demand type of patient, I didn't opted for that. Still the patient is doing well, and he has good range of motion, and for the last 3 or 4 years follow with me. So basically, if this is just an extra thought process of doing an dry scopy assisted reconstruction, because restoring the PCL and MCL in such case makes life so easy that the patient might not need a second surgery, and we have restored the central PCL ligament along with the major injury of MCL ligament. So that's why I plan to discuss this case, which might sound interesting to all the panelists and the audience. Thank you.
Well, Dr. Dhananjay, no doubt about it. This is something I haven't seen it earlier. Dry arthroscopy, and of course, dry would be that you didn't want to cause a compartment syndrome with such a severe injury and cause another damage. But I would say, Dr. Dhananjay, that it will be a caliber of your surgeon that you can see inside and do a PCL, which itself is a little difficult surgery as compared to ACL and other arthroscopic procedures. So congratulations on that, and a beautiful case, well shown. Dr. Manocha, you wanted to ask anything? Dr. Mano Singh?
In a much similar situation, I had a different solution. So like I also made a similar paramedian small anterior arthrotomy. And then I added a medial safety incision. So with that, I had a finger on the back, feeling for the footprint. So with that through window, I didn't need even an arthroscopy. Through that small window, you can see that wire loop being pushed by your finger coming out there. And I reconstructed in that MCL, ACL, as well as PCL. So even dry arthrotomy, a very small arthrotomy with a split, the medial safety incision works the similar way what you did.
Agreed. Completely agreed, sir.
Absolutely, Dr. Manocha, of course. You've gone one up. You've gone one up on Dhananjay. That's nice. And safety incision is well described. Finally, safety incision is well described too. Dr. Manu, you wanted to say?
Yeah, I just wanted to know what was the rush? What was the need to be aggressive?
The rush.
How does it improve the functional outcome with a limited visual? What's the right word? With a limited visualization in an acute knee, what advantage do we get functionally for the patient?
This case was a irreducible knee dislocation. That was the
That
first.
much we understand.
Yeah.
That
So
much we understand.
we have to take the MCL out. So we can stage
beautifully.
Yeah. So we can stage the surgery, no doubt. But if I can manage to do a PCL in the same sitting, the patient might not need any surgery for the ACL, even some lateral stripping what is there. He actually didn't need for it. So with a in the simple 1.5 hour to need a time, you can manage both. Or within 2 hours, you can manage both. Then why not? So definitely.
You feel it would
Sir,
have been, it would have been
still incarcerated MCL that was it.
Hello.
Sir, it was, I think, incarcerated MCL, which was what he wanted to take out.
See, what I feel is all these surgeries, these technical procedures, they are basically dependent upon, besides the skill of the surgeon, of course, upon how well you are able to visualize and how well you are able to, access that is within the joint or outside of the joint. So my personal preference would have been to let it heal, let the soft tissue heal. MCL required reduction, obviously, and you could have, if required, you repair that, the collateral. ACL, PCL, much it is better to operate after an interval when life is easier for the surgeon. We are not talking about experienced surgeons like you, but we are talking about the an early young arthroscopist sitting out in the periphery who would be wanting to do these cases, and giving an adequate time to the soft tissues to heal.
Well,
vascularity itself of the limb and of the skin, vascularity itself is the major issue. Yes, Dr. Manocha.
I think I'll sum up.
That's for sure.
Yeah.
I even myself have done at least 4 or 5 MCL repairs in such knee dislocations before I started venturing into doing it in the same setting. And I have done in the same setting like this and another 3 or 4, because these are not common injuries. We see around 1 in a year maybe such injuries which we need to embark upon. So with time and experience, one can go for higher and higher level. But definitely for the beginners, the first stage is MCL. Next, the rest can wait.
Correct. Maybe a last word from you, Dr. Manocha. Then we present the last talk.
Dr. Monu, I have to disagree on that point. Whenever there is a PCL with a collateral, you have to address the PCL. We had this point even Dinshaw making. Whenever there is a PCL with any collateral, PCL has to be addressed. You may disagree that the ACL is required or not. Only MCL, when the PCL is completely disrupted, only MCL repair will not really work.
Not if you can brace it, and not at the risk, not at the additional risk, risking the limb, sir. Vascularity of the limb is much more important.
With the reconstruction, these braces do not really stabilize. Even with reconstruction, with the PCL. When you have no PCL and only an MCL, the brace won't work. PCL has to be made. Dinshaw made this point. He made that the central, the pivot is the PCL. If the PCL is broken with a collateral, you have to stabilize the PCL.
We are not contesting that. Only the thing that we are contesting is the timing of the surgery.
Dr. Manocha, even Dr. Dinshaw did it acutely over a week's time when everything was stable, the Dopplers were done and everything. But again, summing up, it's not to be done by an amateur. He has to be as an expert as Dr. Manocha or Dr. Dhananjay. So, so let the message be very clear. So as we say, the last speaker standing, that is me. So let me present my last talk. I'll rush through that so that nobody sleeps. And I'm really proud that there are 400 plus people still logged in who are listening to our talk. So we are not the only few motley few people, and Dr. Lalit Meni is also awake. Welcome, sir. It gives us
He's looking like the Don.
I say he's always a Don.
He is a source of inspiration. उनके डर की वजह से ही हम बैठे हुए हैं. सर बैठे तो हम कैसे जा सकते हैं? नहीं वो बैठे हुए तो हम कैसे चले जाएं?
Very lovely session going on. I couldn't have left it in between. I have still not had my dinner.
Sir. Sir, your presence really boosts.
जैसे हेडमास्टर जो होता है ना, हेडमास्टर ना कुछ बोलते हैं, ना किसी की तरफ देखते हैं.
पर उनका डर होता है.
डर होता है.
सब कुछ सुनते हैं.
वो खाली टाइम
शुरू से ही होता है.
जो लास्ट बेंच पे बैठ के सुनते रहते हैं.
Let's get on with the presentation now, Samir.
All right, sir. My last presentation is from me. All right, sir. I'm sharing it. Thank you very much for everyone for setting up till so late. Okay, so I would like to, so please, for everyone, any question left, since we are very late, we might have missed some queries. You can WhatsApp me and I'll get you answered from the concerned faculty. So you can note down my number, my name, and you can do that. So my presentation is this. All right, so here I go. So my presentation is an approach to meniscus tears. Okay, it was year 1897, more than a century back, that the meniscus was considered as a remnant structure in the knee joint. But over a period of time, we know that meniscus plays a very important role in many of functions of the knee, like shock absorption, increases contact area, decreases contact stresses. It is needed for lubrication, it is needed for better joint congruency, it is needed for stability, and for, of course, proprioception. We know the procedure, we know how it is injured when the foot is planted and the twisting injury happens with the momentum of the body, and there's a grinding force, a shear force between the femur and the tibia, which tears the meniscus, which is more common in footballers, and in India, we see commonly in our practice in bikers. Before we go forward to learn about the tears and their techniques, we should know that the tears and their repair and their healing is based on the vascularity of the medial and the lateral meniscus. So 30% of the medial meniscus and 10 to 25% of the lateral meniscus are vascularized from the periphery. Tears within 3 mm are red zone, more than 5 mm are white zone, which are avascular, and somewhere in between is a red-white zone where tear happens. So O'Connor described it first. The tear patterns are horizontal cleavage, a longitudinal vertical bucket handle tear, a radial tear which goes on to become a flap tear, which further can go on with more shear to a complex tear, and then there is a degenerative tear. This is a better slide to show the type of tears. Then we have a discoid, which is an embryonic maldevelopment of the meniscus. Then we have root tears and a ramp lesion associated with ACL injuries. Radiology, MRI is the gold standard. It is very sensitive to pick up a tear, but again, it has false positives. So a clinical suspicion has to be a very strong one to be ordered MRI for, and then to be diagnosed as a ACL, as a tear of the meniscus. Grade 3 signals are surely indicative of a complete tear, as seen here in a complex tear of the meniscus. Then there are various signs which a radiologist comments on, and we can also see on MRI, which is a double PCL sign of a displaced bucket handle tear of the medial meniscus. There is a double anterior horn sign when the ACL tears and flips anteriorly to posteriorly. And when it goes into the notch, it is called as double flipped meniscus sign. A trivia on the tears, the knee is more prone for meniscus tear in ACL deficient knee because of instability and a constant movement, unstable movement of the femur on the tibia. Medial meniscus, because of its decreased movements due to attachment by the coronary ligaments on the capsule, is more prone, and that's why the triple unhappy triad of Donoghue is more common in medial meniscus, along with the MCL and the ACL. Acute ACL tears do have lateral meniscus more commonly, and degenerative tears are obviously seen in older patients in the posterior horn. Now, what is the treatment of meniscus tear? Well, treatment depends on the age of the patient. The younger, the better. The durations in injury, that is, earlier the patient comes to you and treated, obviously it has a better results. The activity level of the patient, high end athlete vis-a-vis a sedentary worker, both will have a different outcome. Then the type of tear, whether it's a complex tear, it's a radial tear, and so on, which I'll show in later slides. And most important is the location of the tear as per the vascularity. And then there is, of course, the tissue quality, which matters when you repair such, and depends on the healing. What are the tears which can be left alone? Well, short tears, that is short segmental tears, which are undisplaced, which are stable and not flipping inside the joint, and which are less than 1 centimeter or maybe 5 millimeter, are stable and can be left very much alone. But for these, when you're leaving them alone, and if you see them while doing other procedures, you might do some synovial abrasion, you might do a trephination, and the patient has to be immobilized for a longer time for the best results. Now, literature talks a lot on this, and once a study of 2011 shows that early follow-up of the patients, there was a reoperation rate of partial meniscectomy of 1.4%, and the reoperation rate in meniscus repairs was 16%. At longer follow-up in the same study, more than 10 years follow-up, reoperation rate in partial meniscectomy was 3.9%, which is much lesser than a 20.7% repair in repairs. So it has to be taken into account that the repair has much more reoperation rates and re-tear rates. So another study, a biomechanical consequences of meniscal tear, meniscectomy, and meniscal repair in the knee, as late as 2018, shows that meniscal tears increase contact pressures within the knee when they involve 60% of the width of the meniscus, but a resection of up to 50% of meniscal depth may be an acceptable case when repair is not feasible. So this is the case for excision or balancing or debridement, as we call it. But why do we excise it? So keep it very simple. Why do we excise when repair is the thing? Well, we excise because excision is time tested. We started with excision long back, and we still do. While repair is relatively new age, it is more safe, reproducible in even a young surgeon's amateurish hands. The results are immediate, and patient is ready to go in and play in the field, and it might save the career in vis-a-vis repair, which takes a much longer time. Indications of repair are limited, as I'll show later. It is very cheap, and it just needs just 1 or 2 instruments to do a partial meniscectomy or just balancing, and you're done. So this is the case of partial meniscectomy in a young man who had a flap tear, and this is a meniscus piece taken en masse. But it was Fairbanks way back in 1948 who, in a classical article, described the changes after meniscectomy. The changes were the femoral condylar ridge formation in the follow-up. There was femoral condylar flattening. There was joint space narrowing. In all, it was an arthritic compartment in a meniscectomy case. So literature says a lot about repair now lately, and it talks about that lateral total meniscectomy causes 50% decrease in tibiofemoral contact area, and so there is an increase of local contact stress load up to 335%, which is massive. And a partial meniscectomy of 16 to 34% increases load on articular cartilage by 350%. So this, of course, shows that repair and conservation is obviously better than any kind of meniscectomy. Then it shows that lateral meniscus decreases compartment loads by 70% and medial meniscus by 50%. So which obviously means they need to be saved. Now, meniscus has best results if repaired when the location is red, as shown earlier. If the time is an acute injury, which is up to 8 weeks or maximum 10 weeks, and better results are seen if it is associated with ACL reconstruction. The morphology 1 to 4 centimeter long and with vertical and longer tears are good enough to be repaired. A younger patient of less than 30 years have better results than an older patient. And side of lateral meniscus with a narrow rim width of the injury are better candidates than a medial meniscus, which is which takes off the body weight. The principles of meniscal repair are: reduce the tear well, prepare it well by debridement or abrasion, good approach to the tear. Well, good approach means that when you repair it, you should not be obstructed by the lateral condyle or the medial condyles or the tibial spines, and the approach should be a smooth approach to get a good hold of the meniscal tissue. Perpendicular to the tear stitches are much better to give a good compression. Enhanced healing can be done by fibrin clot method and vascular channels which can be created. And each tear has to be customized for each patient. So there is not a common formula for all kind of tears or all kind of patients. And we have to do associated stabilizing procedures along with the meniscus repair, as shown earlier by Dr. Dinshaw also, like PCL or ACL repair. Now, what are the contraindications of repair? But degenerative tears in older patients, avascular tears in the white zone are not going to heal. Complex tear, they are really complex because they are all around. They are like burst injury of the meniscus. And stable or incomplete tears need not be done. Patients unable to follow strict non-weight bearing protocols for some reasons are not good candidates for tear because they need a proper protocol, rehab protocol of non-weight bearing to be followed later. And then infections and RA and collagen vascular disease are not good candidates to be done with. Now, these are the longitudinal tears which we normally see, which can be RR and RW are repairable. Excised by partial meniscectomy if they are white. If less than 1 centimeter length, well, leave it alone, as told earlier. Now, this is a good figure which can easily divide the meniscus into 3 zones: the anterior, the middle, and the posterior third. The anterior third, the common technique used is outside in technique. In the middle third, the inside out, all in, or even in some cases outside in technique can be used. And in posterior third, all inside technique is commonly used because we have important neurovascular structures posteriorly in nerves and in arteries. So all inside can easily be and safely be done. Well, the techniques, inside out technique is using needles with preloaded sutures, and they are passed on from inside to outside using proper double lumen or single lumen cannulas, and they are done by fixing the superior and the inferior margins of the tears. Preloaded sutures, pre-tied knots, sliding knots, and they are marketed by the companies. Smith & Nephew has Fast Fix, and Arthrex has Cinch, and so on. Commercially available, easily done. Well, medial compartment buccal handle tear, they need to be probed. All of them, mind you, the meniscus without probing are not to be done, or they are difficult to be seen, because you have to probe the underneath structure, the structure which is near the capsule, and you have to probe it all around to actually see the meniscus tear and then go for it. Well, this is a video. I'll skip it. This is going to take much time. The video is how to reduce it. We go from posterior to anterior, and we repair also the posterior and wise, and we go forward anteriorly to repair it. So always probe. Coming to the horizontal cleavage tear, this is found in older patients and in posterior horn of the medial meniscus. it is split into two, the superior and the inferior leaves, as shown here in this figure. The resection of unstable leaflet, whether it's a superior leaflet or an inferior, can be easily done, and still you can preserve the meniscus and in turn preserve the underlying cartilage. Repair for younger patients is done. Commonly, you can use all inside circumferential compression stitch as seen in here by using a self-loading instruments like first pass or Scorpio, commonly used also in shoulder. Radial tears are really sinister kind of tears. Radial tear is kind of a knife cutting through all the peripheral longitudinal fibers of the meniscus, and this is a really bad kind of injury. It is almost akin to a total meniscectomy, and if it's going to the periphery, you can consider repair in young knee, while if it's in white, well, you can easily debride it or balance it. To repair it, you can use horizontal matter sutures as done here in this case. It was a young 20-year-old boy who was playing football and he suffered this injury. Then we can use a Latarjet two-tunnel technique, which is a transosseous technique, and we pass the sutures from both two tunnels made anteriorly and posteriorly, and these are they are passed in a crosswise fashion to make a good, suitable, strong fixation. This is the article, if anybody wants to read. It is AJSM volume 20, and there Latarjet described this very beautifully, two-tunnel transtable repair. So this is the radial tear. Two cannulas have passed, and if the cannula is here where my cursor is, then you pass a suture from this to this cannula and the other one across it, and this gives a very fine kind of fixation transosseous. You double it up by doing horizontal sutures as done earlier here. So you can do this, which gives a very strong fixation, and radial tear, which goes from inside to the periphery, can easily be done by this method. Now, coming to the discoid meniscus, well, we know that discoid is like an O-shaped instead of a D of a more common in lateral meniscus. Well, we do a saucerization, and then we repair the unstable rim with all inside devices as shown earlier. Outside in can also be done because we want it to be stable enough to be healed in that place. In the wrist break variety, we also do the repair. The peripheral has to be repaired. Then there is a entity called meniscal root tears, which can be of type 5. It can be from type 1 to type 5. Now they are of various times, and type 5 is actually an avulsion of the root. Otherwise, it can be accompanied by a buccal handle tear, or it can be a simple partial tear like this shown in figure 1. Now, root tears, the patient has pain on weight bearing and has a joint line tenderness. In complete root tears, they are functionally equivalent to total meniscectomy because they are free lying in the joint, flipping. So it's like a meniscectomy being done with meniscus being ineffective. Lateral tears are associated with ACL tears, commonly seen, and medial root tears are seen along with chondral injuries. Now, this is the common MRI, which sign that you see, a ghost sign, because it is flipped inside and is missing from here. MRI misses in 33% of the cases, so you have a strong clinical acumen has to be there to actually detect it. Now, root tears, what do? If acute, traumatic, a relatively healthy joint in young, repair using transosseous suture pull-out technique is done by you make 1 or 2 tibial tunnels using jig, as done in ACL. In more than 50 years, degenerative changes in malalignment and obese patients, you can do an excision, but which eventually will go to arthroplasty. And untreated root tears will ultimately need a uni knee. So which means that root tears are so important and they are not to be missed. As Dr. Dhananjay has said, you can do when you do a dry scopy or when you do in fresh cases, you do not miss root tears unless, of course, you're waiting for the acute reaction in an acute injury to be settled, but then you miss the root tears. This is a tunnel technique. You make a tunnel using a smaller jig, which is called as a root tear jig, and you make a tunnel, and then you do loop sutures. You do a shuttling loop by a lasso, pull out the sutures and tie it on the button outside on the middle side. And this is how it looks inside when you can make 2 or 3 bites of the meniscus and to fix it back nicely to its base, to the root. Now there is an interest in the ramp lesions. Ramp lesions were first described way back in 1988, but its importance are lately being felt and observed. They are meniscocapsular tears. They are the tears of the medial meniscus of the posterior horn. They are associated with ACL tears, found in up to 31% in primary and 49% in revision ACL tears. 31% is a huge number. Exploration of the posteromedial corner, that's why is a must. Do the repair first before ACL reconstruction. And for that, you'll need a posteromedial portal as being done here in one of our surgeries. And in few cases, you have to do a AL reconstruction, an augmentation procedure, which is an extra articular procedure in a big ramp lesion to give stability. Well, these are the degenerative tears, as seen degenerative chondromalacic femoral surface, as well as tibia in the fibrillation. These are the complex tear may found in the degenerative tears. Now, they are commonly said by a specific study, which is a big study done from all patients from 1975 to 2016. And they say degenerative tears are only to be dealt arthroscopically and excision or balancing to be done if they cause mechanical block or if they cause any kind of inflammation. Now, after repair, we can augment this by many ways to not to have a re-tear later and not to take the patient for a reoperation. Well, healing rate of good repair is from 50 to 80%. It improves after ACLR in concomitant ACL injuries, because this causes release of cytokines by the tunnels that we make in the femoral and the tibial side. Well, by doing bone perforations and vascular access channels are opened, which increase intra-articular bleeding, which bring in many stem cells, causing and helping in healing of the meniscus. Well, mechanically, you can do trephination. Trephination is a procedure by which we take out the core of a meniscus of the periphery, by which we actually aid in the channel, vascular channels to be formed from periphery to inside to the repair. You can do abrasions. Then there is a synovial flap, fibrin clot, and mesenchymal stem cells, which of course can come again by doing awling and causing bleeding inside. PRP is a known procedure which can be done after the repair to aid and to augment for early healing. Scaffolds, which are made of collagen and in segment losses, can also help in the healing of the repairs. This is just a pictorial depiction of the fibrin clot. The fibrin clot, generally, you take out around 50 cc of patient's blood on a table, side table, you make it clot, and then you can put it inside on the underneath of the repair and not over it, so that it doesn't gets washed away. There are ways to suture it, but many surgeons don't suture it and just place it there and then make the knee immobile by putting braces for at least 6 to 8 weeks. PRP is a known procedure, as said. We avoid the repairs in degenerative tears, chronic complex tears because of poor healing, unstable knee, which are pending reconstructions, so they're high tear rates, so don't do an unstable knee, or you stabilize it by doing associated ACLR or PCLR and so on. Associated grade 4 corneal defects are not a good case to be dealt with meniscus repairs. Well, there are many. Now, what do you do for avascular zones? The vascular zones, the red area are going to heal, but what do you do? Well, you do synovial tissue flaps, trephination. you do creation of peripheral channels, and then a lot of tissue engineering is happening, which we're going to see in the future with all these procedures like embryonic stem cells, MSCs, and adult stem cells, and so on. Well, same which I talked about recently. What is the future in meniscus tears? Well, there is a polyurethane carbonate implant being manufactured and being tested right now, which we might use in the future in irreparable or in meniscectomy cases. Transplant, I really don't know in what centers in India it is being done, but indications are acceptable in less than 50. And when there is a pain in TF joint, tibiofemoral joint, and with cartilage loss, and so many contraindications are there along with it. So this is not a routine procedure to be done. And mind you that it is not to be done as a prophylactic transplant because of so many side effects which allogenic tissue can have. So which means that anybody undergoing a total meniscectomy may not be a candidate for a meniscal transplant unless some indications are met. In a nutshell, I'll wind up my talk. What meniscus treatment is ideal may not be feasible in practice. Every tear needs proper customization. In athletes and young knees, rules of ideal repair of red zone or for the time phase injury may be extended. From 8 weeks, you can go up to 3 months if the tissue is good enough. And in lateral meniscus, which is non-weight bearing, you can even up to go to WW or RW zone in athletes because you want to save them for their long life as an athlete. Whereas preserving the meniscus is desirable, but as described earlier by me in my talk, well, you have to be very diligent in case selection. Cost is much. Expertise has to be good, and there are chances of re-tears and reoperations which have to be kept in mind. Balanced excision, though seems excessive, may be the only treatment in many of the cases like flaps, oblique tears, and so on, and especially in white zone. But treat meniscus tears with kindness for a very, very healthy knee. Well, before I say thank you, well, this was the last. I want to thank all the DOA committee members, the secretary, the president. Last year, we had a very wonderful cadaveric workshop. And this time, we were given an opportunity to hold this webinar. So I thank all the office bearers of DOA for giving us this opportunity, especially Dr. Hitesh Lal and Dr. Sharad Agarwal and team, Dr. Harmesh Kapoor and everybody. Thank you very much, friends. Thank you. All right.
Dr. Samir.
Okay. Sir.
Can I ask something?
Please.
A very philosophical question to Dr. Monu Singh, Dr. Manocha, and you, basically. Don't you think it's an oversold procedure? Like lower end radius, a time came when they said even 1 millimeter is very, very, very major crime. You should fix it. Even a 1 millimeter can lead to arthritis of the wrist, and then it boils down after 5-7 years. It's a pass. Similarly, I think meniscal repairs are oversold. The implants are so costly. The patient has to be non-weight bearing. 50% you are saying is a success rate. And God knows how many years after a meniscectomy or partial meniscectomy will the arthritis arrive. And those long-term complication of any procedure is obviously a very difficult to scientifically prove. These are all hypotheses in a way. Like we say कि arthritis को treat करना है तो जी contracting खा लो तो arthritis नहीं होगा. वो arthritis तो होना ही है. 10 साल बाद होगा, 12 साल बाद होगा. ये theoretical है कि जी नहीं आप नहीं खाओगे तो 5 साल में आपका नहीं खराब हो जाएगा. खा लोगे तो शायद 8 साल चले जाएंगे. So it's all शायद. There's nothing like you can prove these things. So what I feel is you spend lakhs of rupees doing it, and then it's a challenging procedure, and in the end it fails. So it's like more of a service to the company than to the patient, I feel. So it's open to all the panelists. Yeah.
So let me.
Dr. Samir, you're not audible.
More experienced than me. Sir, if you can recall, am I okay now?
Yeah, now, yeah,
Dr.
now,
Ramesh?
yeah. Now
Sir, if you can recall my talk, way back in 1948, it was well described by Fairbank, and this study is quoted by many surgeons, arthroscopic surgeons, in their talks, that they were visible and there were documentary changes by doing radiographic changes by way of different osteophytes and so on, and cartilage degeneration and so on, way back in 1948. Now there are hundreds of studies which have proven that meniscectomy, that meniscus, said otherwise it will be a vestigial structure if it doesn't do anything. So, and we know very well that meniscus has a very important
No,
role
I'm not
in
saying
it.
it's a vestigial organ. I'm saying
Sir,
conservative,
Sir, got
conservative
it.
partial meniscectomy, a
Sir,
simple
got it.
procedure versus
Sir, they are,
repair. Yeah.
Sir, I got it. Sir, but there are so many type of tears which are almost akin to meniscectomy if you don't do anything in it. So you have to remove a subtotal. You have to do a subtotal in them to actually deal with it if you are not doing a repair. Now, repair has come in a big way. There are, and your cost factor, the cost factor, not necessary. You can use just 2 needles. I've done many by using simple spinal 18 gauge needle. Use a PDF which is freely available in the OT, and use a Ethibond or any, even with PDF you can do it. So you don't need cost. So as far as commercial angle is done, we are safe with that. So having said that, now other procedures, like you say, the costly implant, they are for your use, for your benefit. You may not use it, like Dr. Basim doesn't use it. You know, a costly implant has cost as 1 lakh rupees. He doesn't use it, but giving results. So it is time tested and should be done in younger patients. So over to Dr. Manocha and Dr. Monu Singh for further comments.
Sir, okay. Dr. Ramesh, your question is very right. See, I don't have any problems with the cost because everything is on the house. Everything is provided by
It's more of a philosophical. It's not about individual person here.
No. I'm coming to your point. So still, let me tell you that if I get 100 cases of tear, I am able to repair in no more than 12 to 15. The reason is that even if the tear looks repairable, it may not be reducible. If it is reducible, it is not possible to hold it well there. So actually speaking, you saying that it is being an oversold procedure, yes, you are right. Possibly if I judge completely independently and unbiased way and not concerned about putting my implant, possibly I'll not repair more than 10 out of 100 tears.
That's what I wanted to say.
Second thing.
A lot of people are doing it.
I have not completed my answer.
Complex old tears they are repairing.
No, I have not completed my answers. Yeah. Not complete. But there are two tears in which I make all my effort. I go all out to repair, and in those cases, the cost is also not much of an issue. One of them is what he said is root tear. The root tear is like a complete meniscectomy. Even if the whole tear is present, if the root tear is gone, the whole hoop stresses protection is gone. The cartilage is a stress like anything, and in that cases, osteoarthritis is clear risk and it should be prevented. And in those cases, let me tell you, you need to make only 2 small tunnels and 2 simple threads, and you can tie it out even on a bone bridge, and you don't need implant. The second kind of the tear is a meniscocapsular separation. They always heal, right? Mehta make a very good important point that the reoperation rate is very high. So the reoperation rate in meniscocapsular separation is not very high. In my hands, they are almost nearly always successful. They always heal. And they heal even if your repair has not been very perfect and the position is not very close.
I agree. So the point is 10% only.
And then we discuss it. Yeah. In these cases, what you need is not the large and fancy implants. You just need a lasso in which you can pass from the capsule, you can pass from the suture, and then you can tie simple knots with simple threads. Now your questions.
That is what the point I wanted to, you to come across was that only 10% of the tears actually can be done justice with a repair. Yeah. That is a fact which we don't usually fail to accept.
Dr. Harmesh, selection is a must.
Meniscus, Dr. Harmesh,
yes.
meniscus is not to be sacrificed. It is not something that we are not surgeons. We are orthopedic surgeons. We are not going to take something out and throw it away. Meniscus is to be preserved. Wherever possible, it has to be preserved, recorded. We all understand.
Sequestrum has to be thrown out. You can't say it's a body piece. So let me keep it. So if the meniscus is slightly small tear, you can do a partial meniscectomy. Why so emotional about it? Yeah.
Sir, in a young patient, a footballer with a bucket handle tear, would you want to do a meniscectomy and throw it out?
Bucket handle tear is fine, but a lot of these horizontal and lateral tears also people do.
Everything has an indication. You choose your patient well, and you choose your patient well. And it's only with the increasing expertise that you are able to deliver the results. And implants are not there for us to use. They are here for us to help us choose in a judicial way where we can use them and where we can give results. It is nothing. There is no question of implant being expensive or cheap. You cannot.
We are educated, intelligent people, so we can always use and misuse everything depending on us.
Yes.
It is not an oversold procedure. It is a procedure.
Ramesh, you said it. It's on you.
It's for all of us. I mean, we are all discussing. We are all arthroscopic surgeons. I'm telling you a fact that a lot of things are being oversold, and then they go away.
Meniscectomy is the easy way out.
Yeah.
When nothing is going your way. When nothing is going your way, you have to deliver. What you do is you do a meniscectomy and you come out.
Okay, one more question.
It does happen.
Okay, one more small question. 2-month-old complex tear of the meniscus. Should it be repaired or should it not?
No, I cannot repair that. But I have seen Dr. Dinshaw repair it many times.
No,
I've seen you repair it many times.
That was the point I was making. That at 2 months, even if the meniscus had it come to me within 1 week or 2 weeks, I would have repaired and quite successfully repaired. 2 months, more often I failed to bring it back to the place where I can put the sutures. That is because there actually happens a contraction of its length. So a displaced tear, a bucket handle tear, which has been sitting in the notch, has been kept at that shorter distance for 2 months. Now it is contracted. With just close method, by pushing, you cannot reduce it to the place. And if you place even the sutures across, which you can still place, its apposition is so poor that it will not heal.
It will not heal.
So I'm saying that it's not only the point that the tear could have been repaired. The success of the repair has also to be always kept in mind.
Yes.
Samir, can I ask one question?
Please, Dr. Bageja.
I think case selection is very important, Dr. Monu. What Dr. Monu is stressing. Ramesh, case selection is very important, and young patient and the type of the tear, I believe, that's very important. What do you say, Samir? Age of the patient and type of the tear. Yeah.
That's why my slide showed that you have to be very diligent, especially in repairs. You have to be diligent, and Dr. Harmesh, like Dr. Manocha and Dr. Monu said, expertise is important. Because unless you've done, you know what you're doing, there's no point in doing it. So I think the message should be that we have to preserve. There's no doubt about across the.
Samir, my question was your main selection was age and the type of the tear. Am I right or wrong?
Age, tear, the vascularity you have to see, the time since, because like Dr. Manocha said, it goes the displaced meniscus like bucket handle, they go plastic deformation. And that's why Dr. Manocha says it won't come back and it won't sit the way it used to.
So what is the latest, like 3 weeks old or 4 weeks old?
It is 8 weeks. It is 8 weeks.
If it comes back, then he's going to repair it.
Yes, it comes back. Yes, it comes back. You should fix it there and repair it. It's not a vestigial structure. So safe it preservation is the key.
Some junction of time, Dr. Monu, like 3 weeks old or 4 weeks old.
8 weeks. 8 weeks is the time which is stretchable for athletes or young people like 20 to up to 3 months or even 6 months. If rest of the criteria, they fall in place.
Okay.
Yeah.
Thank you.
So I think with this, Dr. Manocha will have the last word.
The final one.
Final word.
There are 3 points which I always look for repair. One is, the first point is reducibility. Its apposition has to be good. Number 2, it has to be in the area where it can be repaired. That is red on red, red on white, or a meniscocapsular separation. The third thing is the longitudinal tears are the best in my hands. My attempts at repairing the radial tears or complex tears has not been successful. I have always failed. I always rude, even in the young patient, why I did it. I should have done the partial meniscectomy to first go. And I don't repair the horizontal tears. In my opinion, they usually do not require any repair. That's what is my take on it.
So I think with this nice thought and nice presentation, I would, before I hand over to Dr. Manish Dhawan, who is still awake, and Dr. Ravi Chauhan, who is rubbing his eyes, poor guys. We are indebted. We are indebted from the bottommost of our heart, sir. आप हमारे साथ हो अभी तक और आपकी वजह से हम यहाँ बैठे हैं अभी तक डिस्कस कर पा रहे हैं. So with this thought, let me thank all the faculty, all the delegates who are still up and listening to our talks. I hope you've gained a lot from today's marathon webinar of arthroscopy conducted by Delhi Orthopedic Association. The panelists, Dr. Monu Singh, Dr. R.K. Manocha, thank you very much. I think I can't thank the rest of the faculty. They're already gone and slept away. But Dr. Lalit Meni is awake. So our President-elect, Dr. Lalit Meni, thank you, sir. Dr. Harmesh, you are always, your presence always jaan dal deta hai ek webinar mein. Or Dr. Bhageja again, is always there backing us up. And Dr. Shamshul, you are really a darling for making it so successful. Ravi, yaar, maza aa gaya. So nice of you. And I will hand over to let Dr. Lalit Meni say a comment and give parting words as the president-elect, because the president, Dr. Sharad Agarwal, I can't see him. I think the poor Dr. Agarwal has gone sleep.
But I must compliment Dr. Samir for making it so interesting that 11:30 people are there. So I must compliment you on that.
Sir, हम orthopedic surgeons हैं, कुछ solid material के बने हैं. Thanks, Dr. Manish. Thank you very much, sir. Dr. Sir, आपकी आवाज नहीं आ रही. Dr. Manish Dhawan, आपकी आवाज नहीं आ रही.
Is it coming now?
Yes, very much. Yes.
Yeah, actually, the final comments to come with Professor Lalit Mani and that Dr. Harmesh Kapoor.
Yes, absolutely.
Because people are complaining now.
Oh,
too much today.
So we are successful. We are successful, and जैसा आपने कहा था, prediction ठीक रही. आपने 11 बजे बोला था. I think 11:30 से ऊपर हो गए हैं.
Yeah, we are closing to midnight now. I think we should wrap it up.
We have created history today. हम 11:30 बजे तक कर रहे हैं. This is history.
Okay,
Dr. Meni sir.
Dr. Lalit sir. Yeah.
Okay, thanks a lot. Big thanks to all the faculty, all the delegates who have attended this amazing sporting session. This was actually a sporting Sunday. We had a double header and Mumbai won today. We have Rafa Nadal winning the French Open 13th time and 20th Grand Slam. And we have Samir and his team hitting sixes from 6 o'clock till 12 o'clock. Thanks a lot, and I think we congratulate all of you.
Dr. Harmesh.
Yeah, I really thank from the bottom of my heart Dr. Manish Dhawan, Dr. Ravi Chauhan, and Dr. Shamshul. I mean, to be awake whole day, every day is a very, very, very tough job. I must confess.
Impossible job. Impossible.
Yeah, it is their stamina. I really appreciate their stamina and commitment and dedication. And obviously, Dr. Lalit Mani to be our inspiration always, and to be around for so late. And Dr. Manocha and Dr. Monu to be our expert panelists.
Always,
really always a fun to interact with you all.
For our expert panel.
Dr. Mishra, Dr. Bageja, Dr. Basin. Thank you very much.
Dr. Mishra is with us now. Good morning, sir.
He is very much there. And all the delegates and the sponsors, thank you so much, and good night. Stay safe. Thank you.
Good night.
Good night. Thank you very much. Thank you, sir. Thank you. Thank you, Ravi. Thank you, Shamshul.
Thank you, sir.